bad without checking. If I suddenly do this, problem. Correct? No. So to prevent that. Next thing, if you are doing with the BNG system, then you have access to do something called as an upright head positions test, which is from this position with the goggle, make the person go down like this. I will show you with left. Each position 30 seconds you have to make. I am doing it fast now, but each position you have to maintain 30 seconds. This is called upright head positions test. Is that okay? Right. We included this upright head positions test in my VNG protocol when my first VNG was made 9 years ago. Some 4. That is the first test. Next test that we are supposed to learn is something called McClure-Pegnini test. What is it?
McClure-Pegnini.
Okay. Name is very difficult, no? But test is very easy. Okay, I will tell you. Take off your shoes. Remove. Very good. Okay. Now you do one thing. Put your legs here. Okay. In the in the hospital, this should not be there. Okay, this should not be there. So in the upright head positions, and preferably, I mean, in this McClure-Pegnini or supine-roll test, it's a modified supine-roll or McClure-Pegnini test. In this, what you do is, the first step is, you make the person, okay, with a pillow, roll to the legs. Is that okay? 30 seconds. Then look for mistakes in the eyes. Okay. Next is again come back to supine. Again wait for 30 seconds. Is that okay? Next turn to left side. Wait 30 seconds. And then come back to supine. Okay? That's all. This is the McClure-Pegnini test or supine test. Here interpretation. How to do you learn first. Interpretation I will teach later. Okay? Because interpretation on YouTube is there, so much is there. Next time we can do. But the practical things is what happens only here. Correct? No? This is the supine rotation. Come back. No, come back. Okay. So in this position, turn the head 45 degrees towards it. Just 45 degrees towards it. Make the person, okay, keep one hand on the back, give support and take them down. And go 30 degrees down. Is that okay? Preferably use a chair. Otherwise you will break your back. Again. Wait for minimum one. If the nystagmus comes, it's okay. You got the diagnosis. That's it. After that, you can make the breakdown. If you don't get the nystagmus, if the person is telling I am having positional symptoms, what are the things? Patient has come and told, on changing my position, I am getting spilling sensation. But you don't get nystagmus. Then what you are supposed to do? Wait for 60 seconds, because some people are late movers of the debris. After 60 seconds also it doesn't come. Make the person get up and what you are supposed to do? Don't say you don't have BPPV. 3 repetitions. But before that it may be the other side. So finish the other side. This one, then go down like this and again check. Maybe it is here. Again wait for 60 seconds. If you don't get it, you get no problem. Then get up. If the person comes with history of BPPV, but this test turns out to be negative, before telling the person does not have BPPV, you have to do 3 times this test. How many times?
3 times.
3 times this test has to be done. Is that fine? 3 times. After 3 times, you are telling no, the person has. You can write, I do a 3 steps, 3 repetitions protocol for diagnostic testing. Which means, after 3 repetitions, if I don't get, you can be sure. Why? Once a professional who starts then you not
Thank you so much for coming and encouraging our audience. And I also welcome our guest of honor, Krishna sir. Thank you so much for coming.
it's high time we should go into depths of vertigo, learn properly about movement corner, like how to assess it, how to treat it, how to evaluate. So Srinivas Varsara sir is the best person from whom we can learn this knowledge from and start implementing in our day-to-day practice. So once again, welcome you all.
Thank you so much, sir. Thank you so much for sir. Go deep dive into it.
It's good. The last time that I was here was when you were just breaking out of COVID. Okay. And this time is when you are about to start, when your capital is going to be reborn. So I'm a good times. Okay. So that's a good thing. And it's good to see so many people who have joined here. So you have taken a good step to come here. We will ensure that you will feel that the next 2 days was worth it. And thank you, madam, for the initiative, and thank you, madam, for the continued effort. Okay. You have you.
Respected Murthy sir, Dr. Srinivas Varsara sir, and as well as Dr. V.V.K. Samit sir. Firstly, I would like to say big thank you to our GM Dr. Sudhakar sir for giving us this opportunity to arrange such a beautiful workshop in this place. Actually, I have seen Srinivas sir's online classes. I have actually listened to many of them, and unfortunately I couldn't attend the offline classes last year. So he is an excellent speaker, and it's really a good opportunity for all of you to imbibe much knowledge. And it's a great opportunity. Please all of you make utmost use of this.
Thank you so much, sir.
Srinivas and President. I've been associated with ISHA. Your main organization, ISHA, and Rakat is a good friend of mine. And Rajshekhar is a very close friend of mine. I have attended ISHA conferences somewhere in 1988, 89, 90. So those. I am glad that you have taken up a half a part of it, because even our own ENT judges do not know the importance of vestibular assistance. Actually, this should have been a combined workshop. Both for the ENT surgeons and the audiologists, then probably somewhere we would have broken a ground. And then say, okay, these are the patients who require that. You people, you do not know what exactly I want. So what investigations I want and what info I want. So there is a gap between the audiologists and the ENT surgeons. Lot of gap. Where we are all unhappy because I am one of the people who are really unhappy because we lost the subject of audiology and speech therapy from ENT curriculum, because we don't have it in our ENT curriculum now. Totally it's come out of ENT curriculum. So we are really losing part of our subject too. But we are creating as another specialist. We are creating as another specialist. So that's the place we need it. Because I have given the syllabus, curriculum, everything I prepared and gave it to the university. But unfortunately, we were not able to start the course in the university. That was the first course out of all the paramedical courses. The entire syllabus was given to them. Because I brought the syllabus from SRNC, Manipal, everywhere I brought the syllabus, prepared the syllabus and gave it to them. So that is one. It will always be tricky because we need to create an opportunity for our own people to come up rather than depending from somewhere else. Because right now both the combined state of Andhra Pradesh, I think only Telangana has got 2 schools.
Yes.
They have 2 schools, including So we need to have more schools so that more and more people get trained in this particular And please also, not only the audiology, you are not getting to exposed to the entire workshop, hands-on workshop and stuff. With him and Pradeep from Vizag. These are the two people we had in mind, and we said, thought we'll have it this, we are going to have this sometime in the month. Then these conferences are not there. So, we also need to, as you think you people need to be sensitized about it, we also feel that our youngsters and junior consultants should be sensitized for the management of our time. All the best. Learn as much as you can in the next 2 days. And I sincerely thank Srinivas for coming all the way from Bangalore and keeping the time for us. And all the best. Thank you.
Of medical counselor.
No, both are not there. Now I got a separate allied health sciences council.
Yeah, so.
I can help that.
Yeah, please. If you
I can take care of that because Rajshekar is one of the members of the council.
Great. Thank you so much for that. That if you can join hands together, yes. Not one college, we can have multiple colleges, like all the dental colleges are multiple colleges, nursing colleges, paramedical can go multiple colleges, and then we can grow much further. Thank you so much for those words. And today, there's a small sad news. Our renowned Ramoji Rao, Mr. Ramoji Rao, who is well known for his development of infrastructure in Hyderabad. His demise has put us a little downhearted. So we would like to have a 2-minute silence in his. Thank you, sir. Thank you for your presence and the value. Thank you so much, sir, for all the doctors for coming in. Inspiring.
Bachelor's or master's, but let's talk about functional anatomy and how it actually works for diagnostics, interpretation, as well as, let's say, treatment. So, and we want to talk about a bit of interactions with other sensory systems in that regard. So these are the few things. I'm not sure if you can actually see this text there. So the first topic that I'm going to talk about is a bit of a basic anatomy, introduce you or refresh our minds, and then we're going to talk about vestibular nuclei, a little bit about vestibular reflexes, and then colic reflexes, then cerebellar, spinal, cortical, and then somatosensory, and a little bit of circular aspect. So, basic anatomy of vestibular system. This we know, right? So we are the experts in this, and we know inner ear has both. So twin sister has cochlear and vestibular apparatus. In vestibular apparatus, again I'm not really going to delve into the basics. We have fluids, perilymph and endolymph, and we have the same fluids that continues into the cochlea as well. So again, when it comes to the anatomy and physiology, I'm not going to be your vestibular professor now. I'm a speaker at a workshop for you to understand. So in my way of teaching, I'm going to ask you a lot of questions. So if you want to stop me asking questions, I want the questions from your end. So first question. Now as we talk about anatomy and physiology, think about diagnostics, because that's how it works with vestibular system. But what if one of this fluid can go wrong? Is it possible? Yes, right? What could that result in if you know any basics? We have this in cochlea, right? The endolymph can be increased, right? That can actually induce pressure into the vestibular system. So there you go, you have your first disorder, right? So, and now you have to think about the consequences. What are the signs that you're going to get? So that will be discussed right after the session. So I'm not really going into it. So endolymph is one of the fluid, and it can go wrong as well. So keep paying attention on it. And then vestibular apparatus. So we have 5 different sensors. Right now, whenever I'm moving, I'm turning my head from left to right, I'm paying attention all of you and see whether you're sleeping or probably let's say paying attention on my topic. So what are we doing? So just to explain you, let me become your joker or guinea pig. So right now I have my fancy, because you can see my vestibular system. I have the fancy way of showing you my vestibular system, right? So this is my vestibular system. How many sensors do I have on the left side and right side? Because I'm moving. Similar like your phones, when you turn on the auto rotation, it rotates. How does it work? Does it have magic?
Sense.
No, right? It has sensors, gyroscope, and all of this, right? The same way, the same and more complicated and more advanced sensors are built into living beings. And humans is not that great compared to cats and other stuff, but obviously we're going to treat humans, so let's pay attention on this. So we have each here, so let's pay attention on one of these. We have 5 different sensors, and they are categorized into semicircular canals. Obviously, we have superior, posterior, and the lateral one. And then the 2 more sensors are otolith organs, also referred as macule, ventricle, and the sac. How does it work? So these 3 are categorized for different reasons, right? So you have to pay a lot of attention. So right now you have semicircular canals, and anytime that I'm actually moving my head left and right, do you think one of the sensors is active? Yes, one of these sensors is definitely active. So we'll discuss that in a very short period. So let's pay attention on what happens and what's the responsibilities of the semicircular canals. When the semicircular canals are activated, it's going to detect all angular motions, right? So let's say if I'm actually turning my head left and right, my lateral canals are actually detecting that motions. I'm actually rotating my head, like enjoying my music. That's angular rotations, right? It's being detected on my anteriors as well as posterior canals, as well as the laterals as well. All 3 canals are being activated. In fact, there's a passive activation of ventricle and saccule as well. Let's keep that aside. So now, think about the functional disability. So I can only stay like this and talk to you without falling up, without feeling imbalanced or even dizzy or even spinning sensation, is because of these 6 different canals. And obviously the other 2 as well and other stuff, but these are the primary sensors that is detecting my head motion, right? So let's pay attention on it. The lateral canals detect left and right. So when this is happening, functionally, so it's like a pull and push mechanism. Basically think like these 2 are elastics. You have elastic band. They're actually pulling each other on each side. So when I actually turn to the left side, it actually increases that there is movement. On this side, reduces. In other ways, when I'm turning actually to the left, my senses on the left side is actually going high, while the senses on the left side is going down. That's how the vestibular nerve transmits the signal to vestibular nuclei. Right? And then turning to the right side, the signal goes high on the right side, goes low on the left side. Right? So now think about the disability. What happens if one of the canals is gone? Or probably the nerve that's actually conducting. Let's say, give you a scenario. Now you're going to answer the question. So completely normal, right? So now let's say my right lateral canal is gone. What's going to happen if I just stay like this? You have your first patient. I'm your patient with you saying that, oh, I have dizziness. It's not a surprise to tell you that patients always don't give you the right terminology. We also need to be aware of the terminology, and that's the beauty of case history. And thank you to have that. So I'm going to continue this in the next session as well on the beauty of case history, or on the art of case history. So yes, so let's say I'm here and say that I'm feeling dizzy. What am I going to do? Just think about anatomy and physiology, obviously science. You need science, right? We're probably going to delve more into and probably ask like, what exactly do you mean dizziness? Is it like more of a spinning sensation? And when does it occur? Whether it occurs only when you turn head to the right or left, right? So as we're talking about the lateral canals, which we discussed that is going to detect all head left and right lateral movements. So the first thing that you should come to your mind is ask more details. So ask them and then see whether if they feel dizzy more turning head to the left or right. So that's one of the, if that's the complaint from the patient, then you have to think about lateral canals. Obviously there's more, as we discuss more about more anatomical structures and functions, you get to know more about these things. Then posterior. So we have two posteriors. And their responsibility is to detect angular motion obviously, but more of posterior bends. So it's not exactly like, if you're going to bend like this, it's going to actually detect both on both sides, but not precisely. So all of you probably are aware of the epineus, right? So the most commonly diagnosed and misdiagnosed treatment is BPPV. So I've seen I cannot say N, but numerous patients being diagnosed as BPPVs. And if you go and look into like YouTube, vertigo treatment, 10 minutes treatment and you're going to get relief. That's epineus. And without knowing which side, which canal we've been treating it, and that can actually put into risk, right? So without knowing the proper canal. So let's look into this. So when the posterior canal is being activated, it detects the motion. Let's say if it's on the right side, it has to bend down and then it goes back. So right now this canal is actually being detected. So this is more enlarged version. We have lateral canal, and then anterior canal, and then posterior, right? So this is how it looks like. Inclined by 30 degrees. It's not exactly parallel or perpendicular to the ground. It's actually 45 degrees deviated. For that particular reason, when you actually bend back, you see that it's not really like this. So that's the reason why whenever you go for testing, it has to be tilted 45 degrees left if you're going to test on the left side for BPPV or any other cases. Okay. So that's how the posterior canal works, and it detects the posterior movements, but on both sides. And anterior canal detects the angular motions towards forward, right? So if I'm going to test my right side, I have to turn to the left and then bend forward, so that you're actually turning on the left side, it's this way, and then go forward, so that actually being detected on this side. Okay, so this is angular motions, and you can see the cow dancing, all angular motions. And what about the utricular mapping? So right now, it's just walking. It's a linear motion. So right now, I'm walking towards you. Do you think like my vestibular system is active right now?
Yes,
Not probably like angulars, but it is activated because the utricle is actually detecting the translation movement, right? So the same way. And what if I'm actually stepping down? Going up. Sacule, right? So if anyone have any issues with, let's say, going up or down, a rocking sensation, or even have issues with, let's say, going in an elevator, probably there are other issues as well, but that's utricle and sacule. It detects the translation of linear movements. Okay, so that's the difference. Why human have better vestibular system, better sensors compared to the phone? Because we have multiple sensors and probably even more complicated. We yet to understand vestibular system completely, so we're still not completely experts. So, but that's just vestibular system. Yes,
There's one thing, if you can explain. See, as of now, it's census and science.
Yes.
But most of the time when they ask the questions, they're feeling nauseated or vomiting sensation. Is there any particular reason to these sciences, sodium, potassium, angular movements, area motions, to nausea or vomiting sensation from the stomach?
That's a great question. Yes, it has a direct connection to it, but not exactly to the abnormality within the organs. But it has connections to the somatosensory limbic system. So I'm going to talk about those things, and that's how it actually works. And that's the beauty of vestibular system as well. I'll definitely get back to you by the end of this session. That's a very good question. I'm going to follow up on that. So vestibular system is shorter term. So whenever I call I'm a vestibular specialist, I probably am only referring to this portion. But human balance is more complicated, and that's where the question comes. The question is sensory system, right? I'm only talking about sensors. And patients do complain that I have vertigo, but sometimes I have like nausea, sometimes I even throw, right? So how does it connect it? Is it something related to the fluid, salts, or probably is it more? The answer is more. The proper term that I would prefer to call it as balance, vestibular and balance specialist. Because vestibular system is very advanced and it has to integrate, and it does integrate with other systems. For example, right now I'm actually talking to you, right? And as I'm talking to you, I'm probably moving from one side to the other end. Probably can hear me. I'm going to use my audiologist voice right now. I'm talking to you, right? Turning my head left, right, and then moving around and even stepping down. If it's only vestibular system, I don't think you're going to stand. You're just going to fall. It is working with other senses as well. It's a teamwork. The brain is not here for the vestibular system. The brain is in pons. It's a vestibular nuclei. That's the nuclei that's going to control all of these things, and it collects all the information and integrates and work as a team. So coming back to the canals are actually aligned in two different manners, one orthogonal as well as the parallel. The orthogonal, as we can see here on, let me bring my pen, as we see here, right here, the canals are arranged in a way that it actually forms a three-dimensional, and that's the reason why any motions, not just left, right, are only in particular direction. You move your head in any direction because it's formulating the 3D dimensional shape, it can detect all of those motions. But the key to remember is that in each of these motions, at least one canal takes lead. Let's say if I'm actually turning my head to the left side, it's taking lead, the lateral canal is taking lead. At the same time, these two are also minimally activated. Remember that the canal is actually inclined by 30 degrees, so it's not exactly lateral canal. It has some inputs from posterior and anterior as well. And that's another point to remember whenever you deal with the patients. Sometimes the BPPV patient, it's a lateral canal BPPV or posterior canal BPPV, the textbook signs might not actually exist as you learn. There are always changes. It also depends on how accurately you're testing and how accurately you're taking the case history. That plays a critical role. Okay? And parallel planes. The parallel planes are just right and left. My left is working with the right side. So when I turn my head to the left side senses are increased while the right side is actually going down. That's one pair, right? And the right anterior and left posterior, they're also working together. In a way, if I'm going to turn or bend my head posteriorly, anteriorly to the left, this is being activated while the posterior one is being actually inactivated. Again, it's like a push-pull and an elastic band. If one is being pushed, the other one is being released a little bit, right? So now, coming back to the same case history question. The patient tells you that, you know what, I completely feel fine, but have issues while bending down, trying to pick something. What should you think? There's more to it. For now, let's say the patient is feeling dizzy, spinning sensation, not dizzy. So now we have to think about anatomy, right, and functional. So what exactly am I dealing with? So these things actually comes into it. You have to think about these connections. Put these pieces together, and you cut more pieces and pieces and put them together. Okay, so anterior, posterior work together, and they are another elastic. So these are parallels. Same thing for the left anterior and right posterior. So one is being activated, the other one is being deactivated. If one goes wrong, there you go, you have a vestibular patient. Right? So that's how it works. So again, I'm not really going to talk about the sensory epithelium and all, but this is the sensor that's actually located within the vestibular system. called as ampulla. It's located in ampulla. So it has both apiculum and basal, and these are the hair cells that we have here, similar to hair cells that exist in cochlea. So these hair cells are differently arranged, not exactly like outer hair cells. In outer hair cells and inner hair cells, we have stereocilia at the one end and then cilia on the other end, right? But it's located different way for different reasons. We probably might need to get into more details to know about that. So the macula, the big brother of BPPV. So in macula, we have a different way of arrangement. So apart from these cells, you also have calcium crystals. So you have otoconia right here, and so it's located on both utricle and saccule. I'm trying to find a better image. So we all know about BPP, right? That's one of the most commonly misdiagnosed as well as mistreated, at least based on my experience, especially many small clinics. But anyway, coming back. So when we talk about BPPV, the first thing that comes to your mind or probably many patients' mind is stones, crystals, right? These are the crystals. And how does it actually work? So BPPV is not just posterior canal BPPV. That's not just BPPV. There can be 6 varieties of BPPVs. Without knowing precise BPPV, you can make your patient's symptoms worse. For that particular reason, again, you have to think about anatomy and physiology. So again, using my crown, let's say, if I have a posterior canal BPPV, which posterior canal am I dealing with? Epimenus can only be implemented for posterior canal BPPV. And if it's exactly in posterior canal BPPV, sometimes depending on how long the patient is suffering with BPPV, it can be multi-canal complex. So it cannot be a textbook version. So when you see these kind of recordings, the first thing that you have to look into is the physiology. So what exactly the responses that you're seeing? You're not going to see upbeating torsion on the left side. It might have different ways. So you have to look into the case history and then anatomy. Okay. So the crystals. So the crystals are actually located in here, right? Utricle and saccule. It will be displaced into this particular canal. This is the posterior canal, as you can see here. And it will only be diagnosed, if we get some light on this, can only be diagnosed when you achieve the proper position. So you can see here, I don't know whether it's visible, it's a red crystals, it's actually moving very slowly. That's how the BPP will be detected. So a patient have a misplaced otoconia. Its job is to stick on the gelatin structure on the utricle, but sometimes it's just misplaced for various reasons, right? So when it is displaced, anytime the patient actually reaches in particular position of posterior canal. Let's say if I have a posterior canal BPPV on left side, I won't detect enough senses. I don't feel nauseous, I don't feel spinning, I actually turn slowly onto the left side. They don't notice it significantly. But when they try to reach down or probably bend back a little bit, especially turn towards the left side, boom, they're going to feel completely spinning, and that's when the nauseous are probably some people actually do throw up. So this results in BPPV because the crystals is particularly displaced in posterior canal, and now you achieve that position. So take the points precisely. Unlike audiological case history, probably 5 minutes. How much time do we spend with audiological case history? Now we understand how important to actually gather information, right? So me personally and my team and most of the vestibular specialists spend at least 20 and sometimes it can go to 40 minutes pre-testing, and then post-testing we might have another call actually. I'll explain how it actually works. And the case history itself can give you more than 60% of diagnosis. We're going to have a demonstration today, but it will help you a lot. Case history and better understanding of anatomy and physiology will give you better test results as well as obviously the treatment. Anyway, so that's the utricle and saccule, the crystals. And then obviously when these sensors are being detected, angular motions are moving left, right, or up and down, these sensors are being activated. and obviously it has to be transmitted into the vestibular nuclei through the nerves. So we have two different nerves, one the superior branch that carries information from the anterior canal, lateral canal, and utricle. So we have inferior branch that actually carries information from posterior canal as well as sacrum, right? So that's the basic anatomy and physiology, just a bit. Now let's look into the actual brain of the balance system. It's not located in the vestibular cortex. It's just in the pons actually that controls and coordinates the balance system. Not just vestibular system, but balance system. So vestibular nuclei located in pons, it communicates with many more sensors, not just vestibular system. So again, we have four different parts. So superior vestibular nuclei, medial, lateral, and inferior on each side. So they do talk together, similar to your supraorbital complex and cochlear nucleus. And so it actually projects a lot of connections, and these are the most important projections. The vestibular nuclei obviously send information to your vestibular cortex and the oculomotor system, the most important one, and cerebellum, spinal cord, limbic system, autonomic system, and as well as receives information from visual, somatosensory, cerebellum, and other motor informations. So this is skipping a little faster because we want to spend most on functional anatomy. So now think about central vestibular issues. That's one of the common diagnoses, right? So BPPV or probably some peripheral, just like vestibular neuritis or hypofunction, and then another one is central vestibular disorder. Is that all we can do? Central vestibular disorders? As of now, yes. But that gives us a start, right? When something happens, not just to the peripheral system, let's say if my senses are completely fine, but one of these senses is gone, that can be just a part of vestibular nuclei or other senses that I'm going to talk about, then you have your issue. So you have to think about these things as well. And signs also change. So keep paying attention on signs. I'm going to talk about these things in case history, and then vestibular disorders, we're going to talk about the signs as well. Okay. And now we have the most important one, vestibulo-ocular reflex. I think we all know about it. It's the connection between the vestibular system and oculomotor system and how it responds. It's a compensatory responses, right? So when I'm actually, let's say I'm actually straight looking at you, straight, so I'm actually looking at you. And I'm talking to you, meaning that my brain is asking to look at the target. The target is, let's say, I have a person in front of me, right? So at the same time, I'm actually rotating my head. So my eyes are actually fixated on my target. How does my eyes know that it has to be right there when my head is actually moving left and right? Usually when it's fixed, let's say it's fixed, eyes are fixed to skull, or probably there is no insights from brain saying that this is my target. It moves along with my eyes, right? So now comes the multi-teamwork or multi-sensory integration, teamwork. The vestibular system detects how the head is actually rotating and which direction, left or right. That information is sent to vestibular nuclei. Okay? First one, vestibular system, goes to vestibular nuclei at the midbrain. And the vestibular nuclei receives information from the brain because the brain is deciding where to focus. The focus is that, look at the target. So receives information from brain, and the vestibular nuclei now also receives information from the eyes, or sends information to the eyes saying that, you know what, head is moving to the left. My brain wants to pay attention on the target, so it actually asks the eyes to move. And how does eye know exactly? I'm still paying attention on my target, my head is actually moving left and right. Exactly, so it's a teamwork. The vestibular system is detecting that the head is moving to the left, let's say 30 degrees per second, the velocity, 30 degrees per second. And the brain knows that the target has to be fixated, the eyes has to be fixated on the target. And the information coming from the vestibular system is integrated with the oculomotor system and directs the oculomotor system to move opposite side exactly at 30 degrees per second. Even if there is, let's say, a little delay, 30 degrees per second on head, but only 20 degrees per second To the right side, you won't be stable. You feel dizzy. Something is off. Now the question is, which is off? Yes, please.
So you need to say first sensations and first information from vestibular, then to ocular. Not the eyes and then the vestibular.
It's both. So obviously, in order for eyes to work, all three has to simultaneously work. Even if there is little delay, as we're just talking about, there might be slippage. So it's simultaneous and all working together. Yeah. So in this particular scenario, let's say a patient is actually feeling dizzy. I'm fine. I don't feel dizzy, or I don't feel spinning sensation. I don't feel vertigo, but I only feel little blurred, or probably little off when I only turn and try to look at a target. What could be wrong? Which part of this multisensory system is wrong?
Ocular.
Ocular?
Vestibular.
Vestic?
So only blood
Coordination.
or
Coordination? They might be blurred, or probably the patient is little dizzy.
so
Both cases.
integration will be missed.
Right? All of you are correct and probably not sure. Even I'm not sure. Unless you evaluate, that's where the diagnostics come. If it's sound, traveling outer ear, middle ear, inner ear, one way. It's straight, one highway. Whereas here, the problem is at the junction. You don't know where the traffic's actually increasing or no traffic at all, right? So the job becomes a little more complicated, and that's where your friend anatomy and physiology as well as case history comes along with your diagnosis. The job is to now evaluate vestibular system, whether the sensors are fine, because even if vestibular system is gone, the information is not reaching vestibular nuclei properly. Maybe oculomotor is completely fine, maybe the brain is completely fine, but vestibular system is probably a little weaker, right? Or vestibular system is completely fine, but the oculomotor system is a little weaker. Or probably the brain is fine, or probably vestibular nuclei itself is damaged. Every sense is fine, but vestibular nuclei could not integrate properly, then we may also have this issue, right? So now you see the possibilities of diagnosis. And how do we get into this aspect? We have to think about all possible scenarios of the anatomy and physiology aspect, right? That's where we actually have the VNG. I'm going to talk about VNG tomorrow. This is how exactly we're going to put the diagnostics. We rule out oculomotor, assess this part separately, and positionals, vestibular system, then concentration, probably other stuff, then see, putting all these pieces together, we can actually find the issue, whether it's central or peripheral or probably neurogenic.
Sorry for the
Yes, please.
Sir, then proprioception system also will include into the diagnosis. So can we talk about
Yes, I'm going to talk about that, the proprioception at the end of this lecture. Yes. So that's the oculomotor system. The oculomotor system can go off, not only with the vestibular system or oculomotor, but the function at the integration at the vestibular nuclei as well. Now the question that I have to the audience, does VOR required for every head movement? Think carefully. Does VOR required for all head movements? Meaning that every time I move, the VOR is active, or it is VOR should be whether it's required.
should be at least
Not required. Not required? How many of you say not required? How many of you say required? That depends on more context. If I'm going to say, I'm moving my head, but my brain decides whether should my eyes fixate or not. When there is no context, when I'm not actually asking the patient to pay attention or pay attention on the target, then there's no need for VOR. So that's the reason why.
No target, no way.
Exactly, and that's the reason
may
why.
or may not, sir.
May or may not. That's the reason why sometimes if it's like minimal deficit of vestibular function, if the patient don't try to fixate on target, they don't feel dizzy. But when they do complicated stuff and try to fixate, like driving a bike, but they could not actually see the signboards clearly because they're trying to concentrate. Because the system is weaker, VOR should be active. But the same person don't complain while actually driving but not paying attention on any target. They feel completely fine, right? So that's the way that we put the pieces gathering from this information together. Okay, so this is how it actually works. You have vestibular system that's being activated and sends through the both branches of the vestibular nerves and the vestibular nuclei and talks to the oculomotor system. Okay, now the hot topic, nystagmus. I'm not going to really talk about it in depth because it's going to be, I think, discussed in vestibular disorders as well. But as we're talking about it, let's discuss about the nystagmus just briefly. So far I'm explaining about I'm still probably half an hour, 45 minutes I believe, but I'm still at the angular muscles because that's a major chunk. So I'm going to stay here a little more until you feel a little more confident. So whenever you're trying to do the diagnostics, you all are here because you want to do diagnostics, right? Vestibular diagnostics. What are we going to rely on? Just science? We're going to do VNG. What are we looking at? Nystagmus. Right? Nystagmus recordings. So do we have nystagmus? Sometimes there is an induced, meaning that you want to see the nystagmus, such as an optokinetic test. That's normal. But sometimes in positionals, we are not expected to see the patient is normal. But if you see nystagmus, then you have an issue. So what is the issue? And how does this nystagmus looks like? And how to quantify it? So the nystagmus happens when my sensor is off. Just looking at the angular, right? So let's say my left side lateral canal is gone, completely gone. There, right? So now I just lost like a couple of hours back, just recently. Can I stand here? Let's say I came here this morning and probably ate something, now I lost. Throw it up. Can I stand? Yes. It's possible if adaptation has occurred, it's possible, but probably not. If it's complete loss of vestibular system now, just probably a few minutes back, I won't be able to. That's the worst symptom that I can have. The reason is that, remember that it's a push-pull, right? It's loose. My system is loose right now. So remember that it's push-pull mechanism. The brain, the vestibular nuclei is used to receive similar information on both sides. It's equal. My one leg is actually bending, the other leg is actually carrying information, right? So it's actually equal. If at all, one side is completely gone, it's like, how far can I do this? It's not possible, right? I cannot actually walk properly and the vestibular system loses that information and it goes crazy. Spinning, spinning, spinning. Because, let's say my left is gone. Let's say this is the regular range. It's not always zero, right? Nerves cannot be zero. There's always resting potentials. I mean, you can go back, what is mean to call as resting potentials, but never it's going to be zero. It's around 20 to 30% approximately, even when you don't move, right? But when you move your head to the right side, it goes, let's say, to 70 to 100%. On the opposite side actually goes down. But if one system is completely gone, there is no pull mechanism, a push mechanism. The other side, even though you're not moving because this is gone, the vestibular nuclei only receives information from the normal side. And at that vestibular nuclei, it perceives it as actually rotating. Because this side, there's nothing stopping. It's not stopping me, so it's gone. It feels like I'm rotating. Even though you're not rotating, that's how the vestibular nuclei perceives, and that's the reason why patient complains, I'm spinning. That's vestibular nuclei. Because the information from vestibular system is off.
Should we pull you down? What is it?
It's lateral canal, you're correct. It will inform that it's actually spinning lateral, because it's only lateral canal. The example here is lateral canal, but it's not exactly like parallel or perpendicular, but it's actually inclined at 30 degrees high. It looks like you're rotating like this. Yes, that's the reason why patients feel like they're going to fall, right? To the better side, not the poor side. But that's not exactly it. The question is, what's happening with the eyes? Teamwork. The eyes also know whether the person is stable or not, or if he's rotating or not. So we are only looking at vestibular nuclei, right? Because one is gone, the other one is actually has two phases. One slow phase, the other one is fast phase. So now the question is, let me replay once again. Which side is the fast phase and which side is the slow phase? Let's give a nice diagnosis. We all call it as right side beating, left side beating, right? So which beating is this? This one. This is left beating. Do you all agree with that? It is, right? So let's play one more time. It's going slowly to the right and then going fast to the left side, right? So yes, it's a left beating. What about this one? Up beating, right? Clear? Any questions on this? Great. Yes, please.
You mentioned that nystagmus occurs when there is no input from vestibular system, but eyes knows that the person is not moving. So it means it's only the state when the person is fixating on something. If the person is not fixating, then the input from eyes won't tell the vestibular mismatch.
It's an excellent question. It's an excellent question. You're partially right, but again remember that the vestibular system is, the balance system is more complicated. So far I only covered oculomotor system, but I'm standing or probably I'm sitting. It has proprioceptive information, spinal and cervical, which I'm going to talk about. Even these sensors actually contribute, not just oculomotor. There might be a blind person. So they also are going to actually have the nystagmus, but these things are now contributing, right? So let's talk about that. But it's a good question.
Sir,
Yes, please.
if the patient is having diplopia condition, how do you identify whether it is nystagmus or the gaze fixation?
So, very good question, but I'll get back to you that as we cover all those things. It's too early to discuss about it. It's a good question. Okay, so nystagmus. So we are comfortable with looking at eye and say which side it is beating, right? But this is how we're going to see in the report. So this is a nystagmus recording, and which beating it is. Is it right beating, left beating? Right? Left? How many of you say, how many of you are comfortable, first of all? Do you know how to read this? So generally there are two ways. One, you should actually have a scale, but standardized is that the R goes top, on top, L, R, U, or D. So this is fast. And it's located towards right or up. Either right, if it's horizontal, if it's vertical, it's going to be up. So it's going high, it's fast. Then slowly sloping to down. It's either left beating or down beating, depending on which direction that you're looking at. Okay, so that's the fast phase and slow phase. So again, this is one more example, recording from calories. Which direction is this? On the left side. Little task. Fast. Or should I pick a person? Which beating? That's a horizontal, not vertical. This is a horizontal recording. I'm going to give you a clue, or probably it will help. This is slow phase. Oh. So this is slow phase. For confidence. How many of you say right? How many of you say don't know? Okay, let's work on it. So this is right. Always top is right. If it's a horizontal, right? Top is right and the bottom is left. So which side do you think it's just going fast? So it's always starts from left, right? It starts from here. So as you can see, slowly going up and then going down fast. Slowly going up and down fast. Right? Slowly up, down fast. So which is the faster side? Left. Right? So are we clear now? So let's erase this a little more. Thank you. Okay, now let's talk about this guy. Is it right beating or left beating? Right beating? How many of you are confident now, whether if it's right or left? Right. Right. I see a little increased number. It is right. Okay. So if you're still confused, I'll be available after this session. So let me move a little faster. Okay. So I'm really not going to talk about this, but obviously the oculomotor system is dealing with eyes, right? And eyes have at least 6 different muscles that actually control the eye movement. It's not just the rectus muscles, which actually controls the lateral as well as vertical movements. But we also have, in VPPV condition, we probably learn about torsional movement, right? The torsional are not going to be controlled by these rectus muscles. So these are the rectus muscles. We have 2 lateral, 1 lateral. This is medial, and this is superior, and this is inferior. So these are the rectus muscles. So the torsional are controlled by the oblique muscle. We have superior oblique and inferior oblique. Sometimes, very few times, so if you even think about the abnormality and relationship to the function of vestibular system and other systems, sometimes there might be a paralysis, right? There might be chances that the muscles might be weakened. You might see some blurredness or probably diplopia or probably other stuff, not because of vestibular system, but this could be one of the possibilities as well. There are other possibilities, but this could be one of the possibilities. It's not just always vestibular system. That's the reason why sometimes your VNG, let's say if your clinic has only VNG, the VNG will be completely fine or completely wrong. Abnormal nystagmus across all tests because it's always twitching, right? That can result, and if you know what you're looking at, if you know all of these recordings are off or not matching with case history, now you know where to think. There is something else, right? So that something else can be determined with other tests, so we can actually discuss that later. Okay, so yeah, the diagnosis, so the innervation comes from 3 different nuclei and obviously connected to the vestibular nuclei. I'm a little short on time, but please do stop me if you need to go in depth. Next one is, and the most interesting is vestibulospinal reflexes. Right now I'm talking to you and you're all sitting comfortably and most of your heads are not moving, right? There are patients in your same situation, they are not actually moving, but just sitting or probably sleeping. I'm pretty sure that you probably might heard or probably going to hear that patients feel floating sensation when they are resting, or feel like they're actually moving, or dizzy, or they won't be able to walk properly. They feel like wobbling or being pulled to one side. There are several reasons, right? But it only happens when the head is not moving, even when the head is actually rested. So if head is moving, then there is a vestibular stimulation. If the vestibular system is damaged, then there is a reason. But in this particular case, there is no head movement, meaning that there is no vestibular activation, but the patient still actually feels imbalanced or probably dizzy or whatever they complain. Why is it? If the vestibulospinal, the spinal reflexes are abnormal, not just vestibular system, it can actually happen, right? So let's say if my spinal is weaker and I actually try to walk a little bit, my vestibular system is completely fine, but I'm not moving my vestibular system, either sitting or probably try to stand up, your patient complains that I feel dizzy. It's not just vestibular system now we have to think about, we also need to think about spinal reflexes. How do we know? When you do the VNG, all of your VNG results might actually come normal. With VNG, we are only testing vestibular system And if you're actually including oculomotor testing as part of your ENG, you're actually assessing only these two parts and VOR. It might come completely normal. But your patient still says, I feel imbalanced. Why is that? Because there is a spinal system that we are not evaluating yet. So this is how you determine to go to the next testing once you rule out the most common cause. Rule out that vestibular system is fine, oculomotor is fine, then complaints, go to the next testing. That's vestibular spinal reflexes. And the vestibular spinal reflexes, it does actually work together. If my my spinal system is a little weaker, it can actually work with vestibular system, and that's the treatment, vestibular rehabilitation, not medications. It makes it even worse. In my experience, we've seen medications makes it even worse, especially in young generation, not older generation. So you should be very careful while actually when you diagnose vestibular spinal reflexes. There must be a medications where it's necessary, but not on vestibular suppressants, because in this situation, vestibular system is going to be friend of the patient. If my spinal system is weaker, we know if one sense is weaker, it's going to ask help from other senses, right? Next thing that it's going to ask is vestibular system. And if you put them on vestibular suppressants, you're making it weaker. And the patient feels more imbalanced. You'll see this patient, he complains that after taking medications, I feel more dizzy and weak. That's the reason why I stopped it. Right? So you should be able to counsel the results to the appropriate physician if they actually deny to actually accept that the vestibular medications are actually inducing more imbalance. So this is how you get to know which sense and how it's going to contribute even in treating, not just diagnosing. And you always need to think about the physiology. Okay? And the vestibular spinal reflexes helps in fall prevention as well. As we get older, let's say one of the most common risks with spinal damage is falls. If vestibular system is weaker or probably gone, the chances of a patient falling is going to be very, very high. Because spinal is weaker and it's going to rely mostly on vestibular system because it can detect all sort of motions and it will feed information to vestibular nuclei to prevent any falls. And that's where you probably might have heard the extended and flexor will actually come in. If I'm going to fall on the left side, my vestibular system predominantly detects that I'm actually moving to the left, and it's going to ask the spinal cord to bear more weight on my left leg. Because my left leg is weaker, I'm completely fine. My vestibular system is fine, my spinal system is fine. That's the reason why I can stay in this position. But if a person has spinal issues, they can with some rehabilitation, but it's going to ask information from vestibular system and it try to contribute. If it's completely gone, even my vestibular system is completely gone or probably affected more than moderate, it cannot tolerate. So the help that it's going to do is extend my arm so that I can actually prevent or damage to the brain. So that's autonomic responses as well. Okay? So how many of you are sleeping? Not yet? Okay, let's cheer you up. Okay, you know this, right? Okay. Now pay on this actor. Pay attention to this actor. So what is he doing?
Balancing on
Both hands. Both hands.
Talk about physiology. I don't want to talk about dance. Talk about anatomy and physiology of vestibular system. How many sensors is he utilizing to do this complicated test? Right? So if you pay keen attention on his leg versus the supporting dancers, pay more attention. I'm going to pay it one more time. Pay keen attention on his foot compared to these guys. He's lifting off his foot actually, he's relying on his toes compared to other people. it's not possible for you and me unless you train actually, right? But I'm not trying to appreciate the dancer, but let's pay attention to actual subject. The vestibular system, is vestibular system active? Yes. Pay attention. One more time. Is his head moving?
Yes, a little bit.
Just a little bit, right? Not angularly. A little bit linearly. So, is the vestibular system really active or is it going to be passive?
Active.
Probably passive. In which sense is really active? Spinal, obviously, right? As well as proprioceptive. I'm going to talk about that. Yes, spinal is the active. But let's say spinal is weaker. Let's forget about this dance. He won't be able to. But the question is, there are dances that comes to you because you're going to be a specialist. Sir, I used to dance a lot. Now after an incident, I won't be able to even walk sometimes. How do I retain my skills back? Is it possible to dance up to this extent? That should be very careful. If there is a permanent damage to spine, right? Probably not. But rehabilitating to walk, yes, that's a rehabilitation. But up to dancing, you also need to look into other aspects such as whether there's a permanent damage, whether it's recoverable, unrecoverable. But we, as a balance specialist, should be able to help them in reaching to the at least balanced walking. Okay. So colic reflexes is going to be very important for your vent. The eyes are also connected to the neck muscles. So right now I'm actually talking to you, but my head is going to be straight. Okay? What's happening? Is my vestibular system active? No, right? How about now? The neck is moving. Vestibular system is completely stable, zero activation, but the neck is being activated. Your neck have two different sensors. One, true neck responses, and there are also proprioceptors. The skin sensors, both are different, and they both contribute to letting the spine and vestibular system know, you know what, even though you're not actually moving, your body just moved to the left side, and that information is pursued by the system and go to this vestibular system, and it can actually control. Have you heard about patients that actually feel dizzy every time, but vestibular system is completely fine? You do calorics or BNG, completely fine. Or probably all of your positionals are irrelevant. There's something called cervicogenic dizziness. Have you heard about it? It does. If there is any issues this level, then because this is off, the patient also feel dizziness, and sometimes it can actually mimic like it's a peripheral. So you have to be very careful, and that's another reason why during BNG, I think I'm the person who's going to talk about it. This is a cervical screening. Before you actually go for actual BNG testing, we do cervical testing to rule out whether if the results are actually coming from the vestibular system or from the neck, because it can mimic like a vestibular system. Because along with the lateral canals, your neck is also moving, right? Both are moving at the same time, and both might actually give the similar responses. Yes, but the peripheral system in vestibular system actually takes lead. This is more active, and this is going to be passive responses. But yes, it can corrupt your diagnosis if you don't. Okay, so if you stimulate sacute with the loud sounds, it's going to actually stimulate the SCM, the sternocleidomastoid muscle, and that's how you're going to measure the vents. Okay, and let's actually watch this one. I can definitely assure you that the chicken's head is not tied with any thread. So what's happening here?
So it movement is
Head fixation. How?
with the fixation of neck muscles.
Fixation of neck muscles? Is vestibular system active?
No.
No, except for a little bit of gravity sensors, right? But how come the chicken is able to actually put its head exactly in the same situation? Because usually we believe that vestibular system is helping that, right? Can I do that or you do that? I don't think so, right? But it can. It's way superior in these animals. But yes, which sense it could be? It's obviously written there. It's a cervicocolic. As I was just going through the cervicocolic is, there are muscles, neck muscles that actually contribute to detect the motions. At the same time, there are sensors. In this particular animals, they have superior sensors here so that they can actually detect this and is able to actually put its head stable in space, even with body movements, right? But it's not that active in humans, but sometimes even if there is a damage to the cervicocolic reflex, your patients might actually resemble like cervicogenic dizziness. But again, in humans, it's very rarely studied and not active. So last two. See, vestibulocortical. So vestibulocortical is not completely studied yet. So unlike auditory cortex, which we're completely aware of it, but vestibulocortical is still working on it. We really don't understand the complete functionality yet. But so far, if any damage to the upper portion of the brain can result in neural circuitry disorders. Have you heard about that? Neural circuitry disorders. Triple PD, or chronic subjective dizziness, is one among those. Meaning that everything is fine. Your spine is fine, cervical is fine, vestibular system is fine, but control from here is affected. Such as, let's say, if you're completely busy, frustrated, you're busy, you feel a little dizzy only when you actually are anxious. But everything is fine. Patient also report that I feel spinning sensation. Sometimes we feel like it's vertigo, probably vestibular issues. No. That's where the beauty of case history comes. You do PNG completely fine, rotary chair completely fine, caloric completely fine, even equipoise, all cardiocarbography, everything fine. But if you put patient in such conditions like anxious or probably cognitive overload, then you're going to see that. So that is probably coming from the vestibulocortical. Anything above the midbrain. So it helps extremely in cognitive perception and spatial orientation. If any patient that actually complains about these issues, then we have to think about the vestibulocortical. And vestibulocerebellar, we know cerebellum, everyone is Telugu speaker, right? Chinnameda dobbinda antuntaru. Cerebellum. So the typical sign is imbalance. Cerebellum is affected for any reason, patient is going to have a lot of imbalance issues. So it controls the balance system of humans. It can be actually rehabilitated, even though it's not to the extent of normal, but it can be rehabilitated. And the somatosensory system. So the sensors so far we discussed: vestibular system, cervical system, and oculomotor system, spinal system, and even colic system are true sensors, right? They actually have a little function. There is something called somatosensory system. It's actually true senses, called also sometimes referred as sixth sense. I can know that the air is actually cool. How is it possible? I know that I'm actually standing on a hard surface. I'm stepping down. If there's a carpet, it's actually smooth. This sometimes patients may say that I'm completely fine, sir, but whenever I walk in a park or probably uneven surface, I actually have difficulty, have imbalance. If you test, vestibular system completely fine, oculomotor system completely fine, cervical vent completely fine, spinal completely fine. What's exactly happening? Now you have to think about specific situation. You say that only in uneven surface because the proprioceptive probably is off. Now do you see the points? If you don't ask questions, again this is actually part of case history, I'm actually jumping, but that's the reason why at the beginning I say that sometimes I call patient again before I finalize my report, because test doesn't make any sense. I cannot say you're faking. No, they don't fake and come to you and say spend like 15,000 for the test reports. They definitely may have, but it's my job to look into all of these functionalities. And you only do this if you truly understand how these bits and pieces works together. Okay? So there's one more and hidden, and it's actually in the rise, vascular system. We all know. Earlier, like probably like 4 or 5 years back, even before you become an audiologist, someone says that చక్కెర వస్తుందండి అంటే షుగర్ ఎక్కువైంది, బీపీ ఎక్కువైంది, ఒకసారి పడుకో అంటాం. It's true, but it's not like once in a while. It is once in a while, but it's true. The reason is that, as we can see, we have immense vascular connection to both cochlea as well as vestibular system. Personally, I'm actually working on a paper. The vascular system, if vascular system is off, it really mimics like several commonly misdiagnoses, such as Meniere's, BPPV. It's really interesting, but yes, it can actually result. If there is high blood pressure, we all know probably about the orthostatic hypofunction. If there is, let's say, thicker blood, if they are not actually using blood thinners, then you probably might have increased pressure within the cochlea. It's not just endolymph, right? Endolymph increased pressure can cause in Meniere's disease. Similarly, this can also happen in similar fashion. Sometimes you might see like complete Meniere's symptoms, but you may actually completely find there is no abnormal ecologies or probably no typical Meniere's signs. Then you probably need to look into vascular assessment. This articles will be published pretty soon, but it's a very interesting findings. Okay. Well, to end as a summary, so I have this fancy. If you attended Rajamandri session, you probably know this. So this is one dance step that actually integrates all of your vestibular system, all of your balance system. There is vestibular movement, there is cervical movement, there is spinal movement, and also cognitive lower. Because the dancers are taking a lot of pressure to match, not just randomly, right? So this is a perfect synchronization of all balance systems. So think about it, and if any of these person have any of issues with any of these connections, they won't be able to dance like that, and probably Oscar won't be awarded to this. Okay, so that's all for this session. Again, thank you very much. I'll be right here if you have any questions.
Thank you so much, sir. Now, Aish, promoted to leader in audiology in 2015 and further promoted to associate professor in the year 2019. He has 15 years of teaching, clinical research and administrative experience. He primarily works in the area of assessment and management of vestibular disorders. He teaches audiology to undergraduates and postgraduate students. He has presented more than 60 scientific papers at national and international conferences and published more than 65 peer-reviewed papers in international journals. His publications are in very reputed journals such as Journal of Vestibular Research, Frontiers in Neurology, the American Journal of Audiology, and the Journal of the American Academy of Audiology, European Archives, and Otolaryngology, and hearing research. He has received many awards for his scientific paper presentation at the National Conference in Audiology. He has successfully guided 35 postgraduate students in their master's dissertations and is currently guiding 5 PhD candidates for their doctoral research. He is also the first audiologist in India to publish a book on vestibular science. Great. Thank you so much, sir, for coming here. And now you all know why
or feeling sleepy. Actually, I am the one who is feeling sleepy. Okay, so after a good session on anatomy and physiology, I am going to talk about the causes of vestibular disorders. And I am not going to talk here about what you have already learned, Meniere's disease, BPPV, vestibular sternoma. I am not going to talk about that. Rather than I am just moving forward where Dr. Yogandan left, that is the anatomy and physiology, and I am only going to explain that what can go wrong with this anatomy and physiology and what it can cause basically. So before I move, I would like to thank the organizers for providing me this opportunity to come here and give a talk on this topic. So, if you look into the vestibular disorders, if you can just understand this chart. So, yeah, okay. So here what I have done is try to understand this, that what it is going to cause. Now understand that vestibular disorder can be hyperactive disorders and could be hypoactive disorder. Hyperactive disorder means where the responses of the vestibular system is basically increased, and hypoactive is the one where the responses are basically decreased. Okay. Now the hyperactive disorders can be, first I have put is a mechanical disorder. Mechanical disorders such as your benign paroxysmal positional vertigo or B2PV, and then a third motor syndrome such as superior canal basin syndrome. And hypoactive disorders, I will just explain here. There can be an end-organ, I am audible?
Yes.
Right? Yeah, okay. So there can be an end-organ pathology. When I talk about end-organ pathology, I am talking about the inner ear basically, the labyrinth, and nerve pathology wherein I am talking about the pathology related to the superior vestibular nerve and the inferior vestibular nerve. When you look into the end organ pathology, there can be pathology which is related to the endolymph, and in the endolymph there can be a pathology like hydrops wherein there is an increased quantity of the endolymph, and there can be infectious conditions of the endolymph. And then you can look for, in the labyrinth you can look for another pathology which could be vascular in nature, and this vascular pathology either it can be idiopathic in nature, that means that there is no cause for it to occur, or there could be a lesion because of anterior inferior cerebral artery and posterior inferior cerebral artery lesions, that is ICA and PICA lesions. And the nerve pathology, there can be a space occupying lesions such as your tumors, vestibular sonomas. Then demyelinating diseases wherein there is a demyelination of the vestibular nerve, and there could be an infectious condition such as your vestibular neuritis. There is another pathology wherein a lot of attention is being given and you get many patients, that is your vestibular migraine, which I will deal in detail. So this is how you can classify. And I am not telling you about what is BPPV, I am only telling that what is happening inside the inner ear now. So if you look into the inner ear, so already Dr. Yugandhar has already explained that you have utricle and sacral, and this utricle and sacral has a small otocorneas which are basically your calcium carbonate particles, and these calcium carbonate particles basically they are binded together. That means to say that it's like the whole, if you just put a jelly kind of thing there and you just put it, they are binded together. Now due to aging process, in most of the time either due to the aging process or due to a sudden road traffic accident, what will happen is this binding will become loose. So when this becomes loose, what will happen is this is likely to fall from the utricle, and this can go to one of these canals, that is the anterior canal, the posterior canal, or the lateral canal. When this moves to the one of the canal from the utricle, what will happen is this is an unwanted guest here. So when it is an unwanted guest here, it is going to create the problem. What problem it is going to create? When the person's head is quiet, person is not moving the head, person will have no symptoms at all. But when the person is going to move the head, this crystal is going to move, or this calcium carbonate particles are going to move inside the canal, and it is going to affect the physiology of the semicircular canal. That's why every time the patient will move the head, what will happen is patient will experience an episode of mortality. Okay? The anatomical condition is such that 90% of the time the debris will fall into the posterior canal, that is the calcium carbonate particles will come into the posterior semicircular canal, and another 7 to 8% of the time it will come to the lateral canal, and only 1 to 2% of the time it will come to the anterior canal. Because of the position, because anterior canal is positioned superiorly, the things cannot move against the gravity. So that's why the chances of occurring a BPPV of the anterior canal is rare. Now here again you have to understand one more thing, is that either this debris can remain within the canal or it can get attached to the cupula. So if it remains within the canal, it is called as canalolithiasis, and if it gets attached to the cupula, it is called as cupulolithiasis. Okay. Now when this will occur, When this will occur, what will happen is there will be episodes of vertigo, but it will be of small durations. Maximum it can occur for 30 seconds and not beyond that. Okay, and vertigo, usually when you look at these patients, vertigo will start in this patient, the first episode, I am talking about the first episode, the person will tell that night I was sleeping somewhere in the midnight and 12 o'clock or 1 o'clock or early morning 2 o'clock, 3 o'clock, it started and I felt that the whole world was spinning around. This is the first sign and symptom which the patient will tell you that it started in the midnight or it started in early morning. Similarly, sometimes if you just, I don't know how many of you have concentrated, if you take the case history of otitis media in children, all the parents will give you a common information that the child got up at night and started crying that the child has ear pain.
Yes.
Yes, similarly, this will start at late night or early morning. First 2-3 days, patient will have vomiting or the episode of nausea, and after that, this episode of vomiting or the nausea is going to reduce over the period of time. And symptoms, these symptoms, the vertigo symptoms when the dubbies will fall will be more in the early morning, and as the day will progress, the vertigo will be lesser towards the evening. So they will feel that more severe symptoms in the morning and they will feel less severe symptoms in the evening. And nystagmus, when it is posterior canal BPPV, basically it will be upbeating torsional nystagmus. When it is lateral canal BPPV, it will be horizontal nystagmus, and when it is anterior canal BPPV, it will be downbeating torsional nystagmus. Downbeating torsional nystagmus. So these are the characteristics when the otocornea will fall into the semicircular canal from the umbilical. The second pathology, which is your hyperactive disorder, is the third window syndrome, or I am going to talk about the superior canal lesion syndrome. Now, if you look into the superior canal, it is called as superior because it is placed superiorly, and now you already know that there is osseous labyrinth, and inside that there is a membranous labyrinth. Now, whenever the footplate of the stapes is moving inside, what will happen is the window lymph is going to move, it is going to create a motion, but what will happen is this membranous labyrinth will have a restricted movement because upside there is a bone and it cannot move beyond this bone. It will always get stuck here. So it has a restricted movement, and that's how the oval window and the round window will work together. Fine. When there is an opening here, that is, whenever what will happen is there is either the thinning of the bone or the bone is missing. At that point of the time, when the footplate of the stapes is moving in and out, another pathway to relieve this pressure is open. That's why whenever you give a sound through the air conduction mode, what will happen is the sound energy will be wasted here. So hence the audiogram might show an air conduction loss. That is, it will show a hearing loss in your audiometer. But what will happen to the bone conduction is that you are placing the bone vibrator on the mastoid, and you know that theories of bone conduction that it will get transmitted from the skull to this one. When the bone is missing, the sound transmission to the membrane becomes easier. That means to say that there will be an increased sensitivity of the bone conduction now. So the audiogram typically will show a conductive hearing loss. The audiogram will typically show a conductive hearing loss. Okay. So here what is happening is, although there is no middle ear pathology, only there is a pathology in the inner ear, but it will show a conductive hearing loss. Okay. And another thing which is very important, which you have to understand in this condition, is that the 500 Hz tuning fork will often lateralize to the affected or to the worse ear. The 500 Hz tuning fork. And then photon audiometry will often reveal a conductive hearing loss, usually less than 1 kHz, in the lower frequencies more, and there will be this is the main thing, normal tympanogram with presence of acoustic reflexes. Now what you will think always that most of the time I have seen that people will think that okay, there is a conductive component and reflexes are present. That means to say that something which I have made mistake, because of which there is a gap in the air conduction and bone conduction threshold. Many people will just correct that and make it is a to match what? The presence of reflexes. But you have to be careful. Okay? That may not be a case of actually ISN hearing loss, this one conductive hearing loss, but what could happen is there could be a SCD or the superior canal ASN syndrome. And another major finding is the vestibular immobile potential, when I will dealing that next, that generally VAMPs are elicited at a very higher intensity. When I record VAMP, I record VAMP at 95 dB NHL or 125 dB SPL. And in normals, the VAMPs you can record up to maximum 85 dB NHL, below 85 dB NHL you don't get the VAMP usually. But in these patients with superior canal DSNs, what will happen is the VAMP threshold can go up to 40 to 45 dB. That means to say that you can record VAMP at 40 dB NHL also, 45 dB NHL also, which is not possible in individuals with normal hearing or normal vestibular system. Now, pathology related to the endolymph, that is your first thing which I am going to deal is the eye drops. Only I have in this slide, I don't have any other thing, and here only you have to understand everything. Now, what will happen is, this is what you have to understand the whole thing. This is our scala media, this is our scala vestibuli, and this is our scala tympani. Now, eye drops means that there is increase in the endolymph quantity. Now, you have to go back to your physics. You can compress any system or anything in this world, you cannot compress is the liquid. Essentially, liquid will compress everything else where it is there. That's why you put liquid in any structure, it will take the shape of that particular structure. Now, because there is an increased endolymph here, what will happen is, it is going to create a pressure on the basilar membrane and it is going to create a pressure on the Regener's membrane. When it is going to create a pressure on the basilar membrane, again you have to go to the characteristics of the basilar membrane basically. When you look at the basilar membrane is more stiffer at the base and it is less stiffer at the apex. When it is less stiffer at the apex, there will be a more compression at the apex and there will be less compression of the basilar membrane at the base because it is more stiff. So when there is more compression, pressure is equally applied, but the compression will happen more because it is less stiff. Hence, the hearing loss which will appear in the high drops cases will be concentrated in the low frequencies, not the high frequencies, low frequencies. So you get typically low frequency sensorineural hearing loss in the Meniere's disease. Is it clear? It is coming from the apical structure, and that's why the tinnitus will also be concentrated in the low frequency. That's why they will have a low pitch tinnitus.
Can you repeat the cause? The cause can you repeat again? Can you repeat the cause again, sir?
Yeah. So here what will happen is, you have to understand the basilar membrane. Basilar membrane, it is more stiffer at the base, it is less stiffer at the apex. When it is less stiffer at the apex, what will happen is pressure is equally applied. But because it is less stiffer, the compression will be slightly more at the apical end compared to the basal end. Hence what will happen is the hearing loss will come from the low frequency first. Hence all the cases with Meniere's disease, you can see that low frequency SN hearing loss. And the tinnitus also will come from the low frequency or the low pitch. Now, basilar membrane and the Regener's membrane, both are membrane, but one is base. Base is always stronger. Base should be stronger for anything. So here also in the ear also, the basilar membrane is more stronger compared to your Regener's membrane. But what is happening is the quantity of the fluid is increasing day by day, it is increasing. Now it is creating a pressure on the basilar membrane also and creating a pressure on the Regener's membrane also. Someday what will happen is this Regener's membrane will rupture. What will happen to Regener's membrane? Rupture. Now there is a pressure which is pressure of the fluid which is confined within the scala media. When this will break, the fluid will just gush out with thrust. Fine. So when it will just move out, what will happen is there will be a sudden deflection of the hair cells inside the cochlea also and inside the vestibular system also. So when it moves inside the cochlea, what will happen is there will be an increase in the tinnitus. So the patient will tell you that whenever there is an increase in tinnitus, at that point of the time I get this vertigo episode. That is the time that we say that Regener's membrane has ruptured. The pressure is just suddenly out. There is increase in tinnitus and there is increase in vertigo. That is the time they get the episode. That is the Meniere's episode. And this episode will last for several minutes to hours together. Is it clear? But Regener's membrane has a property. Regener's membrane has a property. What is that property? Is that slowly it is going to heal. That means say that it is going to get regenerated. When it is going to get regenerated again, what will happen is again the pressure will start building up inside. When the pressure will again start building up inside, again the heaviness of the blocking of the ear the patient is going to feel. Again it is going to rupture, again the second episode will happen. Again regeneration will happen, again it will break, again third episode will happen. So it will cause an episodic vertigo in the cases of Meniere's disease or hydropic cases. Is it clear? And remember, between first episode to second episode there will be a gap. But between second to third, that gap will reduce. Third to fourth, the gap will further reduce. Fourth to fifth, the gap will further reduce. Because it's simple thing, you go on breaking some structure and you go on adding again breaking, it will become weak. So the rupture will happen more faster. Is it clear? And one more thing which you have to remember, when this will rupture, there is no separate endolymph and there is no separate perilymph. It is the mixture of endolymph and perilymph. When the perilymph gets mixed to the endolymph, perilymph is basically toxic to the hair cells. So it will result in degeneration of the cochlear hair cells as well as your vestibular hair cells. Is it clear? So eventually one fine day the patient will have severe sensory neural hearing loss and the patient will have a complete death of the hair cells inside the vestibular system also, which is called as burnout phase of the Meniere's disease, wherein the patient's vertigo will completely disappear, but that takes 7 to 8 years or 10 years for the vertigo to completely disappear in the particular patient. Fine?
Usually, what's the duration, sir, to
regenerate
loss of hair cells?
What?
What is the average duration? How much time does it take?
No, complete
damage hair cells.
Complete damage will at least take, burnout phase will take at least 7 to 8 years. 7 to 8 years. Till then the episodic vertigo will keep again. But
in the first episodic vertigo, second one, how much can be the duration?
it varies from one person to the other person. There is no fixed timing. For one person, the second episode can occur within 3 months also. For some person, it occurs 3 years after also. It depends upon person to person. There is no fixed timing. But they will have symptom only on the day of episode. Between the two episodes, always there is a silent period. They don't have any symptom. They will remain normal.
But they complain of fullness all the time. So
Because of the pressure which is building up
yeah,
inside.
so the only symptom that they keep showing is fullness of the ear.
Yes. Because the gyrus membrane gets regenerated again, it is building up, so that pressure is increasing, and that's why they feel that fullness in the ear.
Sir, what is the average of the long-lasting of episodic phase? The duration?
I said it will reach to burnout phase in 7 to 8 years minimum, not before that. Okay. So the next condition, which is again related to the endolymph, it can be infectious. That is, there is an infection of the endolymph. And remember, anything that happens to the endolymph, please remember, it will damage both the cochlear as well as vestibular structure. Very simple. Whether it is infectious condition or whether it is hydropic conditions. So when there is an infection here, it will lead to the damage of cochlear hair cells as well as your vestibular hair cells. And that is how you know as labyrinthitis, infection of the labyrinth. Okay. So here, it can be caused by a bacterial infection or it can be caused by a viral infection. Even the standing middle ear infection can invade inside the inner ear and it can cause a labyrinthitis. Okay. Now bacterial infection, if it happens because of a bacterial. Suppose the labyrinthitis happening because of a bacterial meningitis, the loss is always greater. Remember this. So remember that the labyrinthitis occurring because of a bacterial infection, the losses will be higher. The labyrinthitis occurring because of a viral infections, the loss will be little less. More severe degree of hearing losses you will see in bacterial labyrinthitis and lesser severe degree of hearing loss you will see in viral labyrinthitis. Okay? And again, tinnitus, hearing loss, vertigo and nausea or vomiting and symptoms will be non-fluctuating. It will not be a fluctuating symptoms like your Meniere's disease. Okay?
Isn't the vestibular symptoms are severe and bacterial come to viral?
Yes, it will happen. But what will happen is, remember this, if the hair cells are dead, the vertigo will disappear. Very simple. No sensations. Sensations are gone.
Sir, is there any particular region to difference between the attack of bacterial and viral?
region.
Is there any region? Sorry, sir. Is there any particular region?
No, see, the
more
what will
loss of
happen
bacterial
is,
and less loss.
basically it will start up after an episode of upper respiratory tract infections. Now, upper respiratory tract infection, more common symptoms are cold, cough and flu. Okay. Now, that cold, cough and flu has been caused by a bacterial infection or whether it has been caused by a viral infections. That can, the pathogens can go to the inner ear and it can cause an infections there. Something like, for example, bacterial meningitis. The root is through the CSF, but it is bacterial in nature. It will come to both the inner ear and it will damage eventually both the inner ear. It will cause labyrinthitis of both ears. So it is a bacteria which has reached to the inner ear, will damage the entire ears. Fine. Can be unilateral or can be bilateral depending upon how the pathogens have reached to the inner ear. Suppose, for example, if a person has long-standing otitis media of the right ear or long-standing polystatoma in the middle ear of the only the right ear can have labyrinthitis. If bacterial root is there, meningitis, then both the sides can be affected. So it can be unilateral or can be bilateral in nature. But remember, it is non-fluctuating. It is not a fluctuating symptoms. The third one is the vascular lesions. Vascular lesion, you have to understand a little anatomy now. I'll just come here. This is the main basilar artery, and the basilar artery, from the basilar artery there is another, this one connection which is known as ISHA, anterior inferior cerebellar artery, and from inferior cerebellar artery there is a labyrinthine artery. Labyrinthine artery means that is supplied to the labyrinth, and this artery will further move on and it will go and supply the cerebellar structure. It will supply the cerebellar structure. Now, the symptoms are going to be very different. Now, suppose if there is a moving thrombus or emboli in the artery here, say that in the ISHA circuitry, if this gets stuck at this lesion, this gets stuck at this lesion, what will happen? What will happen is the blood supply to the inner ear will be cut off, and also the blood supply to the certain part of cerebellar system will be cut off. So the person will have hearing loss, vertigo, and the cerebellar symptoms. Person will have the cerebellar symptoms. There can be cases of sudden sensory neural hearing losses. Sudden sensory neural hearing. You have to be very careful with cases with sudden sensory neural hearing losses. They can have a pure sudden sensory neural hearing losses, or they can have sudden sensory neural hearing losses associated with the cerebellar infarct or cerebellar damage completely. Now, if suppose, for example, the thrombus or the moving emboli, it gets stuck here at this point of time, in this region, then what will happen is it will only damage the cochlear structure and it will only damage the vestibular structure, and it is not going to cause any damage to the cerebellar structure. So person will have the sudden sensory neural hearing loss associated with vertigo and no other cerebellar symptoms. Then the another artery which is responsible for blood supply to the cerebellar system is called as posterior inferior cerebellar artery, which is spica circuitry. If there is a blockage here, what will happen is the blood supply to the cerebellar structure will be gone. In this case, the patient will have vertigo, patient will have all the cerebellar symptoms, but patient will not have hearing losses. That's why you have to be very careful with patient with acute vertigo cases. You don't know whether you are dealing with a case of coming originally purely from the inner ear, or it is coming from the cerebellar structure plus the inner ear. Is this clear? Any doubt? If there is a blockage here, it will damage both the inner ear as well as the cerebellar structure. If there is a blockage here, it will damage only the inner ear. If there is a blockage here, it will damage only the cerebellar structure, it will not damage the inner ear. So it depends upon where there is a blockage in the artery. This is what will happen to the vascular lesion. Yes.
How can we differentiate between the vertigo symptoms associated with cerebellar issues and inner ear?
Yes, and if there is a blockage here, then the patient will have a sudden sensory neural hearing loss,
plus patient will have a vertigo. That can arise from here also and that can arise from here also. But patient will have the cerebellar characteristics, disease characteristics, which I call them as deadly Ds. These are dangerous Ds. So if you find that the patient has a hearing loss, along with that the patient has dysarthria, dysphagia, diplopia, dysphonia, dyssynergia, dysesthesia, dysdiadokinesia, then definitely patient has a damage to the inner ear plus the cerebellar structures. These are called as deadly Ds. And at least as a speech pathologist, you should be able to pick this. If you are not able to pick this, then don't know, you should not practice. Very simple. Correct? Yes. Understood now? Yes. So I am not talking this, all this one, your BP, PV, these I am coming here now. Now nerve pathology. I said that nerve pathology there could be three things. One is a space occupying lesion, other thing could be demyelinating condition, and third one will be your infectious condition. Now I am coming to the space occupying lesion. So now again you have to learn the anatomy well. Now this is your internal auditory meatus. Inside the internal auditory meatus, you have the vestibular nerve, you have the cochlear nerve, superior vestibular, inferior vestibular, cochlear nerve, and you have the facial nerve plus the blood supply. The blood supply, the labyrinthine artery basically comes to the inner ear via your internal auditory meatus only. So now, if there is a space occupying lesion, what will happen is, if the space occupying lesion means there is a tumor here, growing tumor here, and most of the time when the tumor arises from the 8th cranial nerve, it basically arises from your vestibular nerve rather than your auditory nerve. It arises from the vestibular nerve most of the time, and that's why it is called as vestibular schwannomas. Now, it will depend upon, the symptoms will totally depend upon the size of the lesion, that is how big the tumor is basically, Now you can see that there is a small tumor there which is only compressing the vestibular nerve. Slowly if the tumor grows big, then it is going to compress the vestibular nerve plus the cochlear nerve. Further, if the tumor grows further big, then it will not only compress the cochlear nerve or the vestibular nerve, but also it is going to compress the facial nerve. It will also compress the blood supply, because the labyrinthine artery is going from here to the cochlear system. Okay? So, if the tumor is really big, as you can see here, if the tumor is really big, it will not only compress the nerves, but it will also compress the cerebellum and the brainstem structure. So, in the later part, when the tumor is really big, the patient can have many symptoms coming from the brainstem compression or the cerebellar compression. But initially when the tumor is growing, what will happen is individual will have a high frequency sensory neural hearing loss associated with tinnitus. Now high frequency hearing loss, why it will occur is, you have to understand this cochlea. If you just open the cochlea a bit, this is the basal structure and this is your apical structure. So your all the nerves which are in the high frequency range are outside, and which are there low frequency are inside. So the first nerve which will get compressed always is the high frequency fibers, and the low frequency fibers will get compressed at a later point of time. That's why what will happen is the hearing loss in the vestibular schwannomas will always just start from the higher frequencies, and later only the low frequencies are going to get involved. It is clear? At later part of the time, various symptoms like dysarthria, diplopia, the Bell's palsy because the facial nerve is got a lesion. Then there can be a case, there can be an incidence of sudden sensory neural hearing loss in the tumor cases, because what will happen is the labyrinthine artery which is here will also get compressed and blood supply will stop to the inner ear, and hence there can be an incidence of sudden sensory neural hearing loss cases in the vestibular schwannoma. Fine? Okay. So the next pathology related to the nerve, it's your demyelinating or axonal pathology. You know that this is the nerve and you have this cell body, and you have the myelin sheath over it, and you have this dendrites, and you have the terminal button. Now, in a neuron, when you look into, the pathology can be at the dendrites, the pathology can be in the axon, the pathology also can be in the cell body, the pathology also can be at the terminal button. There is no specific tool or there is no specific test that can tell you that where is the exact lesion in the nerve. Am I clear? So, what will happen is a lesion can be anywhere. But think of just a demyelinating condition, wherein demyelinating condition is the myelin sheath is basically missing from the nerve. When the myelin sheath is missing from the nerve, what will happen to the action potential?
So it will be
Action potential will become
decrease.
slow. The transmission will become slow because myelin sheath is responsible for faster conduction of your action potential. So what will get affected? Signal which aspect? Spectral or temporal? Temporal aspect of the signal will always get affected in the demyelinating condition. Okay. So if you look into this part now, what will happen is, if suppose that these are 30,000 nerve fibers of the auditory neuron, let us understand that, or 20,000 neurons of the vestibular nerve. If it is a normal system, there is no demyelinating condition, the action potential will be generated together, and what will happen is, if you measure a compound action potential like ABR or WAM or whatever it is, what will happen is the amplitude is going to be very large. Now, here if you look into this, there is a demyelinating condition. Now, demyelinating condition can be two types. One is that all the 20,000 vestibular nerves are demyelinated together, or what will happen is 10,000 are demyelinated and 10,000 are normal. Two things. So now, if all the 20,000s are demyelinated together, the latency of the action potential will be delayed, but the amplitude will be constant. Hence, what will happen is, only the latency there will be a delay, but the amplitude will remain same. That is, the timing will be affected, but the amplitude of the compound action potential is going to remain same. So overall, you will find that in the WAM or in the ABR latency, that ABR is fine, the amplitude looks fine, but only the latency is delayed. But there can be another condition wherein 10,000 nerve fibers are affected and another 10,000 nerve fibers are normal. In this, what will happen is, when you measure the compound action potential, the amplitude will get cancelled, because the action potential is happening at different point of the time, and when you sum together, it will get cancelled because of the phase delay. And hence, what will happen is, there will be reduced amplitude. So reduced amplitude will tell you that the demyelinating is in different characteristics in different nerve fibers. Now here, if you look into, this is your, when the axons itself are affected, when the axon will get affected, what will happen to the action potential? There will be a cutoff of the signal. There will be no transmission from the peripheral part to the central part, and hence what will happen is, only where there is some normal fibers, what will happen is some potential can be recorded there, otherwise there will be no action potential generated in the neuron. And if it is both combination of a demyelinating condition and axonal loss, there will be a complete loss of your compound action potential. So you cannot get the ABR, you cannot get the WAM, you cannot get anything else. Now, in cases of peripheral, demyelinating conditions such as your auditory neuropathy cases wherein you see, remember that, how many of you have seen auditory neuropathy cases? How many have seen presence of ABR in them? Okay, even if it is present, which peak you have seen? First. No, totally wrong. There is no first peak of ABR in cases with auditory neuropathy. You will always see broad wave 5. Remember that. So, if it is absent, 95% of the cases it is absent right from first peak, and that suggests that lesion is more peripheral and not lesion is not more central. So, it is confined to the Schwann cells basically, and hence your ABR will be completely absent from right from first peak to 5 peak. And what you see, what you are trying to see in the region of 1 to 2 milliseconds, that could be a cochlear microphonic. You should reverse the polarity of the stimulus and you should put an alternating stimulus. Record with 3, you will get any idea that whether that is a peak or whether that is a cochlear microphonics. So remember this is an issue of your Schwann cells and not the issue of the glial cells. And remember, ABR you have 5 peaks, First and second coming from the nerve, third coming from cochlear nucleus, fourth SOC and fifth coming from LL and IC. First and second peak are coming from the nerve fiber which are myelinated by your Schwann cells, and third, 4 and 5 are coming from the nerve fiber which is myelinated by your glial cells. Is it clear? And when the peaks are absent from wave 1, that suggests that pathology is more peripheral, that is from the Schwann cells itself. Next, nerve lesion which is infectious in nature, the vestibular nerve. Now vestibular nerve which is infectious in nature, basically it is vestibular neuritis what you speak about, and vestibular neuritis, when you look into the vestibular neuritis, it is caused because of one of the variant of herpes zoster virus. Herpes zoster virus is nothing but herpes zoster simplex basically. I am talking about the one which causes chicken pox. The one which causes chicken pox. A variant of that, you had COVID variation, no? Wave 1 you had different alpha, beta, delta, theta COVID. Okay, so you have different variation of the same herpes zoster simplex virus which can infect the vestibular nerve. And remember this, sir can explain this better, but what I have learned is that these viral infections, whichever virus is there, will have affinity to some structure. Something like the COVID will affect the lungs more compared to anything else. The herpes simplex virus which causes chicken pox will affect the trigeminal nerve more because you see the more rashes on the face because trigeminal nerve is involved. Here, the one variation which causes it affects the vestibular nerve particularly. And when it is affecting the vestibular nerve only, and if it is not affecting the cochlear nerve, the patient will have only vestibular symptoms and the patient will not have any kind of cochlear symptoms. No tinnitus, no hearing loss. The differentiating feature between a labyrinthitis and the neuritis is presence of tinnitus and hearing loss in labyrinthitis and absence of hearing loss and tinnitus in the vestibular neuritis. So, if the infection is there in superior vestibular nerve, it is superior vestibular nerve neuritis. If the infection is there in the inferior vestibular nerve, it is inferior vestibular nerve neuritis, and it could be a total neuritis of both superior as well as inferior vestibular nerve neuritis. And this you can get the information through CVM and OVM. When I am telling you it later, you will understand that how it is. And here most of the time, 90% of the time, it is superior vestibular nerve neuritis, and 10% of the time it is either inferior or a combination of.
So when there is vestibular neuritis, doesn't that infection affect cochlear?
No, it doesn't affect the cochlear. No, it doesn't affect the cochlear. I have no idea. I said, no, this virus are very this one, and they have affinity to some structures. They damage some structure more than other. Certain, probably from medical point of view, there is something happening. Okay, so that is the thing. Now, one of the most common pathology which you will see in the cases in the clinic is your vestibular migraine, very much growing. If I see today 10 patients with vestibular disorder, probably 5 or 6 I am seeing only vestibular migraine. Remaining is all VPPV, Meniere's disease or neuritis or labyrinthitis. But most of the cases are in today's time I have is vestibular migraine. Now vestibular migraine, now what is happening is it is a most common condition of spontaneous vertigo. That is, there is no triggering factor. There is nothing that is triggering any. Patient is sitting, watching television, one episode of vertigo is coming wherein the patient is feeling that everything is rotating around. That gets subsided after some time. It is a spontaneous vertigo. It is not a trigger vertigo. That is first thing. And can occur at any age, but rarely occurs after the age of 60 years. And females are more affected compared to males. And 30 to 50% of the children with vestibular symptoms have history of headache. That is, they have a case of vestibular migraine. Now, when you say vestibular migraine, basically, all these patients will have a history or a complaint of migraine at some point of time in life, and whoever has suffered from migraine, eventually most of them will have some episode of vertigo. Is it clear? So the first diagnosis is history of headache, and then comes the vestibular migraine at a later point of the time, wherein the person is going to experience the vertigo basically. and the vertigo can be very bad also, and one episode of vertigo in vestibular migraine can last up to 72 hours in a row. BPPV, the maximum duration of one episode of vertigo is 30 seconds. Mean SDG is few minutes to hours, but vestibular migraine it can go up to 72 hours in a row non-stop. It will go on continuing. And this vertigo will worsen during the stress, during the menstruation cycles in females, lack of sleep, and these patients can also report of positional vertigo, that whenever I am moving my head I am experiencing a vertigo. Now the question is that when they have positional vertigo, most of the time they may not have a BPPV condition. They might have just a positional vertigo. In the BPPV, the positional vertigo is very constant. Every time they will move the head, they will have vertigo. But vestibular migraine will tell you that 2 days I had the vertigo because of the head movement, another 2 days I didn't have. 1 day I had, another day I don't have. In a day, if I 4 times I am moving, 2 times I have, 2 times I don't have. But BPPV patient, every time they move the head, they will have the vertigo. That's another thing. And the most common, phonophobia, photophobia and osmophobia are very common. Phonophobia is nothing but irritation to the sound. Photophobia is irritation to the light. Most often they will tell you that whenever I get this headache or vertigo, I make the room completely dark and I just go and sleep. They don't want to see the light. This is what is your photophobia. Osmophobia is nothing but they have displeasure to some of the smells. They will say that agarbatti which I light for the puja, I don't want to smell that. Petrol, diesel, perfume, most common. I cannot take that. I enter into the bus, that smell I can't take. So they will have displeasure to some of the smells basically, and this is very common. And not only vertigo, many of the patients with vestibular migraine will also report of imbalance. They will not say that everything is spinning, but they might say that I have imbalance issues wherein if I stand I feel like I am going to fall down towards right side, or I feel like I am going to fall down backwards. So they might have imbalance also, and motion and nausea aggravated or provoked by the head movements, and patients do not get a proper sleep. Most of the migraine patient, if you take a case history, they will tell you that I don't get sleep. I will be there in the bed till 12 o'clock, 1 o'clock also, I don't get proper sleep. Even if I sleep, it is half sleep or no sleep. It is a very poor quality sleep which they will get. And visual disturbances, most common. They will tell you that if I just take the mobile and keep on scrolling the images, I feel like disturbing, I just close my mobile and keep. I am working on the computer, I am changing the pages, I feel that something is wrong with my eyes, so I don't do that. Whenever I am traveling, I am just using the mobile phone, I feel like vomiting, I don't want to use, I just close my eyes and sleep. These are the most common complaints which they will give you. And for vestibular migraine, some of the days are very good, some of the days are very bad. That means to say that some days the symptoms are very bad and some days the symptoms are fine with them. Okay, and this is one thing which I have started working upon, because every 10 patients I see, I have 5 to 6 patients only of vestibular migraine in the present scenario, wherein they will tell you that I have the history of headache plus vertigo plus etc., photophobia, etc. But you have to really elicit the response that what is that. If you ask every patient that do you have migraine, many of the people may not know that what is migraine. So you have to tell them whether they have a history of migraine, whether they suffer from headache, any kind of headache. Then they are going to tell you that yes, I have headache, or I had headache 5 years, 10 years back, and I am not experiencing, but during that time it used to happen. So I thank you for your patience listening. Me and this is
You look into many aspects, not only motions and ocular and vestibular, but we need to even check the viruses in that. Thank you so much, sir.
Thank you so much.
and I hope the audience also appreciated college. Had a special interest in complex airway surgery and contributed towards the establishment of cadaver-based advanced surgical skills lab at MS Ramaiah Medical College. He runs a 3-month mentored learning course in vertigo for ENT, urology and audiology production. Such simple person, look at him. But he is the one who initiates audiology.
In front of this gorgeous lady, everybody will look simple only.
So I will stick to clinical examination. Can you hear this? Or you want, is the audio better without the mic or with the mic?
Without mic also, you can hear both.
Without mic is better now. Can you hear me?
Yes, sir.
Okay, good. If you can't hear, then you need to go for hearing aids. We can get the clinical examination information that we can get. In vestibular practice, the most important thing is actually clinical history for the diagnosis. And then there are specific reasons why we require examination and investigations to seek out a certain kind of information. Okay, given that, let us just today stick to the topic, this session only about the examination. So I'll take you step by step. What are the examination things that you already know, what are the things that you should be learning, and we'll do this hands-on. So if a person is, if you're called to see a patient, which is not likely in the audiology vestibular clinic or the investigation setup, but if you're practicing in a hospital or anything, this is likely that you encounter. So to just start from the basic, if the person is wheeled in, okay, on a wheelchair, or the patient is brought to you, or you are asked to come to the bedside and see the patient for vertigo, what is the first investigation, first examination, clinical examination that you are supposed to do? Is the first question. Is that okay? If I'm in a hospital setup or something like that, patient is already in the bed, or patient comes to you in a wheelchair, they are pulled in. What is the first examination that you are supposed to do? Any guesses? What do you want to do?
Observation.
Observe
Okay, observation, everything is over. Next, he is conscious, he is talking to you, fine, next. Next. Examination.
Hearing from the patient.
Huh?
Hearing from the patient.
Yes, that's all done. You are hearing, you are talking to him, everything done. I want to drive home one particular point.
Eye movements.
Anything more?
Cerebellation.
Please write down here, bold letters. Make the patient stand up. Very, very critical. There was one question when Dr. Sunit was presenting, how will the patient present? Okay, what is that difference? Okay, if it is a lesion involving the cerebellum, brainstem, whatever it is, that person will not be able to stand. He will push. Even if he stands, he is going to be a pusher. Write down the term called pusher. Pusher versus a support seeker. A vestibular patient is a support seeker. A seeker of support. If you stand by you, next to you, vestibular patient will tell, sir, even if you give me little support, I will hold. And then that is enough to stabilize him. A person with a stroke is going to push against you. He tells it is going to push him towards. That is the kind of it. He is a pusher, P-U-S-H-E-R. Pusher is a person who has had a stroke. Okay? Very important part. So make the persons. Even the most severest, most acute vestibular attack, that is vestibular neuritis, complete, total vestibular neuritis, day one, today the patient is having, which is at the severest. At that time also, a pure vestibular neuritis patient will be able to stand, with eyes open and eyes closed, will be able to stand with eyes open and eyes closed with feet together also. They will be able to do it. Okay. See, they are so imbalanced. You feel that they are so imbalanced. Acute vestibular nystagmus is like beating like taka taka taka. All is happening. But and you think patient is protesting. No, I cannot. I am feeling so giddy. But you still make the person insist on making the person to stand up. Make the person stand up, and you will be surprised that despite that much of a subjective complaint, the person will be able to stand with eyes open and eyes closed on firm surface. Okay, this is the wherever you are.
Now that we have talked about examination skill as a, I can't see somebody here like this, behind the pillow. So if I can't see, principle is that light rays cannot reach me. You also cannot see me, correct? No? Why don't you move little this side? I think that works like that, no? Unless you have X-ray vision and I don't. You can come sit next to Uganda. That is, there is one more pillar. You are standing behind one more pillar. So that is the thing. Now that we have started about standing, so let us complete the standing, okay, so that we do in the examination, because these are the very, very important things in vestibular. I talked to you about, sir, your audio visual. My problem with my sessions, my camera persons is throughout school reunion. You know school reunion, no? 1992 batch, old man. Every other session they took photographs. Only my talk, no photograph. That fellow also was easy. What? No photos. No, he is also taking pictures. So next thing is the standing. We will do the next thing. Okay. These are simple things, no, nothing much to acquire. So in the standing, what we are supposed to do here is we are supposed to ask the person. Now this is usual in the clinic. Okay. You ask the person to stand up with feet together a little apart, comfortable stance. Ask the person to stand with eyes open. If in this position, I will give the interpretation from here on. If in this position the person is shaking, what is the diagnosis? Come to stand. You are the doctor. Okay, so no. See, he is the doctor. I am standing. I am doing this. Okay, come stand here. What is the diagnosis? Huh? This person is having conversion disorder, psychological. Where he is, on that side I am falling. I am not going to fall. He came on that side, I was about to go and I am going to take it. I am going to come and fall. That's all. He will. This kind of this thing where somebody, see, standing like this needs less balance or less involvement, or the pressure on our balance system is much less to stand like this versus standing like this. This is a pushpa dance, what sir told. That much you need to do all that and still not fall, which means the person's balance system is good. So this person's diagnosis will become conversion disorder. In the standing only so much is there, no? But if you do the same standing on a posturography system, even an acute vestibular neuritis patient also will be apparently stable, but on the posturography you will see the sway is much more than others, but they will not fall. Okay. But that sway is not this sway. Okay. The next thing is, if you ask the person is perfect. See, this goes through step by step, 1, 2, 3. Step 1 only that person is so shaky, don't go to the next step. Clinical setting. Okay, there only you get a diagnosis, forget about it, that's all, okay. Unless it is a very bad acute cerebellar event where even in the standing position they are all around going. But they are more of pushers, as I said, one side pushers, not going all around. This going all around the place, yet not falling. There is a term for it, it is called astasia, abasia. A-S-T-A-S-I-A hyphen A-B-A-S-I-A. Astasia, abasia. Astasia, abasia, if you get, you be sure. You are supposed to have 5 MCQs, no? If you get astasia and abasia, you can be sure that this particular person is actually having a conversion disorder. Conversion disorder also is used to be called a hysterical conversion disorder. That's a psychological form. Is that okay? It's a psychological. Conversion. C-O-N-V-E-R-S. Don't confuse with conversion. Conversion is fixed. Okay. How many wrote conversion? No, everybody was getting conversion. Okay, it's a conversion disorder. It's a psychological. Okay, it's a conversion disorder. Anybody who you make a diagnosis of a conversion disorder, after that, you just next, if the person is already married, you ask, how's their married life? They will know how this person can make a diagnosis at this level. Again and again, you will be right. The commonest condition, commonest cause of problem of conversion disorders is in married people is marital disorder. Okay. If it is not, then there are other pressures and all those things. They have put something else. They have done. They have seen. They have gone. They are going through other stressors. Maybe education. Maybe family is going through business. All those things in kids. But in married people, this is the problem. Okay, and this has happened. And it is across the society. From the poorest people who are living in one-roomed houses to IAS and IPS officers, I have seen conversion disorders. And universally so far, all conversion disorder is related to marriage.
So don't get married.
Huh?
So don't get married.
You want to become Prime Minister? Because one Prime Minister, one aspiring, eternally aspiring Prime Minister, both are not married.
You are not getting married pushes into that situation. Sometimes you are not getting married can push into that situation.
Okay. Then after that you got married.
No, I am only married.
So that is the first interpretation. And they come to the balance game. Okay. Whatever you do, ultimately you should be aware of these things. Okay. The next thing is, if the person passes the step 1, means if the person is quite stable and okay in the step 1, that is eyes open, okay, and with feet closed, on solid surface, then you proceed to the next step. Then you ask the person to close the eyes. If he passes, no problem, we'll go to the next step. But if the person fails in this step, and then they become shaky and then they are about to fall, what is the diagnosis? The diagnosis is, you know, to maintain proper balance. You have to understand, to maintain proper balance, what are all the things that are needed? What are all the things that are needed for maintenance of proper postural balance? If you are taking a self-driven car and driving that car, Tesla cars, what are all there in that self-driven car? Sensors. Then there are sensors to tell where is the obstacle, where is this thing, all that. Correct? Next one is motor. Excellent. Who said the motor? Super. Excellent. Get up. Stand up. Give her a claps. For sensor also. So sensors, motors. Then sensors and motors. In between them, there is a controller processor. Excellent. So there are sensor processors. In the human body, the controller is the nervous system. Okay, the brain. Okay, the brain. What has he said? Chinna medudu, peta medudu, everything put together is the controller. Okay, correct. Then sensors are.
Proprioception.
What are the 3 sensors? Vision. Hearing. Vision. No, for the balance. Vision, vestibular. Vision, vestibular, and proprioception. 3. Everywhere you are taught. Every lecture from first year when you joined vision, proprioception, again and again you are told, correct? Yes. Now you know what it is. Another 5 minutes you will know what it is. So vision is there, proprioception is there, and vestibular is there. Within that proprioception, as sir was telling, that proprioception can be from the cervical spine, it can be from the thoracic spine, it can be from the lower joints, all the places. Okay, joint positions. Basically, proprioception is joint positions and muscle Golgi apparatus. Tendon Golgi apparatus. How much is the how much is the pull on the muscle? Okay, that is what is there. And then the effectiveness of the proprioception is so much that you saw the video that he showed you of the this thing, no, of a bird which does this. That is cervical, entirely based on proprioceptive. Okay, how much the muscle gets stretched. Okay, that much is enough.
Okay, Golgi tendon apparatus. This is the thing. That is the proprioceptive input. Is that okay? And then we have the vestibular input. So there are the three sensors. Motor is motor nerves, muscles, joints. Is that okay? That's it. That is the motor. So these are the things. Now, in a person, now we have the broad overview. What are the broad overview? For a proper standing balance, we need sensors, motor and controller. Okay. First step only shakiness that you saw was controller, another type of issue, that is conversion disorder. There is another kind of controller problem that is like where when you challenge, they will fall. That's like tandem, okay, single step, those kind of things. That also I will show you later on. Next thing is, within these three sensors, all the three sensors are available means, again you can write down, three sensors are available means there is redundancy. What is redundancy? More than required. There is redundancy. English alphabet is supposed to be redundant. Why? You can remove the C and still spell every word. Correct. Receipt. Instead of writing R-E-C-E-I-T, you can C-E-I-P-T. You can write it as R-E-S-E-I-P-T. Still the sound will be the same. Instead of, you remove the C. Somebody wants to pronounce cat. Instead of C-A-T, you write K-A-T. Done. Which means C is redundant in English language. Which means one was, you can do without one, like that. So if you have all the three sensors, there is redundancy. Got it? There is redundancy. Which means you have more than required. Okay, generally. Okay. Especially for standing balance, this is redundancy. Now, if you remove one sensation, it is called sufficiency. If all the three are available, there is redundancy. You have more than required, so the person will be really standing well. You remove one, then there are two more available, there is sufficiency. So now, tell me the answer to the previous question. I told you something. Even a very bad vestibular neuritis, acute vestibular neuritis patient also can stand with eyes open like this. I told you. Correct? No? Yes. With eyes closed also they will stand with eyes open. They can stand well. Even if the vestibular nerve is fully gone, one side is fully gone, they can stand. How they can stand? Other two are there, sufficiencies. Okay. When only one is available, it becomes inadequacy. That is the time the imbalance settles in. If you challenge it. Okay, that is that. Okay. So that is how things happen. Is that fine?
So if only one system is available,
then it becomes insufficiency. Okay, insufficiency. Okay, but that also in insufficiency there are some people who respond differently. There are others who respond differently. But two is okay sufficiency. Okay, three is redundancy always. Okay, so now if a person with the eyes closed, the moment the person closes the eyes, a normal person now has what are all the senses that are available? Sufficiency? Yes. Correct. It is called sufficiency. Within that again there are grades of contribution. Vision has the highest contribution, proprioception has the next highest contribution, and vestibular system has the lowest contribution in a normal person. Vestibular system's contribution comes only when the other two fail actually for standing posture. Is that okay? So sometimes it is told, so in a normal person vestibular system is a of not, it's when it goes wrong, it troubles you more. Okay. So fine. So this is the. So now the next question is, what will happen if in this particular, when the eyes are closed, when the person starts shaking, vision is lost. If the person is shaking very much, okay, what is it likely to be? If he becomes very shaky, what is it likely to be? Vision you have removed. Of the other two, something else is also not there, no? Yes. Means there is insufficiency, correct? Yes. There is insufficiency, something else is not. And of the other two, through clinical experience, when it causes this much of instability on eyes closure, Okay, most likely it is the proprioception that is lost. That is the proprioception that is lost. Okay. To a certain extent, when the proprioception is available and vestibular system is lost, okay, unless the person is really challenged, they can still maintain the posture. Okay, it is in the, when they are challenged that they cannot maintain the posture, but when, with unchallenged, they will still be able to maintain the posture. Though it is only one sensation, it comes in insufficiency, but undisturbed, if you ask them to stand, this is how vestibular neuritis patient also will be able to stand, because proprioception can to certain extent take care. Is that fine? So of the insufficiencies, absence of proprioception is more punishing to the patient than absence of just the vestibular system. So that is, so the interpretation is step 1, eyes open if the person is shaky. In all around places, aesthesia, abasia, conversion disorder. Is that okay? But in the eyes open position only, the person is always pushing to one side consistently, then the person is most likely is to have had a stroke, the pusher that I told you. The support seeker is a vestibular patient, only pure vestibular deficit. The pusher is a person who had a stroke. Fine. Now on closure of the eyes, previously has passed, only on closure of the eyes if the person becomes shaky, the interpretation is the person has a proprioceptive deficit, also called as somatosensory deficit. Is that okay? Somatosensory deficit. Fine. Anybody who wants to practice vestibular system, vestibular sciences, anybody in your clinic, the first investment will be what? 128 Hz tuning fork. Second investment. Tell me. Will be a foam. Will be a foam. So you need a foam like this. Is that okay? So if the person passes the first 2 steps in standing, the person passes the, pass means he is not fallen. Is that okay? Next step is to make the person stand on the foam. Is that okay? Stand on the foam with eyes open. Okay, with the eyes open. If in this step the person shakes too much, all of us will be able to just stabilize. Anybody. Unless you are standing on this with heels and all, otherwise you can stand on foam or barefoot without any problem. Is that okay? So you should be able to stand. Anybody wants to try, you can try later on. Okay? But you will be able to stand. If on the foam with the eyes open, if the person becomes too shaky, then the person has developed something called as a maladaptation to vestibular deficit. Previously the person had a vestibular deficit. As a consequence to that, there are 2 main, very nicely known maladaptations. Sir can tell you many more. Okay, that is, one is surface dependence, another is visual dependence. Here, this person has developed something called as a surface dependence. What is surface dependence is, because of the vestibular deficit, they start hyper-tuning or over-tuning the proprioceptive input. So they start depending much more on the proprioceptive information rather than on the vision or trying to, so they over-tune it. So to that extent they have started becoming independent on proprioception. That now when the proprioception is no longer reliable, they start becoming very shaky. Is that okay? Why is proprioception not reliable here? I am a normal person. My proprioception is good. It means my proprioception is available or not available to the brain. From the joints, the position is, joint position sense is reaching the brain, but it is not reliable. Why it is not reliable? I will tell you a simple example. Look at this. You are standing on the firm surface. Now my joints are 90 degrees. Okay. 90-degree joint position means palm and this one. Correct? No. 90 degrees. What does it mean? That I am straight. If it is an acute angle, what does it mean? I am bending forward or falling forward. If it's an obtuse angle, what does it mean?
I am falling backwards, leaning backwards or falling. Correct, no? Exactly. So there is a clear-cut correspondence between my position or my posture or my stance and or my stability and the joint angle. Is that right? Just to take one joint example, that's all. There are so many things that happen. One joint example. If I stand on top of this, is that reliability there? No? Now it is acute angle, but I am still. It's a soft surface. So the acute angle actually tells the brain that I am falling forward. From my birth, whenever that acute angle has happened on the normal thing, it was only happening when I was falling forward or when I am leaning forward. Now that is happening, but I am not actually falling forward. Is that right? So proprioception is available but not reliable. When it is not reliable, a surface-dependent person starts becoming shaky at this stage. So the diagnosis at this stage will be surface dependence. Is that okay? Now, what is the next step in the standing?
Close. Eyes. Close.
Yes, eyes closed. Now, you want to see what sleep deprivation causes? I call Sujit sir and make him do. Okay. Now on top of this, you make this and ask the person to close the eyes. Fine. You ask the person to close the eyes, and the person should be able to maintain the posture. Everybody becomes shaky in this. Everybody. Unless you have trained for multiple years, everybody will shake. Okay, including Allu Arjun will shake, okay? Allu Arjun may shake like this, that's okay. Okay. But everybody will shake, okay? But if you fall in this step, and that's it, you definitely have a vestibular deficit. Okay, this is the interpretation, 4-step interpretation. You know, no? Step 1, step 2, step 3, step 4. Correct? You have a vestibular deficit.
So
if you
keeping hands this way,
it's always better. See, there is another test called clinical test of sensory integration of balance, in which the person is asked to do this. Even this one is considered as fail, because the person feels that he is unstable, and this is considered as fail. So a stable person is supposed to hold it on like this. Okay, for 30 seconds you are supposed to. I'll show you something. Sujit sir, come. You did not sleep last night. No, come. Come, sir. Close your eyes. This sleep deprivation actually causes this front-back sway. You can see this better on a posturography. I can see he is swaying front and back and front and back like that. Okay. Yes, sir. Thank you, sir. Maybe today also I will not allow him to sleep. Tomorrow I will show you on the. So this one. But actually he is very stable.
Actually, doing the VIP for many patients.
Yeah, so that's why you are very stable. So you are not a good candidate for this demonstration. So sleep deprived people do this. Okay, the front back sway. So in that there are other patterns. How many tests we did? We made the person stand. In the standing, so much information is there. Correct, huh? We used to make diagnosis those days in surgery wards. Patient will come like this and ask him to stand and sit on the stool. If he sits properly, one diagnosis is excluded. If he sits on one bum, there only we make a diagnosis of piles. It is like that. See, the observation has so much to do just in walking, standing and all those things. Somebody is brought to the OPD like this. Tetanus, we used to make a diagnosis from there only. Correct, no? But it is like that. There is so much there in the observation. Sherlock Holmes was actually written based out of a doctor story, how a doctor would make a diagnosis. And all of us are done in this investigation. Okay.
It's about teasing out little small bits of information, putting it in the context, and you get the diagnosis. It's like that. People will tell artificial intelligence that, this, and all those things. Next 20 years, don't worry. Okay. Till that. AI, generative models, all those things. I work more than anybody else. I'm a first rank holder in data science. Okay. So to that extent, I am telling you, AI will not disturb your jobs for next 20 years, at least in the diagnostic domain. Okay. Because it is clinician interpretation. The clinician story nobody can. If you put the correct story to the AI algorithm, it will give. But who will get the correct story? There is where the clinician is. Getting the correct story. Patient will come and tell, I lost my consciousness. Afterwards, you ask the story. Your patient lost consciousness. Patient is telling, I lost consciousness to tell that I am really tired. AI algorithm will not know that, no. It will tell loss of consciousness means, okay, viral encephalitis, that is good. Correct. So it is like that. So this is about the first thing that you are supposed to do to investigate. Standing. Next clinical examination that all of us you should master is tuning fork test. Not the audiology tuning fork test. There are two vestibular tuning fork tests. One is using 128 Hz tuning fork. Second one is 512 Hz tuning fork. Both of them, you just go to the opposite end to place the tuning fork. You are only all the time dealing with head, no. Once in a while, you have to go down. There is a prominence called malleolus here. There's a prominence called malleolus. Correct, no? That's the bony prominence. Okay, malleolus. On the bony prominence, what you are supposed to do? Just take a 512 Hz tuning fork and keep it. If the person tells, I can hear the sound, vibrating tuning fork, okay. Because if an examiner is listening to me who did not tell vibrating, correct, no? Yes. So vibrating tuning fork, you keep it. If the person hears that sound from that far, the person has a semicircular canal dehiscence. Hear the sound. If he hears the sound, he has a superior semicircular canal dehiscence. That's a clinical test. Okay. If he hears, if he does not hear, it is not that it is ruled out. But if he hears, it is very, very likely suggested. It is called malleolus sign. Malleolus sign. SIGN sign. Malleolus sign. Is that okay? You have to tell me when my time gets over. You have to tell me, otherwise problem. Okay. Morning I was supposed, I kept the alarm for 3 o'clock. 2:45. I kept the alarm at 2:45. Alarm rang. My wife switched off the alarm and slept off. 3:03. I simply think, by now it should have been time to get up. But I thought, okay, no. Alarm will ring, no. I am simply imagining. Then I thought, okay, at least when it rings at 2:45, I will snooze for 15 minutes. For that sake, I will bring the phone and keep it next to me. I went, already 3:03. I know Sujit sir had already reached Bangalore, overnight full. Next thing is, 512 Hz is over. Next tuning fork I told you is 128 Hz tuning fork. What will this tell? Honestly tell me who has 128 in your clinic. She is raising her hand as if to tell yes, then suddenly tell you. So it is not there. So please buy the 128 Hz tuning fork. The reason is that's a beautiful test to test for vibration sense. Again place the same tuning fork there only. Okay, and see whether the person can feel the vibration. People will tell, another clinical tip I will tell you, people will tell, I can feel the vibration. Because vibration can be imagined. Ask them to close the eyes, once with vibrating tuning fork, once without vibrating, you ask him, can you, yes, no, you bang it, then you step it. that means that person is not knowing the vibration. Simple. Person who is able to feel the vibration will clearly tell you this thing. If the person does not have any edema, edema means, you know, no? Swelling will be there. You can feel the bone on the skin. And if that person cannot feel the vibration, there only you make a diagnosis of large fiber neuropathy and send the patient to the neurologist. Just imagine an audiology professional making a diagnosis of large fiber neuropathy, sending to neurologist. The neurologist will get unconscious there. Send him with one water bottle, because after reading this he will fall. You tell the patient you put little water on top of it, make him get up. Correct, no? But this is all about not clinical. Why? Again, this is another group of patients who is coming with what? Balance issues. Okay. And the way to diagnose this thing is all getting recorded. Don't put it in YouTube. That is okay. Fine. So what will happen is, so that is one.
Sir, you can hear in both ears or one ear?
That is previous sections. Last night you didn't sleep. See, what happened is, we were discussing about 5 to alerts tuning fork. That story got over.
No, 128.
5 to alerts tuning fork was for superior semicircular canal dehiscence. Then after that half an hour passed, 120. that half an hour gap is there in your memory, correct now?
Yes, sir.
Look at your watch now. Half an hour is not there. That is because of sleep deprivation. I will tell you what all sleep deprivation can cause. It's really, so sleep well. Okay? Not now. So 128 Hertz tuning fork will make a diagnosis of sensory neuropathy. That is, what it causes? Again, somatosensory loss or proprioceptive loss. So what else you will see? A person with eyes open, eyes closed. Here also he becomes more shaky. Also he is not having. These are the people who will tell, I feel like I'm walking on a cushion. These kind of stories they will tell. They can't feel the legs, these things. Just make this habit, these small investigations, and start seeing magic that is happening. Okay, these two things. About the tuning fork. So first equipment you are going to buy is tuning fork. Second equipment you are going to buy is See, I make costly equipment, but I am asking you to buy such low cost ones. Because information is there. Once you start loving it, then you will only buy the costly equipment. Correct, no? The next thing here is, third equipment that I want you to buy is a stethoscope and a BP apparatus. How many of you can check blood pressure? How many of you can take the pulse of somebody? Raise your hands. 1, 2, 3. Now I will tell you, each one of you have to learn how to take the pulse, how to take the blood pressure, buy a good quality mercury BP apparatus and a good quality stethoscope. They are not very costly. A few thousand rupees you get good ones. Don't think I am an audiology professional, I should not learn this. Okay? Even grama volunteers are there, no? They are also learning. Correct, no? They are also learning. So this much you should be able to do. At least for your grandmother, I will only check my blood pressure. She will be happy. Correct, no? Correct, no? How many of you are married? Everybody are. Everybody. What is wrong? Once again, raise your hands. Almost everybody. That is why the happiness is not that much here. So, next thing is, you learn BP. Very important. In a balanced clinic, we run this course. The biggest satisfaction that I get out of this 3-month course that we run, Adam has done, and who else has done? How many of you have done the course here? You have done, who else has done? The 3 months course. Okay. So, how many of you? The biggest satisfaction that I get out of this course is when people call me and tell, today I made this diagnosis, today I made this diagnosis, today I made this diagnosis. Somebody who had never done a positional test will do. Best part is I am getting now calls from audiology professionals. I am making this new diagnosis. I am going to teach you the diagnosis right now. That comes with blood pressure. Lot of imbalanced patients, okay, the significant group of these imbalanced patients, okay, especially chronically imbalanced, daily, all the time imbalanced patients, actually have a condition called orthostatic hypotension. Orthostatic hypotension. The extent to which it is not recognized, some of these people have been going from pillar to post for 3 years, 4 years without a diagnosis, because when they go to the hospital, any reasonable hospital, any hospital, they will take the blood pressure and pulse. Correct? No? And that blood pressure and pulse will be normal. If it is normal, they think it's normal. Correct, because they are not searching for a condition called orthostatic hypotension. Orthostatic hypotension is not one blood pressure reading. You have to make the person lie down without disturbing. During that lying down, okay, in a case he is lying down, now 10 minutes of lying down is there. I will tell you what happened. The thing is, you have to lie down for 10 minutes. After having lied down for 10 minutes, take the blood pressure. If the blood pressure is 180 by 120, the person, then you have to make the person to sit up or stand up actually. After standing up, again repeat the blood pressure measurement. Now it becomes 140 by 100. What do you think? What is the normal blood pressure? 120 by 80, no? 140 by 80, 100 is hypertension. But previous blood pressure was how much? In the sleeping position, lying down position?
180 by 100.
So compared to 180, it has become 140. Systolic has fallen by 40. Systolic fall by 20 itself is considered as orthostatic hypotension. You are getting the idea what I am trying to tell? And what I am trying to tell is, it is not the absolute value, it is the relative drop that gives the diagnosis. Lot of time, actual also drop will be there below the thing, but this is the drop. That happens orthostatic hypotension in an elderly patient. If a 30-year-old, a 25-year-old, 28-year-old girl comes, and if the BP falls tuck, previous BP is lying down position was like 120 by 80 or 120 by 70. On standing, it goes to 90 by 60 or 80 by 30. If it is a young lady, it is a missed abortion or something. She is bleeding internally. That is what is happening. Or it is like a ectopic rupture, something like that. Rarely some of them without pain abdomen also it will come. You have to. Elderly person comes and then it is falling suddenly. It is orthostatic. Clinically also you can make a differentiation that pulse rate increases if the person is bleeding internally. In orthostatic hypotension, pulse rate will not increase more than 20. Is that okay? You remember this? So what is your next equipment you are going to buy for physical examination? Stethoscope and you are going to learn. Just any YouTube, how to take the pulse, how to take the blood pressure, that's all. 5 minutes I can teach you. How many of you actually felt a pulse so far? So what you are supposed to do, this is the thumb, no? From this side you come like this, okay? From this side, thumb side, back. Okay, and then fold the fingers up like this. Here this bone is there. Just hold the fingers like this. That's all, here. Lightly press on the bone. You will start feeling your pulse. How many of you could? That's all. Over, magic. How much you paid for them? Vasool. Correct. If you felt the pulse, then same thing. Depending on the pulse, you will take the blood pressure. You have to go little up. Bias pygmometer. Why I am telling bias pygmomanometer, bias pygmomanometer? Everybody started thinking, why this fellow is telling? Medical store that home run is there, no? My grandfather is using, my father is using. How many got that idea? One automatic BP apparatus is there, no? You know, no? You can buy one automatic BP apparatus, no? Why this fellow is?
How many of you got it? Honestly. How many of you got that idea?
I think most of them had it already.
You already have it, I will use it, I will not buy it, correct? No? Why break my, how many of you that I will go home and start doing it? The margin of error in those systems is beyond the margin that we need for diagnosis. We are looking for 20 drop, there the margin of error is 20 or more. Like our psephologists, 400 plus for Modi. Correct, no? That is like that. That is the margin of error. With that amount of margin of error, your difficulty 200 plus because of Babu, government formed third time. Correct, no? Because of Andhra Pradesh only this time government has formed. Otherwise, no. So Andhra is saving the country and Andhra. Correct, no? Pat your shoulders. No. You don't want to pat your shoulders. Correct, no? Pawan Kalyan. Gabbar Singh. I love Gabbar Singh. Next thing is, so margin of error is there, so you learn to take the. Is that okay? You will do that. How many of you are hungry now? Akalestunda?
Sir, for orthostatic hypotension, how much time the person should be on the...
So this is the next protocol I am going to take. So lying down for 10 minutes. Now what happened? I introduced this protocol, lying down for 10 minutes. What this person simply lying down, I will waste that, why should waste that lying down 10 minutes? Somebody will do, okay, we will do Bera now, ABR in that lying down time, finish it off. We will do one web during that lying down time. No, it has to be undisturbed lying down for 10 minutes. Okay, fine, undisturbed. That is the option. Then you make the person to stand up.
Immediately after standing?
Immediately after standing, you take, then at 3 minutes, at 5 minutes, at 7 minutes. There is one condition called very early orthostatic hypotension, in which case the BP becomes normal within 1 minute. Then you will miss it. So what I do to pick up those patients is, when taking the BP apparatus, there is something called inflating the cuff and deflating the cuff. I do the inflation of the cuff when the person is lying down, and then make him get up. And when the mercury column is going down, I check them. Okay, so you have to learn that. Okay, this is one extra skill I want all of you to learn. Other things are simple. Tuning fork, you have been only thing I change the end from up and top end to bottom. That's all you have to come back. So once in a while. Is that okay? Okay. That is it. So that is the next thing is what? So many. What is the next investigation you are supposed to do? Next physical examination that you are supposed to do after so much? Huh?
Walking.
That will come later. Okay. Next. Look at the eyes now. Okay. Look at the eyes and see for the presence of any mistakeness. See for the presence of any mistakeness. At this point of time, all of you should start investing on a goggle called Frenzel goggle. A Frenzel goggle is a 20 plus 20 diopter lens. If anybody wants that, when we place order for the next batch, I will give you this thing. I will send the link to both Madam and Gopi. Okay, so she will share it with you so that you can place an order for it. It's hardly 5,000 rupees or something like that. You will get this thing. What is it, Frenzel goggle? Sarla Madam has. Madam, okay, Frenzel goggle. She has the Frenzel goggle. So basically, it's a 20 plus 20 diopter lens. What it tells is it removes the fixation of the person. Okay, it removes the fixation. Madam, you play call, Linko. You are sitting, suddenly you got up and then. Can you go on for another 1 hour?
Yes.
Okay, no? How many of you raise your hands for the next 1 hour? Who are extra speaker?
Actually, sir is doing great job in history as well.
No. I will give you the. So the next thing is, where were you? Frenzel. So next thing is you are supposed to look at the mistakeness. Sir explained the mistakeness to you. So eye oscillation is nystagmus. Oscillation of the eyes is nystagmus. If eye oscillates to one side, like as if it is beating somebody and coming, beating and coming, beating and coming, it is called jerk nystagmus. The meaning of jerk nystagmus is, write it down. Meaning of jerk nystagmus is in an undisturbed, unprovoked jerk nystagmus. Means if the person is sitting without disturbance, and then you are able to see the jerk nystagmus, the meaning is there is a vestibular asymmetry. That's all it is. Jerk nystagmus is equal to vestibular asymmetry. If the person, if you can see a nystagmus, jerk nystagmus, jerk, if you can see that nystagmus, when the person's eyes are open like this in a normal lighted room, it is severe vestibular asymmetry. Is that okay? It is. Huh? No matter which direction it is. There is, I mean, it will be right beating or left beating. I am talking about that one, with a torsional component, with a little bit of vertical component. So if you see that, that means meaning of a jerk nystagmus is underlying pathological meaning is there is a vestibular asymmetry. What is the meaning of vestibular asymmetry? Either one nerve or one ear, one side is either less or the other side is getting irritated. In a normal person, I am removing the, I am telling in the lying down normal standing position, okay, in the standing, not in the provoked position. In the positional test also it can come, that's a different story. So this one it comes in. So meaning of jerk nystagmus, the primary position in jerk nystagmus is vestibular asymmetry. Primary position means center position. Okay. The next thing you are supposed to see is if you don't see nystagmus here, if you see nystagmus here, there only severe vestibular asymmetry at that time. Otherwise, what you do, you make the person wear the goggles. If at that time you see the nystagmus, it is moderate vestibular asymmetry. It is moderate vestibular asymmetry. Then also you don't see any nystagmus. Then you do something called, why I am coming to all this thing? We are doing clinical examination. Correct? Now all the clinical examination techniques we have to learn. I need a volunteer. Hungry volunteer on the stage. Who's going to come? Camera person is coming. Volunteer. Gopi. Madam, come. So next thing what you are supposed to see is, if the second step also no nystagmus is seen, then what you do, you hold the person like this, head like this. So do this with the Frenzel goggle on. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. Okay? And look at the eyes. If now you see, only now if a new nystagmus comes, it is mild vestibular asymmetry. See, if the first step also the nystagmus was there, here also the nystagmus will be even more. That don't call it as mild. First, with vision allowed, no nystagmus. On wearing the Frenzel goggle, no nystagmus. Third step only nystagmus, then you call it as mild vestibular asymmetry. Is that okay? This is clinically grading the nystagmus. Clinically severity. With eyes open, with vision allowed, what is the grade of, if you see a nystagmus, it is severe. Otherwise, only on Frenzel goggle only it appears. On removal of fixation it is moderate. On removal of fixation also it is not there, only on head shaking test it appears, it is mild vestibular asymmetry. Is that okay? Yeah. Close your eyes. Close your eyes. See, she is quite stable now. Yeah. Open your eyes. Close your eyes. They're closed. Pass. Super. Yoga. Sometimes yoga.
So what is the name of this procedure?
Which procedure? Head shaking test, that's what I mean. Head shaking. That's simple. I don't like all the big names and all. Head shaking test over. Malleolus, we are touching malleolus side. Simple. Shaking right, I am calling it head shaking test. That's all. That is the head shaking test. This much is over now. Next to last 2 vestibular tests I will show, because otherwise madam will shoot me.
What's the degree in this?
Huh?
Severe, moderate, mild over. In this case, what would
No, this I wanted to see your stability. Some people, if you have vestibular asymmetry, I can't ask open a eyes. Because the moment I open a eyes, it's not like putting the frenzel cover. So I was trying to see if there is a vestibular asymmetry, should have fallen to one side. You want to? Okay. So that is what I'm just trying to see whether she will fall. That's the indirect evidence. That's mild asymmetry. After a check, she would have fallen. She didn't fall. So that is it. That's why I told you you're doing yoga. Super. Congratulations. You should give claps. Nobody claps. Next one is another 2 investigations. I will do a clinical examination. There are more, so many, but most relevant. One more thing is after head shaking test, it has to be done with. Without also you will see some mistakes, but it is better to do it. Is everybody able to hear me? My voice went up.
No, we can hear.
The next thing in clinical examination skill, I want you to practice on. Is that okay?
Practice on?
This one is called head impulse test. It's a clinical head impulse test. Once you get the understanding of clinical head impulse test properly, then you will understand. Then you will understand instrumental head impulse test. Sir was talking about head impulse test. Okay. I need one volunteer, and I want all of you to face one another. Turn the chairs like this, face one another. Okay. But one volunteer, come. Sir has come. So how you do head impulse test is the classic way the head impulse test is taught, and I used to do. I will show first. Next I will show you how I am doing now. Then I will give the reasons. Okay. I will give the reasons during the lunch time. Okay. Because otherwise time is over. So what you have to hold the head like this. Ask the person to look straight. Is that okay? Ask the person to look straight. Now, first you check once how much is the neckline. Sir, ikkade chustunda. Somebody significant here. So now hold like this. And suddenly and it has to, he has to remain fixed. Okay. And then you go like this. Okay. This is the new way I am doing. Previously I used to do like this. I used to go from like here and I do like this. Okay. Okay. So, and then ask the person to look like this. Now I will give the explanation. Later on I will share one video. That's a commercial video for our FIT device, but that also explains FIT nicely, anything. So what it is what is the purpose of vestibulo-ocular reflex? Tell me.
Coordination between.
Why?
To stabilize eye.
Why? Excellent. Super. Huh? So the purpose of the semicircular canals is vision in motion. When you are moving around, to give you a good quality vision is the purpose of semicircular canals, main purpose. Perceptual purpose, all those things are next. But here it's extraordinary, to move the eyes. What is the movement of the eye? What does it do when the person is looking straight like this? If the vision, eye has to remain fixed on that. Why? In the retina. In the eye there is a retina. Retina is like a big movie screen. In that big movie screen, I forgot about looking at the time. In the big movie screen, like that is the retina. So a full thing image is forming on the retina. But there is one central area called the fovea. The best vision is only of the object that falls on the fovea. If you are looking, look at one another. Look at one another. See one another's face. If you are looking at the right eye of the person, can you see the left eye clearly? You can't. If you are looking at the nose of the person, you can't look at the lips correctly. Full expert, huh? You can't. See, try. Try that. I want all of you to see that.
Yes.
Correct, no? See, look at the right eye of the other person. If you want to see what is happening to the left eye of that person, you have to shift your gaze. The brain is fooling you into thinking that you have a clear vision of the entire world. Is that okay? But if I have to look at Gopi, if I have to see what, I can get an idea Gopi is moving or not moving from here. But if I have to see, cleanly appreciate the handsome Gopi, I have to look like this. I have to look my eyes have to go there. Is that okay? Otherwise it is not, I can't see. Because I have to foveate that person. So clarity of vision is foveation. Vestibular reflex function is foveation. The instruction that I gave him is foveate on the tip of my nose or on the brow, between the brows. Correct? That is the instruction. If his vestibular reflex is working on the right side, when I make a fast movement to the right, he should still maintain the position when the head is moving. If he has maintained the position when the head is moving, in the beginning, eye starts in the center. By the time the head movement has stopped, the eye ends in the corner. If the eye has not ended in the corner, if eye goes like this, then it will come to the corner after the head has stopped. Started in the center, ended in the center, then came to the corner. That is impaired head impulse. Remember this, that is all, because head impulse interpretation is very difficult if you are not looking for these points. When you do a head impulse test, or if you do the other technique which I am doing, now I start off from this eccentric position. Now eye is in the corner. When I do this, I should have come to the center. The eye remained in the corner and then I can notice that it has come back. Other way of looking at it is, head stopped, eye should have stopped. After the head stopped, if the eye moved, that means head impulse is impaired. Head stopped, eye stopped, means what? When the head was moving, eye was moving correctly. Head was moving to the right, eye was moving to the left. Is that okay? Now the advantage of start from here and do this. Start from here and do this versus start from the center and go to this side. There is one disadvantage of starting from the center and doing to this, which all my life I used to do. But the only problem here is, even if the person has something called as a grade 1 nystagmus, on one eccentricity, that is when it goes like this, eye comes here, the nystagmus starts beating, that will give me a false impression that there was a corrective saccade. But if you start from side and come here, it will come to the center. In the center, grade 1 nystagmus will not disturb, only grade 2 is good. Correct? No? That is the only advantage of starting from the eccentric position. Second thing is, when you start from the eccentric, you know how much the head movement. If you are in the beginning stage, you hold like this, and you want to make the head movement to one side. From starting position, you do full like this, or full like this. Third time, sir, take the head. No. So you should not do that. So start from here, you know how much you have got, and you come only to the center. Is that okay? Next thing is about isolating one ear. Both ears are responding to horizontal movement, right side also, left side also, sir told in the morning. One with excitation, another with inhibition. You have to check only the right side, means you have to make the head movement fast. If you make it slow, both ears will respond. Then you can't make it a test of one ear. So what you are supposed to do, hold it like this. I am holding it to the left, so look here, and do this. Which ear I have tested? Right ear. Right word movement. Word is important. W-A-R-D word. Right word is important. Is that correct? Right word. That is more important. Not right or left. Started off from the left. So from here also, if you go to the right side only you are testing. From here, if you go to the right also, right side only you are testing. Is that okay? This skill is an acquired skill, because some girls, full strong, I ask them to do slow, full effort. Like, no, I will show you, now only I will show you, don't think. It has to be really, okay? That fast it has to be, that jerk it has to be like that. Is that okay? Now, face one another, learn this. You learned one skill today, who all were not taking pulse today came to know how to take the pulse. Correct? No? How many of you really felt the pulse today? Who did not feel? Who did not feel? Sir, why? You come from admin department, you participate. Feel James, sir. Please, 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 please. See, that is why light should be there. That one corner you did not see, Lakshmi Mani. Akka lights very. Correct, no? Sir, you come, sir. Come, come, come. Come, friend. There are chairs here, please come. What is it? Come, Gopi Garu. Ask sir to come, friend. Do heading pulse test on. So please face one another now. Let us learn how to do the heading pulse. I will correct if there are mistakes. If it is right, we will do it right. Then one last thing I will teach, and then I will apologize to Yugandhar sir for taking his time. Then we go for lunch. Okay. Turn. Turn, 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 turn. You can see your eyes? Beautiful eyes, all of you. You like your eyes? Yes. Fine. Good. Now what you do, don't look at the camera, don't look at your eyes, look beyond, same level. And switch on the recording, okay? Look beyond, don't look at here, look beyond, switch on the recording and go one round. And stop. Okay? Play that answer. Meeting mistake was if you go to left, it will left meeting mistake. Selfie camera, look at the beyond and do, you will get what? Mistake. All of you saw your own mistake was? Yes. Who all did not see? Did not see. Come here. Right now I gave certification to Yogi and all. Put the selfie camera. Look at your. Look at the walls. Look at the wall. Go one round. Go one round. Look at the wall. Don't look at the camera. Your camera is just another. Look to back side. No. Look. Now you. All of you do that. Everybody saw your own mistake, was right? Everybody. Fine. Okay. Now, if you make one round, and when you stop, the moment you stop, I am rubbing for 15 minutes, getting the potentials and all that thing. If I can get some information just by rotating the see. Impedance not matching, This new fellow has come, he is not rubbing correctly, skin preparation not correct.
We can't give that report saying that I asked them to put a camera.
Next I want you to do next now. You know what? Again selfie camera. Stand up. Now you look at the camera and do one. Get mistake. Must. It's a cerebellar floccular problem which can happen even in migraine patients. This is vestibular reflex suppression test, it is called. VOR suppression test. It is called VOR suppression test. Means your brain is able to switch on and switch off the vestibular reflex. The first time when you went round, the nystagmus that was generated was actually VOR, vestibular reflex. It came from the VOR. It's a gaze stabilizing VOR. Is that okay? Fine. It was a gaze stabilizing VOR. Because of that. In the second round, when you were looking at the camera, the head was moving now. First also it was moving, second also it was moving. First head movement also. Where is Yugandhar sir? That one. Then also the fluid was moving in the semicircular canals. Second time also the fluid was moving in the semicircular canals. You saw now that, you remember that one, no? Correct. When the fluid moves, action potential is generated, message is going to the semicircular canal in, it's a dual image. He likes this. Okay. So when he moved in the beginning also, he's made a very nice, I think he has made it.
I purchased it.
You purchased
Not
it.
a patient.
Okay, okay. So when he moved, how does this pipe know whether he's looking at the camera or looking at the wall? It does not know. Is that correct? So when he turned in the beginning also that pipe, these things moved. Second time also it moved. But one time that message went to the eye. The second time the message did not go to the eye. Don't send this message to the eye. I am concentrating on something that is moving with me. My phone is with me. I have to look at the phone and then do. Don't send this message to the eye. Suppress this message. Don't send this information to the eye. Who is telling that? Cerebellar flocculus is telling that. If that is not being sent, the person gets nystagmus even when looking at the camera. That happens with flocculus dysfunction. Flocculus dysfunction can happen in floccular lesions, actual structural floccular lesions, or even in migraine patients sometimes you see during an episode. Is that okay? What you are making diagnosis suddenly no. You know all the structures are shown, no. Now you are able to make a diagnosis also, no. Superb, no. Enough, or you want more investigation, more clinical exam?
No.
Sure.
Subject for the parameters management.
There is no
They are
parameter.
not operating.
No, complete the thing. That is rapid alternating movement. If they make a mistake, cerebellar. They are able to do it correctly, no problem. 1, 2, 2. Like this, it's a cerebellar problem. Is that right? If they make a mistake. Then you know the finger nose test. That also they are supposed to do. If they become shaky, as it comes closer, they become more shaky, cerebellar. Is that okay? This is finger nose test. Okay? Okay? Next thing. One new test I am going to show you. That one is rapid repetitive movement. This was rapid alternating movement. This is rapid repetitive movement. If the person can do it symmetrically, then you can be sure the person does not have Parkinsonian features. Parkinson's patient, one will be doing, other will become small. Okay? Asymmetric. Is that okay? And one will start becoming smaller and smaller and smaller. One will be doing big, this will become small. I can't even mimic and show to that extent. Okay? So that is evidence for Parkinson's. Okay, that is one examination that you can do for Parkinson's, other than noticing a resting tremor in a person. He is sitting like this, one hand only, doing this, only one hand. In the road also, in the bus stand also, he makes this diagnosis from now on. Because if you are walking in the bus stand, somebody is sitting, one person is sitting, one elderly gentleman is sitting, only one hand is doing. Next time, you know what is the diagnosis? It's like that. Then go and ask him, do this and show. I will do it. Correct, no? That is how it is. This subject is like that. Now, once you become passionate, once we started learning about rhinoplasty, previously we used to look at a girl and like, so beautiful. After learning rhinoplasty in ENT, beautiful girl also said, this could have been little like this. This is the problem. Correct, no? So that's it. This is all. You have written down everything? Yes. What are you going to buy? 128 Hz tuning fork? You are going to make one foam made? Stethoscope and BPM apparatus. Learn how to do it. This month you start doing it. This month you start doing it and this conquer the world. Thank you all.
I'm sorry to stop you actually. They were so interested and they wanted to know more and more from you. But because of time restrictions and the next speaker, can we go for lunch or you want the next speaker?
After lunch.
After lunch, yeah.
Now lunch, ma'am. Now lunch.
Thank you.
Wait.
You ready?
So light on. Okay. Yeah, Jason.
So this is right after lunch, and I should be very careful, making sure that you don't sleep on me. Okay, so before I start about the importance of case history, I do want to prove 2 points. So not to be commercial, but I'm just going to show you this case history form and see how it can actually help us and what are the points that we can actually take to improve ourselves and make ourselves comfortable and confident in diagnosing the vestibular issues. So this is just a form, just follow me. So I need attention from all of you. So these are the different symptoms, right? Consider that this is one of the questions that you're going to ask your clients. So before that, let me ask, how many of you are taking case histories or how many of you are seeing vestibular clients as of now? Even 1 or 2? At least 1 or 2? Yes. Yeah, I see good number of hands. So, do you ever ask such questions like, my dizziness is intense but only lasts for seconds to minutes? This is one of the common questions, right? We ask like, you have dizziness or vertigo or how long does it last? So let's say we go with one of the conditions. I'm a patient, I'm just going to choose my symptoms. So my dizziness is intense but only lasts for seconds to minutes. I would say never. And this is another question. Like you as a clinician asking client, had a spell of spinning dizziness that lasted for days or weeks after a cold or flu. This doesn't apply to me. I'm unsure of my footing when I walk outside. This doesn't apply to me. It said no. And I get dizzy when I turn over in bed. It says that yes. I get dizzy when I'm in open spaces and have nothing to hold on to. I'm a patient. I say, when you ask me this question, I would say no. And I have a rolling sound in 1 ear only before or during a dizziness attack. Again, I would say no because I'm a patient, I don't feel it. And I have a big dizzy spell that lasted for days where I could not walk without falling over. Again, it doesn't apply. I get dizzy when I sneeze. No, I don't feel those symptoms. There are times when I get dizzy and also have headache. I get dizzy when I strain to lift something heavy. I'm not sure. I get short-lasting spinning dizziness that happens when I bend down to pick up something. This is more relevant. I would say yes. My hearing gets worse in 1 year before or during a dizziness attack. I would say rarely. I had a single constant spell of spinning dizziness that lasted longer than 2 to 3 days. I'm not sure. I have a feeling of fullness or pressure in 1 year before or during a dizziness attack. I haven't faced that. I have spells where I get dizzy and it's difficult for me to breathe. Not sure. The patient says that I'm not sure. My vision changes before a headache begins. No. I'm unsteady on my feet all the time? No. I'm anxious much of the time? Not sure, because I do feel anxious sometimes. When I cough, I get dizzy? No. When I get a headache, I'm very sensitive to light or sound. And I try to find a dark or quiet room so that I just want to be alone. This doesn't apply to me. I feel dizzy all of the time. I would say yes or rarely. Just ignore me. Canal, crystals are displaced to the posterior canal on my left side. What are the symptoms or signs that you're going to expect from this patient?
So rotational movements can be worse.
Yes, right? So if a patient comes to you and says that I have a spinning sensation, kallu tiruthunani, chakra vastundani. So the first thing practically that we should do is have more clarity on it. Because people, the patients, does not know the difference between the true spinning sensation versus dizziness, right? So you should take additional step to actually confirm what exactly that they need. That's most important because that actually leads you to the next level of questions. So first thing, let's say if I'm your patient, I come to you and say that I feel dizzy. So the first thing that you can ask me is, explain, ask them to explain. So you can say, so give examples. Sometimes what I would do is I would actually give them examples. You feel like spinning, like you feel like you're rotating, or probably the room is surrounding you is rotating, or you feel like more of a dizziness, like an imbalance or floating. Also, so give clues so that they can give you a better idea. Let's say they said, yes, I actually felt spinning sensation. Now we know that if it's a spinning sensation, what would be the probability? Is it more of a peripheral or central? When do you feel? Srinivasa just gave us a brief spinning sensation. Right beating. Let's say constant right beating. That's the vertigo, right? So it's felt spontaneous right beating. Peripheral, right? So probably it's a complete vestibular loss. It's on the left side. If there is a left side peripheral loss, what kind of beating can we expect? Right beating, right? Because left is gone, the right is going to be better, so the fast beating will be towards the right side. Okay, so now we know probably there is no sure diagnosis. Not even a single equipment can actually give you a definitive diagnosis. You always have to get more information for a proper diagnosis. There are some diagnoses that yes, you can definitely depend on, just like a APASLPA, just one test, you can actually get the diagnosis of posterior canal BPPV. That doesn't work most of the time, but there are a few times, yes, it does. So now let's say we have first symptom, vertigo. Okay? And now how would we elaborate? So remember that vertigo can happen with vestibular neuritis or any vestibular peripheral weakness, right? And it can also happen with BPPV. And sometimes it can also happen with Menius and Suzisa was actually presenting on it. Vestibular migraine, right? So now we have certain clues. The first sign is the first episode is spinning sensation. Now we have it. So now we know there are several conditions that can actually start with vertigo. So can we actually further elaborate that based on vertigo? Yes. So now we're going to further elaborate vertigo. So get more insights. So first question is that how long? When does it last? Background information. Were you sick? Were you sick during that period? Or what were you doing? And when does it actually start? Let's go with an example. So I'm your patient. So you asked me, how did I felt? I felt spinning sensation. The next question that you're going to ask me is, what were you doing? When did it happen? So I would say, I started feeling dizzy when I'm actually lifting my head up from the bed. Okay? Does that give you any clue? What could it potentially be? I felt dizzy and I'm lying and then I'm trying to sit back up. You don't need to come up with this definitive answer because we don't know it. Even I don't know it. Just trying to gather the bits and pieces. So what does it indicate? It's indicating it's a position, right? When we are actually stimulating the vestibular system, first thing is let's keep it broader. Don't need to come to complete diagnosis here. So moving, yes, it seems like vestibular system is activated. So yes, now as the vestibular system is being activated, the person is actually complaining about vertigo, spinning sensation. Now it makes sense. And what else that we can ask? Think about it. You're going to see patients from now onwards.
How long it lasted?
Sorry, I'll get back to you. Yes, please.
Again, by the normal sitting position, when they are lying on back, they are getting.
That would be a good follow-up question. Is it only once? And is it every time or only once or occasionally? So, does the patient feel the same vertigo when even going back? Because that's positional, right? If it induces while sitting up, if it doesn't actually go backward, then it might be representing something else. So as Teresa was mentioning, if it is a vestibular migraine, sometimes yes, it does actually make you feel dizzy, but not consistent. If it is consistent, then yes, you're looking at the right direction. If not, now you have to think about something else. The common misconception is that the common misconception is that you're probably only dealing with one disorder. That may not be true. I have vestibular migraine. Today I have vestibular migraine. That doesn't mean that tomorrow I'm not going to get BPPV or vestibular neuritis. Sometimes you might be dealing with more than one disorder. And the chances are that in here, if a patient is being misdiagnosed and mistreated, the chances are that they are actually going to get into triple PD. We've seen several cases where there might be uncompensated vestibular loss and no proper rehabilitation, and you're also dealing with triple PD, neural circuit or psychogenic disorders. So you probably might be dealing with two. So the point here is, how are you going to get that information? You follow your symptoms, the signs that you just learned, at the same time also observe other factors that they're going to exhibit. So in this particular case, let's stick to the point. So first we started asking, when do you feel? Sitting up? Yes, there is a vertigo. And then the follow-up question is, do you also feel vertigo when you're actually going back? If they say yes, how often? Is it every time that you're going to actually turn or probably sitting up? If they say yes, then you're probably looking at the vertigo happens only when there is vestibular system activation, right? Every time you activate vestibular system in this particular angle, you're actually looking at vertigo. Doesn't that confirm almost the highest probability of vestibular issues? Yes, right? Because every time you activate vestibular system, you're actually looking at an abnormality. That's peripheral and vestibular. And more precisely, if it's only through one angle, some patients tell you that I only feel dizzy when I actually turn my head to left or to the right, only to the while sleeping position, or in probably standing left and right. That is something else. If the patient says that I only feel dizzy when I lay down back or probably sitting up, or only during bending forward. So aren't these different angles? Aren't these the angles of the semicircular canals? So this is how we deduce the information starting from one simple point. But there are scenarios where you might get this information, but there's always contradictory. Patients are not expertise in explaining the symptoms. So you have to take the lead and give them more clues to explain what exactly that they're going through. Otherwise, you'll definitely get confused and probably go into like a maze. Right? So sometimes the patient also says that I also feel floating sensation. Not just spinning sensation, but also feel floating or probably feel more blurred vision. Sometimes it can be BPPV with other signs. It can be vestibular migraine or probably triple PD as well. So that doesn't mean that you're always looking at one particular diagnosis. You probably might be getting into more than one or after effects. Sometimes you treat BPPV, you tell them that you're going to be completely fine. They may not. They'll come back to you and say that I don't feel spinning anymore, but I feel like I'm actually floating all the time. Can you relate to anatomy and physiology? What could be happening? Is it relevant or is it just psychogenic?
Sometimes it's relevant also.
I'll get back to you on that.
Sometimes it's relevant to some disorder also.
Yes, it is relevant. So think about the canals. Let's say posterior canal BPPV. You did an amazing job in diagnosing it, and then you actually fixed it through APASLPA maneuver, right? So patient doesn't feel spinning sensation. You tap on your back. Good job. The patient goes home and he does it everyday activities. Then he calls you and says that, thanks Ali, but I have recovered from vertigo, but now I feel a little floating sensation. Probably. We never know. We never know until we confirm it. Yes, that could be one other possibility. The other possibility is that, again, go back to physiology, that's all. So what are we doing through the APASLPA maneuver? We're trying to put the crystals back where it belongs, right? So on the gelatin structure there is autoconia. You just try to put them back. You're not punching it to stick on it, right? It might be free floating a little bit. So it hasn't been completely, right? So this is the reason why sometimes we tell the patients that give a couple of days rest, or probably visit back if he doesn't actually recover completely. The reason is that you cannot stick to one particular diagnosis and say that no, you have just BPPV and you treat it, nothing else. Or sometimes there can be misdiagnosis because this patient might have vestibular migraine or probably some other balance issues or probably vestibular migraine. So you still have to rule it out. And for that particular reason, you probably might need to get more signs. So now this is a situation where I told you that sometimes after diagnosing, I might call the patient back once again. So call them and inquire like what's exactly happening. Now you rule out that there is no BPPV, right? Be particular about it. But there might be conditions where it can be vestibular migraine. So we call them, and as Sulisa was mentioning, sometimes they don't know the other symptoms. They might have some oral fullness, or probably they have some migraine aura, like phonophobia or probably sonophobia and all. They won't be able to tell you because the primary issue is spinning sensation. They only focus on it until you see a path that they could be more than vertigo. So now you get into that particular direction. So now you expand more questions towards migraine. If they say yes, yeah, I feel like I have headaches once in a while, and I also noticed that, as you asked, I also noticed that I am a little sensitive to sounds, but only once in a while. And you connect the points now, connect these dots. Then you can ask them, do you feel like more unstable or probably imbalanced or probably feel spinning sensation when these symptoms gets worse, when you are anxious? So these are the few signs that actually helps you in gathering more information. So this is very important because we see a good diagnosis and then you do try to actually treat small amount of population, but that definitely gives you edge in this. But there are associated symptoms. If any patient, in my experience, if any patient that has been misdiagnosed or untreated for a prolonged period, there are chances that there's more than one disorder. There might be psychogenic involvement as well. So this particular condition can actually confuse you. And the simple measurements that you just, Dr. Srinivas just mentioned, it's an amazing, the SIB, sensory integration of balance. Those 4 steps that Sir actually showed us can help you a lot. In step 1, where we'll be asking the patient to just stand and keep eyes open. Now let me know if a patient, just like we treated BPPV, and he complained that I still have a little floating sensation on D. So simple test is ask them to come back and then just ask him to like stand and close, open the eyes, probably looking forward, have them fall and see what happens. So what if they actually just move around? Right? So you follow the same path and see what exact sense is off. whether if it's neurogenic, probably proprioceptive, or visual, or probably vestibular system. So by doing this step by step, you can get more information to find the precise diagnosis. Okay, now coming back to a different example. So another patient says that I have dizziness, I have a very bad spinning ability. How long? Next patient is like definitely over 4 or 5 hours. So 4 or 5 hours, and then doctors gave me some pills, and so I'm fine for a week or so, and then I stopped taking it because doctor only gave me for a week, and then I started feeling dizzy. This is simple to explain, but they use different terminology. But you as a professional is receiving this information, you have to be very careful understanding these symptoms. So they say dizzy, it's not spinning sensation anymore, but they say like imbalance or probably dizzy or blurry or all sort of things. So what does that indicate? Again, physiology. First spinning, probably around 4 or 5 hours, and then obviously he went through medications which relieved their symptoms, and probably after a week, the patient is not completely treated yet, but he is complaining about dizziness. Probably ocular physiology. Let's start from basics.
Any disintegration between the three senses?
Could be, definitely. But what's the basic? Spinning sensation, what does it indicate? Peripheral or central?
Peripheral.
Predominantly peripheral. Again, there are some signs, certain disorders it can be central. We know that it's peripheral. Now we're going to expand it. 4 hours. And the next question, simple question, does it get worse only with certain head positions or in all head positions or most of the time? If the spinning sensation is not exactly positional related, it's not that only I get it when I'm actually bending backward or forward, but I just felt it only. It doesn't matter which direction I am in, it actually is worse for a couple of hours. Remember that BPPV only happens when the crystals are actually being displaced, right? Okay. It only happens when it's actually moving. So it's not BPPV anymore. But we are still looking at vestibular issues. So how do we expand? We know that it's not BPPV, and what could be other possibilities? Meningitis, neuritis, right? That's exactly how we step in. So now what are the signs that you know about meningitis? Fullness. Exactly, right? So we get into these things. Let's still look at meningitis. He says that after that you say that, okay, have you had any ringing sensation or probably reducing hearing sensitivity? Most of these patients says that I didn't notice because the torture is spinning sensation. So yes, obviously we do need to look into that. And oral fullness. Yes, obviously. That is the case. Now you know which direction that you're looking at. Boom. So you know which test that to refer to. Great. Now say second scenario. He doesn't say that no, I don't have any ringing sensation. I'm completely fine. But it's just after taking medications, chala helped and it really helped me. I was able to do all of my stuff. But once I stopped medications, it came back but not spinning anymore. Physiology. Not meningitis.
Duration?
Duration 4 or 5 hours. Can be, right? So it can be labyrinthitis, can be vestibular neuritis, or just hypofunction or insufficiency. So now we get proper questions again. So think about physiologically. What happens when, again, I don't think I spent enough time on vestibular compensation. This is something that you're going to learn probably tomorrow in vestibular rehabilitation. So as Dr. Srinivas is mentioning, there is insufficiency, right? And sufficiency, and there is also called substitutions as well. So when one of the systems, because it's an amazing system that it doesn't rely only on one, but can take advantage from the other sense. So in this particular case, when the first episode occurred, obviously spinning sensation because it's a new sign, something it's lost. So it results in complete spinning sensation. Because there is vestibular suppressants, we are alleviating the vestibular signs, he felt completely fine. But during this process, there's an indirect physiological functioning that's happening in background. That's called as adaptation. because the vestibular system, the vestibular nuclei on one side lost signals from, let's say on the left side, it's lost signals. There's no activation at all on the left side, complete vestibular loss. Right side is high. So that's the reason why you felt like completely spinning sensation. But this is a continuous signal. So that is perceived by vestibular nuclei and it actually interacts. At the vestibular nuclei, they talk to each other. They talk to each other, and when they compare, so when they compare, if one side is weaker, it slowly improves and matches it to the opposite side. That doesn't happen in auditory system. That's the amazing part of vestibular nuclei, and that is the reason why, if you know the peripheral proper diagnosis, the treatment results can be outstanding. The patient can almost be turned into almost normal person. You do need to work on dynamic compensation. So this particular compensation of vestibular nuclei helps in matching the lost signal from the left side. It actually matches a little bit. When this happens, again remember that it's a temporal, right? And during this period, 1 week period, the patient is actually moving around. With this movement, again the patient is restricted. They cannot just turn like this, right? Because they still have this, they are afraid of actually doing any quick movements. All movements are called as static movements. All only necessary movements. They turn slowly and bend slowly even if necessary. But these movements are contributing to learning the vestibular nuclei. One side is fine. This side knows that I'm not getting any information from the left side. It's a continuous one, which is not good. So it slowly decreases the signal on the right side and try to match it. So 0% and 100% on one side, that is going to be contributed as 100 and 100 on each side. So this results in something called adaptation. Now vestibular nuclei knows that, okay, there is something wrong. This adaptation results in change of symptom. It started as vertigo and now it's slowly getting into the dizziness. Because it's not completely imbalanced anymore, patient is not going to feel vertigo anymore. But patient complains that I feel a little dizzy. That's in static compensation. So there is one more. Then you ask the patient to do more rehabilitation, just going out of little topic. So then you can get them into dynamic compensation, meaning that you ask them to do where they feel more imbalanced. That's giving more signals to the vestibular nuclei. Let's say if a patient has issue bending down, but knowing that it's not a BPPV, you ask the patient to do the same thing. Because the vestibular nuclei never received enough information on the left side, so now you're pushing a little more so that it can learn completely in all directions. So it learns better and actually prepares you for the best possible case, and that can be reduced with the dizziness can be reduced with the vestibular rehabilitation. Okay? So those are set of questions that you can think of. So you get the basic point, first determine whether if you might be dealing with peripheral or central, and then go through those symptoms to deduce, and then probably put all those dots together to come up with some diagnosis. So the next point is, what if a patient has symptoms that just is everywhere? Patient is that once in a while I feel spinning sensation. That may tell you that, yeah, it probably might be peripheral. Then you ask follow-up questions. Is it only in one position? Is it only during, let's say, only during left side or probably right side? Or probably patient also says that I have tinnitus or hearing loss. Is that possible? Possible, right? It can be easily trick you into getting into wrong diagnosis. So what are we going to do now? Let's say we're dealing with vertigo, same symptoms, vestibular neuritis, and patient also tells you that I have tinnitus once in a while. Can it be meaningless? But it doesn't complain about oral fullness, or it's not low frequency hearing loss, and it's not episodic. Just felt once, probably like 4 years back, and never experienced it. Neuritis probably uncompensated. Can there be a hidden vestibular schwannoma? right? So these things, so here the tinnitus is important for us, and progressing hearing loss as well. So by putting all these small and tiny bits and pieces, you get more and more information. It doesn't need to have, let's say, a sophisticated WEMP equipment or probably a sophisticated VNG equipment to begin with. Just by knowing these things, you can put these pieces and come to at least preliminary conclusions. The same thing goes to vestibular migraines. As Dr. Sujit was mentioning, sometimes patients give you different reasons, different symptoms. It doesn't match, it doesn't have any consistency. It does happen. And there is a disorder, I think I'm pretty sure that you probably might have heard, neural circuit are also called as psychogenic issues. No sensor is abnormal. All sensors are fine. Vestibular system is fine, spinal is fine, cervical is fine, because you evaluate everything. Vestibular with VNG, our problem when completely fine. VSR, spinal reflexes, probably the SIB, CT SIB, you did that and you came to know that even proprioceptive is completely fine. And there's even no orthostatic hypofunction. You ruled out that. And then probably VCR, pollic reflexes, well, completely fine. But patient do complain, and patient does not report any kind of migraines. No migraines never, no phonophobia, nothing else. The patient had one episode of vertigo, but it's completely fine. Let me give you a little background information. So this patient is a true patient, so had an episode 2 years back only once, then he's completely fine, nothing else. No medications for any long, but he just had once. And then the questions that, so we did all of these things. Because we initially thought that it could be vestibular neuritis or probably uncompensated vestibular hypofunction. So the follow-up questions, after diagnosis, we followed up with them and asked them, do you have any migraines? Nothing. Any dizziness while just standing up, like after laying down to standing up, orthostatic hypofunction or any vascular movement, completely fine. Another contributing factor is the stress. I'm always stressed. I'm a software employee, I have targets to reach, I sleep less. So what could be the diagnosis? This is a clue. All sensors are fine because we had a proper diagnosis. Psychogenic, right? So it could be triple PD or chronic subjective disease. Both are same, called in different terminologies. Yes, it could be that, and it is true. It is real. It can have an effect. It's just that the system, as Srinivas is saying, when you are on soft foam, testing your proprioceptive, it can be hyper sensitive, right? When it's hypersensitive, the neural circuits will result in higher potential. So it's very active. That can actually result in some imbalance issues. So we see these patients, especially with in generation. So we see these patients in young generations. Yes, please.
We stand on the uneven floor or something. So the system will take some time to stabilize it. So that's also comes under problem.
So system, that's the reason why sometimes we have to give around 20 to 30 seconds, right? We ask them to stand on the floor. Let's say if on a cushion, testing proprioceptive. So basically the patient, you and everyone, just will have a small wiggling room, but not only to one side or probably like falls. That's fail or abnormal response. It's just a little bit of wiggling is fine. But if it's only like at the beginning, but rest of the time it's fine, then no, there won't be anything. Because remember that even if the proprioceptive is off, like completely gone, not the hypersensitive, it's going to rely on vestibular system. Because as you slowly move or wiggle a little bit, the vestibular system is now being activated. So the vestibular system is going to actually give more information to the spine and actually helps us stay you balanced. But even if the vestibular system is gone, then yes. So this is the exact point where we are actually getting into. If there was a vestibular loss earlier, but now there is a psychogenic issue. Because there was a loss, it's not completely recovered. The recovery is at vestibular nuclei, not at the sensor. right? The recovery is at the vestibular nuclei, it's just filling the gaps in but not here. So when you are on the soft foam, when you're actually testing, if a patient is going to fall, it's not just proprioceptive. There might be uncompensated, completely uncompensated vestibular loss as well. And this tiny bits of information is very important for proper diagnosis. Okay. So, yeah, so coming back to the patient. So this is one patient, and then I'm going to give you another patient. So the patient essentially, patient's first complaint is spinning sensation only when they actually turn backward on the left side or early mornings. BPPV, sounds like BPPV, right? And they only complain that it only happens like while sitting up or laying back or probably prolonged rest at night. What does that indicate?
There is cervical problem.
Cervical problem, no, there is no neck pain or everything is completely fine. And only on one side, left side.
There is a chance of the posterior canal.
Posterior canal. And you test actually, you see updating and then the torsional. The posterior canal BPPV exactly mimics like that. Yes, it's posterior canal BPPV. You treat multiple times with equilibrium, then surmount or probably Gaffoni. You do all of those things. Patient says that I'm fine for one day, and second day he says that I have it once again. You repeat again and again and again. You see this practically. You can ask Srinivas sir or probably even Suman sir that you see this patient where patients had multiple occasions of equilibrium maneuvers and all other repositioning maneuvers has been applied on them, but there is no outcome. Is there any benefit of repeating the same thing if it's not fixing the problem? No, right? So now think a little beyond. What could be the reason? If it is BPPV, right? So think about physiology. What's happening here? The circulatory system, the vascular system is actually supplying blood, right? Sometimes these can actually have an impact. So it can be vestibular insufficiency, you have to be very careful. Or it can be, let's say, any vascular issues like a compression. All these things can also mimic like BPPV, because let's say if you're actually compressing an artery right here, there might be vascular loops. Meaning that whenever like you're doing compression on, let's say, the left side, you're also compressing the artery. That can result in the similar features what you observe in BPPVs as well. And this is something that we observe more than what we expect actually. If the BPPV is not treated frequently, you have to be careful on these occasions as well. So how do we come to know that the diagnosis is proper based on its case histories? So obviously you're going to have a lot of tests, functional, subjective and objective tests, which gives you enough information. The idea of case history is that it will help you further diagnosing all of these things. So make sure that you pay attention. Don't hesitate to spend more time. Don't be like an audiologist, but be like a vestibular specialist. Don't hesitate to spend time with them, because they give you the diagnosis when the equipments can fail you. Okay, so that's the questions. Yeah, please.
Is there any embolisms in the vascular system? So the CT angio is the only gold standard to detect that?
No, I really cannot comment. Sir, do you have any comment on it?
For which one?
Sir, is there any obstructions in the vascular route? The CT angio is the only.
For dynamic compression, CT angio is the only best one.
Okay, sir.
There is other static compression, there is already stenosis, even MR angio can.
Yeah, MR angio. Thank you, sir.
So I'm trying to keep it very short, but if you have any questions, I'll be right here, because we have a better diagnostics test you're waiting for. Okay?
Thank you so much, sir. It was so nice to see you how well you made ourselves to diagnose with little symptoms and everything. Thank you so much. Once again, we are going to call Dr. Srinivas Prasada, sir. But was
So even the fluid moves, when the footprint of the stapes is moving, it is making the fluid to cochlear side also and towards the vestibular side also. But vestibular side, the stimulation reduces because it has to pass through those narrow channels, and hence the vestibular system typically becomes insensitive to the sound basically. Now here the problem, there are many patients who will be coming to the clinic, and what will happen is there are many patients who will come to the clinic with only isolated otolith dysfunction, who will have only problem with the secure or only problem with the utricle, but they will have not any problem with the semicircular canal. Typically what will happen is that these patients will report of tilting, rocking, floating and translational movement in roll or pitch plane, otherwise they will not have any other kind of symptoms like a spinning or vertigo episodes altogether. They will have isolated sacral or utricular dysfunction. Now this sacral or the utricular dysfunction, you cannot measure it through VNG. There are no tests which can assess the function of sacral and utricle apart from the vestibular evoked myogenic potentials. WEMS are the one which is going to assess the utricle and sacral, and the utricle and sacral can be assessed with three types of WEMS. One is cervical vestibular evoked myogenic potential, which is CWEM. Then you have OWEM, and third one now which is picking up is your MWEM or mesenteric vestibular evoked myogenic potentials. Now when we look into the cervical vestibular evoked myogenic potentials, it is basically assessing the sacral and the inferior vestibular nerve, sacral and the inferior vestibular nerve. It is a very short latency reflex which is recorded from the sternocleidomastoid muscle. Now sternocleidomastoid muscle are on the two sides of the neck. Once you turn the head to the opposite side, you will see that there is some stiffness over here. This muscle, what you can see here, is your sternocleidomastoid muscle. So the average response or the compound action potential which you are recording it from the sternocleidomastoid muscle. Fine. So I told you that it is a myogenic response. It is a myogenic response because you are picking from the muscle. Now it is a polysynaptic response which will also help you to assess the lower brainstem, which tomorrow when I present some cases you will understand that. And sacral basically has the lowest threshold to response to the acoustic stimuli. That is the basis of the whole WEM test. Now what you have to understand is when you read into the embryology of the ear, the whole ear develops from the sacral. Sacral is the first structure that gets developed, and from there the whole inner ear develops. Okay, so that has got some sound sensitivity basically. Now if you look into the pathway, that is the cervical WEM pathway, it is basically the sacral. When you stimulate the sacral through the inferior vestibular nerve, the stimulus reaches to the vestibular nucleus, and from the vestibular nucleus there are two pathways. One is through medial vestibulospinal tract, which goes to your spinal accessory nuclei, and from there it comes to the sternocleidomastoid muscle, which is over here. Second is it comes through your lateral vestibulospinal tract, which is supplied to your gastrocnemius muscle of the leg. That is here, this muscle. So gastrocnemius muscle of the leg. So either you can record from the neck muscles or you can record from the leg muscle. But we prefer neck muscles because it is easy and convenient to record rather than from the leg muscles, and also that amplitude is smaller for the gastrocnemius muscle. Latency is long because the pathway is longer over there. So we prefer to record from the sternocleidomastoid muscle, and easy to locate because if you just turn the head of the person to the opposite side, you will be able to pick from there. So when you record the stimulus, then what will happen is you get a waveform which is a biphagic peak, wherein the first peak is your a positive peak and second peak is your negative peak. This is P30 because the average latency of the positive peak is around 13 milliseconds and the average latency of this negative peak is around 23 milliseconds. P13 and N 23. However, when you look into the data of the normals, the positive peak varies between 12 to 16 milliseconds for the normal, and this peak varies roughly about 20 to 25 milliseconds in normal. 12 to 16 and 20 to 25 milliseconds in normal, this peak is going to vary. Now when we are doing this, what we do is we measure the latency of P1, but because it is one single peak means one positive and negative peak, we measure the peak to peak amplitude. We don't measure individual P1 amplitude and N1 amplitude. What we measure is P1, N1 peak to peak amplitude, and so the latency and amplitude, and then we calculate amplitude asymmetry ratio. Amplitude asymmetry ratio is, the formula is given here, better ear amplitude minus poorer ear amplitude upon better ear amplitude plus poorer ear amplitude into 100. Now why this is done is, there is some differences in the response of the right vestibular system and the left vestibular system. Generally we all have learned that right ear has got a better stimulus processing compared to the left ear. That's why we have a right ear advantage. That's what you learn in CMPD, that we have a right ear advantage. Correct? Similarly, one can have a right vestibular advantage, other can have left vestibular advantage. I may have right vestibular advantage, you may have a left vestibular advantage.
Is there any difference in the handness?
Handness? No. No.
Right-handedness will have.
No. That is not there. Okay. Now, how you will come to know is, come. Quick. Stand here. Okay. Keep your feet together. Close your eyes and quickly march 60 times. 1, 2, 3, 4, 5, 6, 7. Okay, done. Thank you. Do you think right dominance or left dominance? Right dominance. Right dominance. Vestibular system, that's why the body is pushed towards the left side. That is what is the basis of your vestibulospinal test lumbar. The patient will always fall towards the side of the weakness. Okay? So now what happens is that there is some asymmetry, and now most of the vestibular pathology which is confined to the inner ear, I am talking about confined to the inner ear. Meningeus disease, unilateral or bilateral? Unilateral. How many meningeus you see bilateral? Mostly unilateral. BPPV unilateral or bilateral? Most of the cases, it can be both, it can be multiple. Mostly unilateral. Vestibular sonomas? Labyrinthitis? If it is not bacterial meningitis, then it can be unilateral, it can be bilateral. Correct? Most of the vestibular pathologies which are confined, vestibular neuritis, unilateral or bilateral? Unilateral. So most of the vestibular pathologies which are confined to the labyrinth or the inner ear are unilateral in nature, and they are not bilateral in nature. So the asymmetry ratio in normals can vary up to 30%, and if it is greater than 30%, then it indicates a pathology towards the side which has got a lower amplitude. Is it clear? Another parameter which is there, it's your frequency tuning. Frequency tuning is nothing but, as when I just go on to the presentation, you will understand that what happens is that when we use a frequency specific stimuli like tone burst, 500 Hz, 1 kHz, 2 kHz, 4 kHz, the best response which you get in WEM is at 500 Hz or 750 Hz. So even if you do in 1000 normal people, you will get the best WEM responses at 500 Hz or 750 Hz. That means say they are specifically frequency tuned responses. So amplitude of 1 kHz, 2 kHz or 4 kHz tone burst will be always lesser compared to 500 Hz. In patients with Meniere's disease specifically, there is going to be a change in the frequency tuning. They will have a better responses at 1 kHz or 1.5 kHz compared to your 500 Hz. And that's a significant diagnosis that they have a presence of endolymphatic eye drops. Tomorrow I am going to discuss one more patient based on the frequency tuning also. So now this is the parameter which we utilize to record the entire WEM, cervical WEM basically. So the type of stimulus which we are going to use is a tone burst, 500 Hz basically I use 212 cycle and intensity 95 dB NHL, or if you want to use in dBSPL, it should be at least 125 dBSPL. Repetition rate of 5.1 per second, polarity rarefaction. Total number of stimulus 150 to 200 is sufficient. You don't require too many stimulus like ABR, some 1000 or 2000 stimulus. You require 150 and 200 stimulus. Analysis time is 70 milliseconds. Filter setting high pass 10 Hz and low pass 1500 Hz. Amplification only by 5000 times. And the electrode montage. I'll just put the electrode montage. Do I have a picture? Just one second. Yeah. Can you see this? Here you place the positive electrode, that is your non-inverting electrode, and here you use the inverting electrode. On the sternocleidomastoid muscle, you will place the non-inverting electrode. On the sternoclavicular joint, you place the inverting electrode, and the ground electrode you will place it on the forehead. This is the typical placement of the electrodes in your vestibular for the cervical vestibular myogenic potential. Is it clear? Okay. I'll come to this. What is all about all this? Okay. So now stimulus effect. Now stimulus, what is the kind of stimulus which we are going to use, whether it is a tone burst or whether it is a click. Now when I say that it is typically insensitive to the sound, then why I am then choosing the stimulus whether click or tone burst? Now with a tone burst stimulus, basically I get a better large amplitude compared to the click stimulus. Click stimulus, when always the stimulus amplitude, response amplitude is going to be smaller. Now what is the role of amplitude, or more amplitude or the less amplitude in the diagnosis of the various vestibular disorder using vestibular myogenic potential? Now when I am looking into the end organ pathology, that is pathology which is confined to the inner ear basically. Okay. Now when you look at the cochlear side, there is a master, ring master. That ring master is the basilar membrane. Basilar membrane is a resonator, and that will determine the whole frequency tuning of the auditory system. Is it clear? So when you are looking into the cochlea and when you use different frequency stimulus, because it's a resonator, a particular part will have a travelling wave. So the higher frequencies travelling wave will be shorter and low frequency travelling wave will be longer. Hence the latency is a major parameter when you are using or when you are recording any potential from the auditory side. ABR, you always depend upon the latency to diagnose whether there is a retrocochlear pathology or there is no retrocochlear pathology. But when you look into the vestibular system, there is no resonator. It's a saccule, it's a utricle. So what will happen is, in response to a stimulus, the entire hair cells will move together to one side or to other side. That means say that either it will get depolarized together or either it will get hyperpolarized together. So when it will get depolarized together or hyperpolarized together, what will matter, latency or amplitude? Amplitude. So whenever you are looking into labyrinthine pathology, whether it is Meniere's, whether it is labyrinthitis or whatever it is, ototoxicity, if the pathology is confined within the inner ear, it is the amplitude that is more important. Is that clear? Clear? Okay. But when I am looking at a case like vestibular sonoma, when vestibular sonoma I am looking into, what it is doing is it is compressing the nerve fibers. When it is compressing the nerve fibers, definitely it will affect the timing of the stimulus. Then the latency will become a major parameter. But when I am looking into only the pathology which is confined to the inner ear, then amplitude. So now what is the choice? Tone burst. Okay. Because most of the pathology which I am looking into are mainly confined to this one. This is the same finding, I am not going to put it again. Now, can you see this now? What is that you find here? This is high frequency, this is low frequency. What is the difference you see? No, only you see a latency differences in 250 hertz major resolution.
Mostly amplitude difference is there.
Mainly amplitude difference is there. Only 250 hertz you can see a latency shift. Otherwise, mainly what you see is the amplitude differences. Correct? Amplitude differences. And that is what even if you see here, you can see that the amplitude will reduce at other frequency and the amplitude is always higher at 500 hertz or 750 hertz. And that is because everything has got a resonance property. And that resonance property of the electrical and cycle is roughly about 300 to 500, 600, 700 hertz. And that's why what will happen is the best responses what you will get, either you get at 500 hertz or you get at 750 hertz. So the choice of the stimulus, once I know that tone burst I am going to use, the second choice is that what I am going to use is either 500 hertz or 750 hertz. Fine? Okay. Next. Intensity. What is that you see? Amplitude or latency? You can see that amplitude changes. This is recorded from IHS and this is recorded in some article. Packing it all. This is there in JP College. Okay. You can see that here also you see there is a big change which is there in the amplitude and the latency is not shifting and the intensity is changing. The latency shift what you see in the ABR because of the higher intensity or because of the lower, as you go on reducing the intensity, is because of the traveling wave. The traveling wave, as the amplitude will become higher, it will shift, the dispersion will shift to the other frequency, and that is how the latency will change. Here I told you that there is no Western membrane, there is no ringmaster, and hence whatever the effect you see only for the amplitude and you don't see it for the latency at all. Okay? And also you see that here in the article, when you look into their article, below 95 dB NHL hardly you can see any response at 90 dB or 85 dB NHL, although in the clinic I can see that 80 dB is present, but 80 dB is very rare to be present in normal. Ideally we record the wave at 95 dB NHL or we record at 125 dB SPL. You generally don't get the wave at 80 or 85 dB NHL. Repetition rate effect. Look at the waveform and then tell me that what is the difference that you find. Latency or amplitude? Amplitude only. Latency, there is no major shift. What you can see here. What is changing is your amplitude. Again, if you go back to your ABR, as you go on increasing the repetition rate, latency will change. Latency will decrease or latency will increase? Increase. Okay. Here what is happening is only the amplitude is changing. That's why I told you that amplitude is the major parameter, not the latency is the major parameter. So amplitude is what is changing here. So as you can see that 5.1 gives you a best amplitude. Below that 7.1 it is little lesser, 10.1 is still lesser, and 15.1 still lesser. But how do we determine repetition rate? That I should keep 5 or 6 or 7 or 8 or 10 or 20 or 100 anyone. What is the criteria to keep? How do we determine?
Age.
Age factor? No. It is the time window. Time window is the analysis window. So in general, I put it in very easy then. ABR we use a time window of 10 milliseconds. 1000 milliseconds is equal to 1 second. So how many stimulus we can present per second there? In ABR, if I use a 10 millisecond time window, 100 till 100 I can use, because it's a simple fundamental that 10 millisecond window means I give one stimulus that should be analyzed for 10 millisecond. 11th millisecond only the second stimulus should arrive. Is it clear? Then that should get analyzed till 20th millisecond. Then 21st millisecond the third stimulus should come. So for a 10 millisecond window, you can go up to 100. But 100 is a higher repetition rate. So you bring it down and you do a 10 or 11 per second or 30.1 per second. 90.1 when you say that I am using a higher repetition rate. So if I am recording LLR 500 millisecond time window, then maximum how many stimulus I can use per second? 200 stimulus per second. 500 millisecond time window, I can use only 2 stimulus per second. But 2 stimulus per second for a 500 millisecond, it is a higher repetition rate. That's why eventually you record LLR at. Understood? So this is the determination of that repetition rate. Rise fall time although doesn't matter much, but it is 212 that gives you the best response. And this parameter holds good for ocular wave also. That is nothing but the stimulus type, stimulus intensity, stimulus frequency, rise fall time, repetition rate, everything, all the parameters are same for the ocular wave also. I'll present, but the basic physiology remains same for both the waves. Okay. So filter setting should be for C wave, it should be set to 10 Hz to 1000 Hz, 1500 Hz. This would be the final filter setting for the cervical vestibular myogenic potentials. Now, in the different ways, the wave, how much time I have? Okay. The different ways in which the cervical wave is recorded are rectified method, unrectified method, and EMG muscle monitoring. Now, 3 methods you have to understand. This is only particular to the cervical wave. It is not so much important in your ocular wave. Now, cervical wave, what I am doing is I am placing the electrode here, and hence the electrode does not know to differentiate the potential. It can only record a current what is coming. Here, when you place the electrode, the current is coming from 2 places. One is from the muscle, that is your EMG, and second, because we have given a stimulus to the ear, from the saccule there is another response which is coming here. So whatever the electrode is picking, it is picking the EMG plus saccule responses. EMG plus saccule responses. Is it clear? So what will happen is, typically when you record, such as for example in the simple ABR wave equipment, if you just change the protocol as per what I have suggested, you place the electrode here, turn the head to the other side, you will be able to record the wave. But that will record both EMG plus saccule responses. So you do not know that how much contribution is from saccule and how much contribution is from EMG muscle. So that is called as unrectified method of recording vestibular myogenic potentials. Then second one is your rectification. Rectification is nothing but you give 20 millisecond or 30 millisecond pre-stimulus while you are recording this one. That is analysis window you set to minus 20 millisecond, minus 30 millisecond to 60 millisecond post-stimulus. And then you subtract the post-stimulus from the pre-stimulus. So before 0 millisecond, whatever it is recording, it is the muscle response, and after 0 millisecond, it is muscle plus saccule response. So if you subtract the two, the muscle response will be taken care of, and what you will get will be the responses only from the saccule. So when you are using unrectified method, wherein you are not doing the rectification, the amplitude is going to be like 200 microvolt, 400 microvolt, 500 microvolt, because how much muscle is contributing you don't know. But when you are rectifying it, that we say that you are subtracting the muscle response, then the amplitude will be 2 microvolts, 3 microvolts, 4 microvolts. On the higher side, it is going to be only 10 microvolts. It is never going to cross 10 microvolts. Is it clear? Okay. The third method, or this one you will get in most of the equipment, is your EMG muscle monitoring. EMG muscle monitoring is nothing but at least something to taken care of. I told you that you have to calculate the amplitude asymmetry ratio, because pathology, most of the pathology are unilateral in nature, so it will affect the responses of one of the side. So when you are using a complete unrectified method, so when you have turned the head to this side, or when you have turned the head to this side, you do not know that how much contraction has happened on this side, how much contraction has happened on this side, how much EMG the electrode has picked from this side, and how much EMG the electrode has picked from this side. So if you get some asymmetry between the two sides which is greater than 30%, you cannot be sure that it is because of the muscle movement or it is because of the cycle differences. So third method is your EMG muscle monitoring. The device will not do the rectification of the response, it will just measure or control the EMG response on the two sides. So that you set a value that the EMG level should be between 50 microvolt to 100 microvolt. For example, just example, on the two sides. So when you have turned the head, whenever the muscle contraction is between 50 to 100 microvolt, the instrument is going to record the response. If it is lesser than that, it will not record the response. So on the two sides, at least you are taking care of that amplitude asymmetry ratios. There are different ways in which the neck muscle contraction is achieved. One is that when the person is lying down in supine position and you just raise the head little ventroflexed using a pillow, both the sides will get contracted basically. Another method you can see here, this is from my lab and I prefer to do this. I use a study chair, not the revolving chair, a simple chair where I make the person sit and I just turn the head to the opposite side. That's how you will get a good contraction of the muscle. This side also you will get a good contraction. You can just see that the muscle. And here what will happen is electrode, you can see that the positive electrode is towards upward side because you can see that the broadness of the muscle is more towards the mastoid and it is lesser towards the sternoclavicular joint. Okay, that's why we prefer on the upper side. So positive electrode here, the negative electrode here and the crown electrode over here. So there are different ways in which the muscle contraction is achieved. Whichever you find convenient, you can do it. I go for this because I find very convenient. Just make the person sit in the chair. The person is not scared because the moment you make them lie down, they will think that what you are going to do next. You just make them sit, place the electrode, turn the head, record it. That's all. It's simple way. There are different methods wherein the person they have tried to achieve like this, tried to achieve like this, tried to achieve like this. But this is more simple, which I find that it is easy. There are many equipments in the market. Okay, there are many equipments in the market. Yes, sir.
Few people suggest two-channel is also well. Is it advisable to do?
No, I don't want to see. What will happen is I only record for 150 stimulus and I use a repetition rate of 5. So it takes me only 30 seconds to record 1 gram. That's all. So 30 seconds, 1 minute, it is over. So I prefer to do that. It is very convenient for me also and it is very convenient for patient also. Otherwise, for getting both side contraction, you have to make the person lie down on the patient couch and then you have to ventriflex the head so that both the side the contraction can happen.
Are the results reliable?
Reliable. Both are reliable. Both are reliable. It's just that
proper because I tried doing, but
no, it's just that you have to get used to the contraction, that how you achieve the contraction. But it is reliable. It is reliable. It is not that not. You have to just get this one. But I prefer to do because it takes only 1 minute post cleaning, so it just easy. It is not time consuming. Just takes 1 minute. That's all. 30 seconds from one side, 30 seconds from one side. And anyway, when you make the patient lie down on the patient couch, by the time you clean and ventroflex, it will take the same time. So it doesn't make a difference. Either way, it is fine. There are many equipments which are there in the market which is available, but all of them will not give you the rectification basically. Some of them will give you rectification, some of them will not give you rectification.
Okay. Some cases like your fatty necks can't find the muscle, you really can't excite.
No. You will be able to get hold of some muscle like this. If you just press it, you will get that where it is. The amplitude might vary, that's all. Amplitude might vary, but otherwise because it's a potency.
EMG monitoring, how much ever you turn, it is not becoming real.
No, what will happen is, I am coming to that. Wait, there are many equipments which you have in the market. You have IHS, you have biology which is just top now, acoustics, and you also have neuro audio which is there. Now, this was our very crude method. Can you see this? This is very crude method of recording the wave which we started with, so that the muscle are activated or contracted by an equal amount when only AVR equipment was there and there was no wave equipment. So we designed something like this so that the head can move this side and that side by an equal amount. That's all. This was the one wherein the EMG feedback, this is the one And the first equipment wherein the web was bought, Vijay has done his dissertation. So we saw the first equipment with his dissertation actually of the web. Okay. So this is what is EMG monitoring and feedback in intelligent hearing system. I think many of you have this one, where you can see that this part, when you look into the first part where you can see that this is the EMG levels, and it has got 3 divisions. This range is the range which you can define, and this is the upper range and this is the lower range basically. Now, as Vijay asked that some people you may not be able to achieve this. Actually, this is customizable. If I am using the WEM for smaller children or older adults, then what I do is this lower boundary I put it to the lower side, so that I am able to achieve that. Because at last I am using this asymmetry ratio, so I will pull this to the downside so that this level reduces, and hence with the lower amplitude whatever it is, we are able to achieve this contrast. And this where you can see a frog, what will happen, this is a feedback system which is used for the children. So every time you ask them to turn the head and you say that every time you turn the head properly, see this frog will jump from one limb to the other limb. So that is kind of stimulus feedback which is given for the children. And for the adults, this is the feedback system. You give it in their hand that whenever it shows a green light, that this one is achieved, that's all. There is nothing else over here. So this is the kind of system which is there in the IHS.
Just explain how to exactly apply those minimum minus per left and right, how to achieve that.
No, here what will happen is this minimum and maximum, there is nothing that you have to keep so much. Okay?
So no need to change anything.
No, I'll come to that. Wait. So here what is happening is that here there is nothing defined that you should use only this much or you should use only this much. Why? Because for every patient I am using amplitude asymmetry ratio as a diagnostic criteria. So only what I am comparing is patient's right ear to the patient's left ear. I am not comparing patient A response from patient B response or patient A response to the normal data. I am only using right ear versus left ear as a criteria. So if I use this boundary to the lower limit, to the little lower limit, then what will happen is both the side I will keep it equal. So that amplitude, whatever it is picking from the EMG, it is the same from both the sides. Now here I will never make it 0, at least I keep it at 30, so that at least some amount of contraction that is happening there. And for adults I keep it at 50 km. Lower boundary is the one which I basically try to put it down. Upper
So
boundary
exact settings we can ignore.
Which one?
This apply left side, right side, apply this.
No, apply both. Both the sides you have to keep the same. You cannot keep one side 30 and one side 40. When you say apply both, it will keep both the sides at 30. That's all. So we have to keep both the sides because that EMG of 10 itself will make a big variation in the responses of the amplitude. So apply both the sides, 30 multiple 100. Yes. It is only there in the IHS.
Sir?
Yes.
Can't we just avoid this कि हमने left side right vendor flex position में तो दोनों equally contact करेंगे?
No. There are some variations which will happen. Some variations will always likely to be happen.
And as you mentioned, we have to look for amplitude asymmetry between the ears. तो हम tone brush की जगह clicks भी use कर सकते हैं if we are just seeing amplitude
What will
asymmetry.
happen is the amplitude of click overall it is very less. So when you rectify it at a later point of time, that pre-stimulus, post-stimulus, it almost becomes like a flat line. It becomes very difficult to measure that amplitude in the click stimulus. That is how we go for tone. This is there in the interacoustic system that has got only the EMG monitoring, that has not got a rectification system. This is what I use in equipment which is neuro audio. So you can see that amplitude differences here. This is unrectified wave and this is the rectified wave. First one is unrectified and second one is rectified wave. And this is from a publication by Rosengren, and you can see the huge difference between the two responses, corrected versus uncorrected responses. That is what is the difference, what is you are going to get. And in an ideal clinical setup, you should have the rectification of the wave. You should not use the unrectified version because you are picking the muscle response and you are making the whole diagnosis based on the muscle EMG levels. coming to the ocular vestibular myogenic potential, this is the pathway. So the pathway is from the utricle and through the superior vestibular nerve. In the other one it is inferior vestibular nerve going to the vestibular nuclei. But from vestibular nuclei it is taking a contralateral route and it is going to the ocular motor nuclei on the other side, and then it is supplied to the inferior oblique muscle. So when you look at the cervical web, it is purely ipsilateral response, and when you look at ocular web, it is purely contralateral response. So when you look at the electrode placement, I'll just come to the electrode placement and then I'll come back to this. You look at the electrode placement and this one. See the electrode placement, the electrodes are placed here, but the stimulus is given on the other side. That is, if I am putting the stimulus to the left ear, I place the electrode on the right side. Is it clear? And if I am putting the stimulus to the right side, I am going to put the electrode on the left side. It is a purely contralateral response. And the diagnosis will be made as per the stimulus here, not as per where you have placed the electrode. So if I have placed the stimulus in the left ear, I am assessing the left utricle. If I have placed this one on the right side, I am assessing the right utricle and not this one. So the positive electrode is placed roughly about 1 centimeter below the eye, and negative electrode is placed 1 centimeter below the positive electrode, and the ground electrode as usual on the forehead. This is the electrode placement which is usually done for the ocular. And whenever the person, you have to record the OM, as you can see the person eye, where it is up. You have to ask the person to look up. So you ask them to move their eyes maximally up. This is the electrode placement and the eye placement which you have to achieve. So here the waveform, when you give the stimulus, the first peak is the negative peak, second positive and third negative, but usually most of the literature which you will see, it is negative and the positive peak. So same N1 latency, P1 latency, N1 P1 amplitude and amplitude asymmetry ratio and the frequency tuning, because basic physiology remains same for all WEMP and hence measurement of the analysis also remains the same. There is no difference in the analysis methods. See, this is the recording parameters. I'll just take 5 more minutes. I'm done with. Okay, now here you can see that everything is fine. Only thing which will vary here, it's your two things, that is the filter setting is different for the ocular web and the electrode montage is different for the remaining all the parameters remains the same. There is no change in the parameter. This is the electrode placement. Positive electrode, negative electrode and your ground. Stimulus intensity, you see the same thing, no latency shift, but you see the amplitude change, same thing. I'll just put on, see that gauge, that is nothing but eyes straight versus eyes up. The eyes up gives a better responses. Okay. Now ipsilateral versus contralateral recording, what you can see the difference? Amplitude, you can see the huge difference between ipsilateral side and the contralateral side, so you use contralateral stimulus. Frequency, you see what is that is changing? Amplitude is changing, same as cervical. I just said that the physiology remains same, physiology is not different, so this all will remain the same. Third potential which is there now, which we are started to record, but still the clinical utilities has to be determined. This is the masseter vestibular myogenic potential, and again it is from the right, the saccule. So from the saccule through the inferior vestibular nerve, it will go to the vestibular nuclei, and from the vestibular nuclei now, there are two pathways, ipsilateral and the contralateral pathways, which goes to the trigeminal motor nuclei. Trigeminal motor nuclei. The cranial nerve number 5. Okay, and from there it is supplied to the masseter muscle specifically. So additionally, it gives me information about the lower brainstem because it is assessing the trigeminal motor nuclei also. So it has got ipsilateral as well as contralateral. So you can record ipsilaterally also and you can record contralaterally also. It gives the same kind of responses. This is the pathway which is there in the masseter vestibular myogenic potential. This is the electrode placement that we use. The positive electrode is placed here, the negative electrode is placed here, and the ground electrode is placed over here. Over here. So either you can use a contralateral stimulus or you can use a ipsilateral stimulus which is there. So you have positive, negative, and this one. And there in the cervical web, you ask the person to turn the head to the opposite side. In the ocular web, you ask the person to keep the eyes upward, and here you ask the person to clench their teeth while recording. That's all is the difference. Electrode placement, this is the electrode placement which is there. But lot of things, this is the waveform which you get for the masseter vestibular immobilizing potential, almost identical to the cervical wave, almost identical, but the latency is different. There the latency is P13, here the latency is P11, and N is at 21 millisecond. N is at 21 millisecond, positive peak is at 11, there it is 13 and 23, here it is 11 and 21, 2 milliseconds early, because the pathway is shorter here, the pathway is little longer here, that makes the difference. Otherwise, the response which you can see is identical to cervical wave. If I don't tell you that this is masseter wave, it is same, looks like the cervical wave itself. Then there are many literature which we have reviewed, and we have found that inconsistent parameters which people have used to record the masseter wave. So the first job is basically to establish the protocol of the masseter wave before we can use it in the clinical population. Somebody has used stimulus intensity of 70 to 100 dB NHL, somebody has used 143 dB SPL, somebody has used 130 dB SPL. So a lot of variations in the stimulus protocol, and also this one stimulus. So still the utility has to be determined. Some basic things which you have to understand. First, check the UCL of the person, because cases like Meniere's disease, they might have recruitment, so they might have intolerance to the loud sound because you are using a very high intensity to record this. You have to check that. Then ensure that adequate muscle contraction of the two sides, and the muscle contraction on the two sides is same. So you should have IMG muscle monitoring, and use a rectified method and don't use an unrectified method of recording. Intensity of the sound is very important. Rule out middle ear pathology, that is more important. Any middle ear pathology will lead to the absence of web. Okay, so you have to see that you don't do it with any person with a conductive hearing loss, it will lead to absence of this one. Then understand the pathology, that is whether it is confined to the inner ear or the vestibular nerve. Inner ear pathology will lead to reduction in peak to peak amplitude and disappearance of the waveform, whereas nerve pathology will lead to latency prolongation and disappearance of the waveform. So all the pathology like Meniere's, labyrinthitis will lead to only reduction in the amplitude, whereas the nerve pathology like vestibular sonoma, it will lead to reduction in the, increase in the latency.
Thank you so much, sir, for making that very simple. Yet now we are going for positional tests, and when you are all ready, lights on and we are on hands on. Thank you. I am inviting Dr. Srinivas Darsanas to carry on with this positional testing manuals.
Today, till all of you are satisfied. Okay, about the hand count. So what we will do now is, I'll take around 15 minutes to demonstrate the postural rhythm. Okay. Then after that, again another 15 minutes to demonstrate the C well. I mean C or O and whatever the about. After that, again we will show you the repositioning. Then what we do, you just go around. I will be there, sirs will be there to make sure that you all do the positional correctly, and that is it. Is that okay? And as long as it is there, even if it is 9 o'clock also, Madam will provide you. Okay. Okay, so no problem. Is that okay? Okay, so that is how we do it. So everybody is inside? Everybody is inside? Fine? Okay. So you can see from there, you can do, but what I would suggest is you can just come over once, I will explain the platform to you. So this is the posturography platform. Okay. just, if you can see from there, it's okay. Otherwise, we just come here and see the posturography. That's it. It is the same thing, but this is objective. This is objective. So instrumental posturography. Okay. So what this is the posturography platform. So what you see here is the central line which is showing the marking. Then there is a foot marking. And what you see here is the marking for S, M molecule. S stands for small, medium and large. This is to tell the people how far they have to keep the feet apart for different protocols. Small is for some protocols, for medium is for some protocols, and large is for some protocols. For most of the people will stand like this. Some people are more comfortable like this. Some people are more comfortable like this. Different people have different splays of legs at which they are comfortable, according to their comfort. But it will show you how many degrees. I will show you all the functionalities of all those things. So now we will demonstrate the protocol that we can do. You can go back and concentrate there. Okay. Okay. But there are other people who are really unstable, but in the upper body it doesn't show up. See here. Can you see this? So basically, upper body stability is not the true measure of instability or instability. Is that correct? It is the center of gravity projection that is actually called center of pressure projection, which is the true measure of the stability of a person. Is that okay? So this is what is projected here. Now what is this about? This is the place where this is. Where you see here, this is a grid. This grid is of the same, it is mapped to the platform that you saw. So if on the grid, if I go to a position which is 20 by 20 centimeter, I place a weight here, you see this also goes to 20 by 20. Can you see that?
Yes, sir.
Okay, it's like that. Okay, it is like that. So wherever I go, that goes to that particular point. I go there, it goes there exactly like that. So if I am standing on the center line, and if I just move right and left, you know it also moves on the center line. If I stand on the center line front and back, and if I just move right and left, okay, so front and back, okay, it goes only on that line, okay. So it is, that is the sensitivity, that is the precision of this particular platform that we have achieved. Okay. So wherever you can just map it and do. Now what is it that we are going to measure? The primary measures that we are going to get is just position of the center of gravity. That's all. The primary measure is position of the center of gravity. Okay. Now position of center of gravity we acquire over some amount of time. Okay. The second thing is if the feet is exactly aligned. And if you ask the person to close the eyes and stand, or does not know the screen and stand like this, if my feet, if I'm really having a good posture, this should be on the center line. If I go left, leg line goes down. Okay? Is that right? So you can make it like a distance. Okay. So this is the green line is for the front and back. Okay? If I go front, if I go back, if I go front, if I go back, green line goes front, up and down. Okay? So green line up and down means front and back. That is all. This is the primary measure. So the primary measure is the mobility or position of the center of gravity projection and the in the time series where exactly in that particular point of time the person was having the mistake. Now what are the protocols here? The protocols here are, there is a protocol called escalating sensory integration. There is also a protocol, this is also called as test of sensory integration of balance. Okay, escalating sensory integration. The first thing, what is written here? Surface is firm, eyes are open and feet neutral at S. Is that right? So this surface is firm, I am standing on the firm surface, my eyes are open and I am holding my feet neutral at S point. Okay. I am holding my feet neutral at S point. I am supposed to keep the hands crossed on top of it. Okay, and be there, and then I have to start the test. Okay. I have to start the test. Can somebody do this for me? So that is 32nd acquisition. The next acquisition is same firm surface, eyes closed, feet neutral at S. Same thing what we saw in the morning, now we are doing objective. I am closing the eyes. Next step. Next one is cushioned surface. You see that cushioned surface, eyes open. You can see I am weight bearing on the right more, then somebody is weight bearing on the left more, which Sujit sir was talking about that dominance. Okay. So if the person is not given access to the screen, you can actually know their dominance. Fine? Okay. And the last step is with eyes closed. This is the step at which you have to stand behind this person. However stable it looks like, you have to come and stand behind the person because the person can fall in this particular step. Okay. Shall we start? Who is going to take care of it?
Yes.
I don't know, somebody asked to be So you felt that I was more shaky, is that right?
Yes.
Okay. So now what is the measures that comes? There are multiple such protocols, but before we go through all the protocols, I'll just show you the measures that come out. So for measures, other measures, this is the report. Okay. So this is how the report is present. So what is their stable surface, eyes open, eyes closed? This is called escalating sensitive position flow. Okay. Stable surface, eyes open, eyes closed. See, stable surface, eyes open, stable surface, eyes closed, cushion surface, eyes open, cushion surface, eyes closed. So I'll explain this graph to you by just expanding one graph. So what is written here, what is shown here is where all my center. You saw that small ball moving, no? Yes. So where all that ball moved is now shown as a thread base, and then it ended with the red dot. Is that okay? The same thing is there for everything. You can expand and see whatever, all this. But for the easy comparison purpose, what is done here is everything is scaled. All the four are scaled to the same scaling, so that you can, when you see visually, you can know where the stability was more and where the stability was less. Is that okay? One more measure is if you draw a circular ellipse around this, all these points. What is the size of that ellipse will be one measure of instability or stability. So that is written here, ellipse area 26.25, 14.24. So you know, just by seeing the size of the ellipse, you can tell whether at that particular protocol how stable or unstable the person was. Is that okay? The next thing here is, there is one more line here. Can you make out this blue line here?
Yes, sir.
This blue line is a line which the computer on its own detecting which are the farthest 2 points and drawing a line from the farthest 2 points. Here it is moving horizontally, here it is moving front to back. Is that okay? So it also tells that in which protocol what kind of instability I was having. In this protocol I was having instability right left with some diagonal. Here it was front to back instability with a little diagonal line. Is that right? Okay, so that is one measure of it. Next thing here is, again I am resetting the graph. So here you are able to see the right and left undulations, that my movement. Okay, how unstable or stable I was. Here front and back how stable or unstable I was. Here again right and left and front and back how unstable I was. You can see here the front and back instability is more. Is that right? Yes. Okay, and right and left is there. And here again lateral and anteroposterior separately shown. Lateral sway velocity 1.5, anteroposterior sway velocity of 2.0 is separately written. For each of those things separately it is written so that you know the velocity correctly of each, so that you can compare. Why this is important? Person with a cerebellar issue will have right left instability more. Person with a Parkinson's deficit will have a front-back instability more. Okay, means dramatically more than the other instabilities. So like that. So this one, as we start going on doing research, like you said just now, Sujit sir started off with CWM, then went into OWM, now they have started their own message treatment. Like that, this access is there for you, so tomorrow it is for you to detect in what is going to come, like that. Okay, in which patient what you are going to find. But access of the data is here. Next thing here is sway velocity of the person. What is the sway velocity? Is you see this one, this thread. This thread has a certain length, correct?
Yes.
This sway path, if you can consider it as a rope or a thread, if that is stretched out and made into one length, and that is divided by the time. Okay, if that is divided by the time, that becomes a sway velocity. But only correction here we do is we correct for the height, and instead of giving centimeters, you know the platform is in centimeters, we give as angle of deviation. That is why the sway velocity is in degrees. Okay, the sway velocity will be in degrees. Is that okay? Sway velocity is degrees per second, it is written here. Okay, so all the 4 protocols, how much was the sway velocity? As far as how much are the normatives that I have collected so far based on that, this green zone is marked. You can clearly see there is a green zone, yellow zone and a red zone. Is that right? This is to give an indication to the person and to the reporting person that okay, according to normatives that we have collected, most of the people should fall under the green zone. Little bit margin for the yellow zone, but red definitely is a little bit cause for concern. Okay, so like that. Is that fine? So cushioned surface, eyes open. This came into red zone. You know why this came into red zone? Probably I just was speaking or got distracted. Otherwise, in the clinical setting, this should not. Okay. Then here we have the sensory functional scores. What are these functional scores? What is the percentage of it's a 0 to 100 scale. I don't want to call it as a percentage. 0 to 100 scale where the effectiveness of the vestibular utilization, when that is forced, or the effectiveness of the somatosensory utilization when only that is enforced, is shown here. If there is a vestibular deficit person, this goes to very low scores, 20, 10, 30, like that. So here I am getting 100% and 100%, which means I am normal. Okay. So this is a vestibular score, this is a somatosensory. Again today morning, today afternoon, coincidentally we covered this one. Is that right? Hello?
Yes.
Clear so far?
Yes.
Now this is not the only parameter. What is this maximum sway angle? Maximum sway angle is, here you got the maximum sway distance. There was no measure for this. This blue line, correct? Now we have got a measure for it in terms of angles according to the person's height. Okay? Because a taller person moves the center of gravity by 3 centimeters versus a shorter person moves by 3 centimeters. The meaning is different in terms of how much lean is there. Next thing is directional maximum spot point. In 8 directions, the algorithm searches for any jerk that the person had. Overall shape, overall where the center of gravity was, on which side the jerk. In the stable surface, eyes open, I got 1 degree jerk to the right side. In the stable surface, eyes closed, I had 2 jerks to the front. These are 2 places where if you are not talking, you will not get it. Because I am talking, this is coming. Why? As I was giving the depth. So here you saw that there are 3 jerks to the back. Okay. In fact, in this direction there are some extra jerks, so that got captured as two separate legs. You can expand and see that if you want. Okay. Next thing is, here you saw again a lot of. So I was actually weight bearing more towards the front or towards the toes, and once in a while I used to go back towards the heel and towards the side. So this is the meaning of this one. Okay, where my preferential most weight is and which side I am getting the jerks. So if there is a particular person with say vestibular neuritis on one side, right vestibular neuritis, this full thing will go to the right. Therefore, all these jerks will be to the left. Just like right vestibular neuritis patient will have left pitting nystagmus. No, like that these jerks here also will be to the left. So that will be a postural equivalent which you will be able to make out. Next beautiful thing here is you get access to the actual frequency component of the particular person's shape. This is a research tool. This is for your research purposes. What are the frequency components in different diseases? So the most stable people have the lowest frequency peaking. Instead of the lowest frequency, if you start seeing getting higher contribution for other frequencies, then the person is unlikely to be very stable. Okay, so this is how you can make out. Then the next thing is any normal person. I'll just expand this and show you. Okay. The peak frequency here you can see is just it's about 1.3%. Peak frequency is, can somebody read this? My vision is not right.
0.07.
Point, okay. That's all. Okay. So that's all it is here. Okay. So that is the peak frequency.
1.3.
Okay. Okay. Almost 0.7. Okay. So something like that. Okay. Or 1.07 something like that. That's all is the peak frequencies here. If a person has a Parkinson's or a multi-system atrophy, this kind of diseases, this top frequency, not the highest, I mean this is the most, this will be at the lower, but this one, the top frequency will move further to 3, 4, 5. That tremor that is there, postural tremor, that will start getting captured here. Okay, which you will come to know using this one. Okay, see these two things will tell you that frequency. That frequency component again is captured in the side to side and the front to back component. So the beauty of this one is that, okay, as a research tool you have this one, then you have this jerks measuring, then you have this functional scores, you have access to all these things. And the best part I will tell you of all this, in spite of so much of information, if you think, no, I am not happy, I want to do, my PhD student wants to do, this is about Sujit sir. His PhD students want to do new analysis which is not written here. Correct? And you don't even want to tell the manufacturer that I want to do this particular analysis. Then what do? Just right click. There is something called export. You can export the plot data entirely. It will come as an Excel sheet. All the coordinates will come as an Excel sheet. You can download the Excel sheet and then you can do the calculation. You can write your Python codes, you can do it in your MATLAB, whatever you can do the analysis that you want to do. This is about one protocol. Like that, there are other protocols. I will show, go back to the test and I will show you escalating motor complexity. Okay. Fine, shall we start? So far, everybody with me? Yes. No sleeping? So this is the posturography system. Okay. 20 little water bottle has come? Yes. Where is it? Once it comes, you get it. That's okay. So I will do the next protocol here. By the time they come. Okay. So again we will start. I think this is the first time in the country posturography is being covered as part of a conference. Correct, no? Only so many claps, only from organizer side it is coming. Now audit is balance happen. Okay. That is okay. Just so what I'm trying to show you here is, I'm just keeping this water bottle here. Okay. So you can see that's enough. So what I want to show you here is, can you see the undulations here? This is the water shaking. Here little bit of water shake. Can you see that? Only my finger. I'm just with my finger shaking this. Can you see that shakiness? This small water column with one finger, how much you shake, that small waves also is being captured. That is the sensitivity of the platform. Gone are the days of the West making the best equipment. With passion I am making this equipment. India makes the best I have chosen aircraft grade sensors. What the alloy that I am using is called magnesium alloy, which goes into aircrafts. The sensors are aircraft sensors. The best quality filters, everything. That is the kind of equipment that we are making. Okay, it is no longer there. Buggers called Synapsis, one company is there. They are calling posturography wood. I went to Bangladesh, I saw it is made out of wood. One sensor goes, it has to be sent to Singapore for recalibration. Sending calibration for the Singapore transportation cost, you will buy a new one in India. Okay. So that is the kind of sensors that we have made. This is the kind of analysis we have built. Okay. I will show you one after the other everything. So you saw the build quality, everything. Nobody makes this build quality across the globe. Take my word. Okay. No, that's not it. The next one is I stand on feet tandem. Okay. So you can make out whether a person is a back foot weight bearer, front foot weight bearer, all these things, Okay, just by making them stand firm. See, a normal person will be able to stand here like this, okay? With a little bit of shakiness. I am talking too much, so I am a little shaky. Then question is asked, no fall noticed, okay? Next thing is standing on the right foot, okay? Can you see that if that is shaking, you know with the example of the water bottle that it is a real shake, okay? I am not this shaky usually. This is sleep deprivation. I have not been sleeping for the last 4 or 5 days continuously. Otherwise I don't shake this. I will fake something just for the sake of this thing, okay? I will fake something. I kept my foot down as if I am not able to balance, okay? So that I can show you something. Fine? Actually it should be yes, okay? Because it was, if I kept the foot down, then it was like a fall. That's okay. So, again, simple protocol. We just finished, made them stand on different protocols, okay? So same thing, same score, all this you understand, you remember everything, correct, right? So we can go fast. So now you see, I kept my foot down 3 times. 1, 2, 3. Is that right? Yes. So nicely captured. The second thing is, you can actually tell the patient when they kept the foot down. See here. You can tell that exactly 22 seconds you kept, 24, 25. If this happens here, you can tell what, man, only for 5 seconds also you could not stand on one leg. You need to do exercise. Yes, sir. I will tell you, patient will be so surprised. How do you know in the next room that yes was done? How do you know that 5 seconds afterwards I kept, like that they will ask the question. Okay, because the graph is here. Okay, so same thing here, everything is same. Again, same directional maximum plot is the same, everything. Okay, tandem stance, I was really shaky today. I am not usually this shaky. Okay, standing on right foot, I was shaky. Here you can see, I got pulled in this direction, that is captured here. It was instantaneous, momentary, but it is captured, it is not missed. Okay, so that is the extent to which I just gave it so that we can demonstrate the capability of the system. And again, you see the sway velocity. I told you I was not, I'm usually not this shaky, right foot, left foot though, I made it fake. So it was more shaky. So standing on the left foot, the maximum sway angle is more. And what you see here is what is called as a left and right stability symmetry. Okay, so on the left foot, it is going towards the left, minus 11. This again from minus 100 to plus 100. So minus 11, that means on my left foot I was relatively more unstable than on my right foot. And then tandem score is in the yellow zone. Okay, I told you in the beginning only, I am not that bad tandem everything. Usually, otherwise you should get the tandem score in the above 80, in the green zone. Okay, so this is the tandem score. This has two levels of abnormality in the tandem score. Within this red zone, like above 40, you get it less than 70, but above 40, you get it muscle weaknesses. Or what are the problems that happen with musculoskeletal abnormalities? If you get less than 30, they are mostly associated with problems with the brain, like movement disorders, these kind of things. And that is how it is. Again, for every protocol as a research modality, I made this available. Okay, I made this one available. Is that okay? So that you can actually capture the frequency and study it. If you ask me what is the role here presently other than movement disorder, for movement disorder definitely this will go up. That much I know. For other things, I want all the professionals to come up with new things that this can show up. Okay. Probably when Bera was first given, I don't know how much we studied, but now the same Bera became web, and again, so many things came up. So this is just to give that tool to people so that you can actually start doing more and more. So that is the first next thing. Then there is another test. From now onwards, I go fast. There is a test called weight-bearing squats. Okay. So this weight-bearing squats, you will just make the person do the squats. Is that okay? So here again, one difference that you see is feet at L. Feet at L means the feet is at a distance. Is that okay? So I will do that. So you saw the lines there in the beginning. Feet at L means the lines have to be at the, and when the person is in a comfortable stance, you take it to the center and make the person stand. Is that okay? The next one is, you ask the person to squat by 30 degrees. Is that okay? Sir, start. When a person actually squats, the center of gravity should not move front or back. The center of gravity should be in the same position. This eyes open, okay? The last one is 90 degrees. Now I will show you what this analysis shows, okay? Because everything is record, but then what analysis it shows is important. So what you are seeing is, in the center of gravity, did it move lateral displacements? 30 degrees, 60 degrees or 90 degrees to the side, did it move? If it moved too much to one side, that person has a problem in that side. Okay? Which means there is some amount of weakness which is like pulling them, or pain in the knees or something like that is pulling them to that particular side. This anteroposterior displacement again, okay? So this is back, this is front. Okay. This is same position plot. The ellipse area will tell how unstable I was as I went to the more difficult protocols. This is again a time series plot. Here also you get an idea as to my extent of instability. Can you see that? Can you see this tremor that shows up, the muscle tremor? Which may not have been noticeable if you are seeing me. Is that right? Maybe you cannot pick up this tremor if you just see me. You may be thinking I was doing a squat well. But you see this amount of tremor that is there. Okay? Next thing is, here again, this is the directional maximum if I had any instability any one direction. Same thing. Here you see this one, the progression. This is the smallest. Next one is little more sway velocity, more sway velocity, more sway velocity, but the progression is not very rapid. If the person has a muscle weakness, it will go more and more. Is that okay? So that is the way in which this can show up. This also same thing. Okay, that kind of a pattern can be demonstrated. Here you can see the. So this is the sway pattern. Okay, I will show you. What is the? Can you see the velocity? Is this thing here? Can somebody read that?
0.6.
No, it's not
3.41.
That is the 3.41 is the, see, as the muscle, this thing, the strength became, the requirements became more, So you started seeing a tremor of 3 Hz tremor which started showing up. Okay? That is the beauty of this one. So here also, okay? So that tremor, that is not there in the anthroposcope. So that is how that is picked up. Is that okay? Sorry. So in the Parkinsonian tremor, it will not be picked up, it will definitely be picked up. Is that right? Next thing is limit of stability test. Okay? In limit of stability test, I will just do, for the paucity of time, what I will do is I will show you 1 or 2 directions. Is that okay? Or if you want, all the directions. Or how do you want it? But we will finish the full agenda. So what you do here is very simple. The person stands standard according to the standard what is there. The person is supposed to place the stand in such a way that in their comfortable stance, the center of gravity comes in the center. Okay? Then I start. After 2 seconds, I get a go, and then I go in the direction of the arrow. I move my weight in the direction of the arrow. Is that clear? My friends? Okay. Next one is, I'll do this fully so that you can see the graph next. You saw this? I have to go as much as possible in the direction of the arrow. This is my limit of stability. If I fall, you have to repeat the test. Okay, if I become unstable. Is that okay?
Is there much maximum at where you can go in the air?
Yes, how much without falling, the maximum that they can go. After 2 seconds, you give the go ahead. Without falling, how much they can go is what we are saying. Then you go back. Okay? How much is possible? This is the test called limit of stability. See, if you are reading all this in the book, it's very difficult to remember. But once in life you have seen, you know. Correct, right? I don't know if there are any undergraduate students today. There is no UG, right? Yeah. Because once they see this, if this comes as an exam question or anything, it becomes super simple to answer because they have seen this. Okay? As much as possible. Okay? And then I come to the extent to which it is possible. See, the beauty of these tests is there are some things which the patient would not even have bothered as important. But the test suddenly starts showing some results. And then you start asking, why are you not going that much to the right as much as you are going to the left? Then person will suddenly start telling, I have a hip pain, I have a spine problem. These things are all will come out. When we are collecting normatives, we just collected one particular patient. We had too much left leg asymmetry. We asked, why are you so asymmetrical? Why is your left leg so bad? Then suddenly, after that, she went for a spine this thing, then MRI was done, there was a spine problem detected. To that extent, this will become good. Okay. So this is the limit of stability, the 8 directions that we saw. Can you see this? All this is in angles. The same thing is in position plot. This was an actual trace. That was the measurement. This was the actual trace. Okay? Next thing is the actual time series, like how you went, whether you could maintain, whether you came back, all these things will be known with this. You reach it there, but after reaching there, can you just come back or could you sustain? This truth is told by this one. This kind of a graph. Okay? And this is all the wave frequencies. Okay? In everything. This, what will come out of it is, I don't know, I just given that answer. Next beautiful thing is limit of, after limit of stability, there is something called rhythmic weight. I will show you this one. Okay? So in the rhythmic weight shift, the feet is kept at M. You can see here, feet at M. Okay? So now what I'm supposed to do is I'm supposed to follow this law. Okay. Can you see this? With my weight, I am following it. I think some antivirus is running, so the time is become slow. This becomes, if the person can really do this well at slow things, person is really stable. I will do this test and after that I will close this. There are other tests are there, but then it's okay. Because you got an idea. I think you got an idea of what is posturography, I'll tell you.
Yes.
That's it. There's an, I think there's some antivirus or something running in the background. No. This thing is, charger is not on. Laptop charger is not. That one. That is why it is. The timing was not good. So that we could lose some. No. This has come off. I was wondering why the timing is going slow. Super. No problem. So that is one interesting. It's okay. I just show you. So wondering why this is happening. So this is the thing. So I just show you this one. I think you got an idea. Otherwise 30 seconds everything will become. If you have not done a protocol, it just comes as dot. Okay. This is the on-axis percentage. This is called on-axis percentage. How much of my movement was actually on the axis that I was supposed to be, horizontally. If I made front back instability when I was asked to do anterior, when I was asked to do side to side shifts, then this will go low. That means the person is unstable and likely to fall. Is that okay? So then there is another test called for anteroposterior, same thing. This will move front and back. Is that okay? And then there is another test called tandem and stepping. Okay, this again how to move into tandem position to move into stepping onto the platform. So tandem standing is normal stance for 2 seconds and then move to tandem stance. Again normal stance for 2 seconds, then move to tandem stance, left foot forward. So you take the first foot forward, the other foot forward. Then there is a step onto the platform. Okay, means from sit below and then step onto the platform. Sit below, then visual reference. Here there is a doom that will come which I have not carried. So feet neutral at a cushioned surface, eyes open. Feet neutral at a cushioned surface, eyes closed. Then we give them wearing a doom to remove the to sway reference the eye. So what is the meaning of sway referencing is? If you place a helmet around the person cannot see the world. They are only looking at something that is fixed to their head. When they sway forward, that also moves with them, giving a false impression that they are stable and they become more unstable. Okay, that is sway referencing. Okay, sway referencing. The last one is cushioned surface, eyes open, optokinetic. You get optokinetics means you put a light in the room with the disco light, and then the disco light keeps going and see whether the person is shaking or not. These are the different protocols that we can do with the posturography system. Okay? Then this is about only the posturography as a diagnostic tool. Can it only be a diagnostic tool? Can it be? There are multiple games, but I just show you only one game. So what you do here is, so this becomes a tool for just by weight shift. Okay? Can you see this? I play a game. In the beginning, we give them a game to collect all these diamonds and all that and avoid the. If I hit it, I lose one heart. Okay? If I get cut by this one more heart gone. Okay? It is like that. Can somebody press 4 on the keyboard? This is both sides. I cannot fall on any side. Even if I make a mistake, I cannot fall on that side. But this protocol is where if a person has a left vestibular neuritis, he will simply keep going to the left and he will keep falling. Is that okay? So you have to stop him from falling on the left. So what you do is, you give him. Okay. So each and every time the person is falling, now he knows he has to make corrections. Then what will happen? He will not move that much to the left, and therefore, oh my God. Okay. So now he is not going to fall. Then you give practice. Then he will not go to the left. Okay. And then he will start moving to the right. Is that okay? And see whether if he can really not go that far and then he can play, then it will be great. Okay. So if the person can be taught to go all the way up to here and without going all the way back, if he can play this game. Okay. You saw that? I will lose one more heart and tell you what will happen. Okay. What? See what happens to this game. Okay. So like that you can play. Then you can just press H on the keyboard. So now what you see here is, in the beginning I used to make a lot of movement. Now it is more about the stability. Even if I move little, the character moves too much. Am I even moving? Can you make out whether I am moving? If you look at me, you cannot make out. So with that small, fine postural control, I have to play this game. Okay? So now if I can really master this sticking to the line with small postural control, so there are gross postural controls and there are these fine postural controls which we need to practice. Is that okay? So if you practice this, if the person reaches this stage, then as the Yugandhar sir was telling in the morning, you can take a person, vestibular deficit person, and take him to the dance level. Correct? No? What you can promise, you can promise. Oh, like that. Okay? Okay, this is it. Then there is press 6 on the keyboard. This is free to fall. Fine control. Now both sides I will fall. If I can really play without losing all the hearts for 15 minutes on this, I don't have a balance issue. Okay, I am hardly making any movement. Can you see this? I am hardly making any movement. This is really fine control. Okay? It's like that. Is that okay? But all these protocols are protocols where the person is just standing there, moving around to improve the balance. All this. There are multiple such things. There are so many games. I'll just show you just example games. Okay. So this is about movement in one place and all that. Okay, is that enough? It's not enough. So one more game I will just show you. So this is a minor game. Okay, this is a beginner level. So I need to go and collect the gold. Now you move all around the platform. Okay? You got it? So you saw this, I am moving all around the platform. Okay? So this encourages the person to move. Okay? The previous one was feet were planted in one place. This is one where actually I move this thing. Okay? Okay, press 3 sir on the keyboard. When 3 is pressed, this is the advanced level. What will happen here is, that time only gold was there. Now the mines are there. Is that okay? If I go to the mine, I lose points. Okay? If I hit a bomb, I lose points. Okay? So without going to that mine, okay, I have to collect the gold and come back. Is that fine? So these kind of things, games are there. So if you make this play, and the other beauty of this one is, this particular rehabilitation protocol is not only for people who can stand. If there is a stroke patient, post-stroke patient, he is not even able to do. He just comes on the wheelchair. Even if the person comes on the wheelchair also, he can play this game. I need a chair. Can somebody? So even if I'm sitting on the wheelchair also, I can play this. Okay? With just weight. Okay? With just wheelchair also I can go around. Is that okay? That is the beauty of this. Okay? That's all. So I think with this we got a good overview of osteography. Now we will move on to WEMS by Sujit sir. Okay sir? After that we will go for positional keys. Tomorrow Swaroop is going to talk in detail about this. Today I thought we will just take this over the time.
Sir, which all patients are suitable for this exam? Will be covered tomorrow or?
Swaroop is going to cover tomorrow, but basically there are two categories of patients in the balance clinic. One patient is who has a predominant complaint of difficulty in walking. Okay, they tell what is your problem, the patient tells I am afraid of walking, I think I fall, this kind of thing. They also can be improved. And acute vestibular neuritis, acute labyrinthitis, these patients who are really imbalanced, they are again people who can be done. I also do this for people with ophthalmic dysfunction.
So after medical treatment they come to?
No, they come even before. For our vestibular neuritis patients, the day the vestibular neuritis is diagnosed, immediate day I will start this. On that day only I will start. So that 3 days they are back in work. If you start with third day, fourth day. Third day, then are you coming? No sir, I am busy in my shop. Usually these are people who will take.
Always remember, don't just clean the site of the electrode basically just like that. You have to turn the head, locate the muscle, and then you clean it. It is easy for you. Just bear with me for 2 minutes because I am not aware of this equipment. So just searching something there. So this is your right electrode, the positive electrode. It will not record. You have to connect the fourth electrode in this particular equipment, other equipment is not required. These are in case of the opposite. Okay. So this is your positive electrode, this is your negative electrode, and this is your ground electrode. Usual. Okay. And this is single channel. And then always remember, there are interfering things, electrical interference, one will come from here. If these two are together, your electrical interference will come, so this wire will keep it separate. And second source of electrical interference is here. These wire carry the electrical or acoustical? How the wire will carry acoustical signal?
Electrical signal. Acoustic is air.
Acoustic comes from here. This is electrical. These two, if they touch each other, there will be electrical interference. No problem. Okay. So now the patient is ready. Physically. So now we can start the recording. So you can see the protocol here. 90 dB NHL I have put 500 Hz and 10 Hz high pass filter. Low pass filter is 1.5 kilo that you can keep it at 1000 Hz also, and here is right. So we can start the recording. It will ask that 80 dB NHL it is exceeding. I told you that you have to always look for UCL because patient will have recruitment. So it will ask every time you are recording greater than 80 dB NHL. So say yes. I know interacoustic equipment. I'm searching whatever where what is